but why the image was appearing like that on the virtual background?
सर आपको एक नया M1 Max वाला MacBook लेना पड़ेगा.
ठीक है, तो IAPS will give that to me as a parting gift.
Good morning, Dr. Ramadwar.
Good morning, Dr. Mahajan. How are you? Good to see you. It's a long time we have met.
Yeah, long time.
Hope everything is okay at home front and at PGI.
Yeah, all well, all well.
Sir, 9 बज गए. Shall we start the proceedings?
Yeah, please.
I'll just say a few lines about the event. So welcome everyone. I welcome all of you to this 47th annual conference of Indian Association of Pediatric Surgeons. So this is our second virtual conference, and we hope to repeat our success of last year's virtual conference this year again. And this pandemic has provided this opportunity of holding this event virtually and include a larger number of delegates and participants in India and across the world. So in a normal conference where the usual attendance is around 300 to 400 people, here we have the attendance of close to 1,000 people, and there are a lot of people who would watch the event after the conference is over. So we have already completed our extended program days for the last 4 days. We had the CME on Sunday 17th, and then we had the poster presentations which were ongoing for the last 4 days. Yesterday we finished the poster presentations. So from today onwards, we are starting our main conference days, which will hold the main sessions, orations, and the general body meeting and the other events, which are to be done as a protocol. So please be ready for a gala academic feast during this annual E-Iapscon, and I hope everybody will enjoy. I will hand over the mic to Dr. Ramadwar, President IAPS, to deliver a welcome note and declare the conference open. Sir, over to you.
Yeah, good morning, everybody, and very warm welcome to the 47th Annual National Conference of Indian Association of Pediatric Surgeons. It is a very proud privilege for me to preside over this conference, and I can see that there is a serious enthusiasm amongst all members of IAPS. Looking at the way the pre-conference sessions went, the CME was absolutely successful. The amount of poster presentations and discussions that happened over the last 3 days, the enthusiasm in the seniors lounge reflected that the IAPS is a very thriving and a healthy body, and we all need to work towards it to keep it healthy and very active. So I welcome you all and enjoy the deliberations, and it's a very exciting program which has been set up by our brilliant executive committee led by Ravi Kanoja and Amar Shah. So over to you, Ravi.
Thank you, sir. Thank you so much. We have Amar, our joint secretary. He has been working very hard with us to organize this conference. Amar, would you like to welcome the delegates?
Hi, good morning, everybody, and wish you a very warm welcome to this E-Iapscon 2021. As Ravi said, this present executive committee has been very fortunate to organize 2 back-to-back E-Iapscons, which is one of the first time which has happened in the history of IAPS. We are also very happy and enthusiastic to host an equally successful show as we did last year, and we hope all the delegates and the postgraduate students also enjoy presenting their work and enjoy the scientific deliberations. Thank you and welcome everybody.
Thank you, Amar. I'll just take a few minutes to summarize what is going to happen today. So today we are going to start with our first session of Swapna Datta Award session, which is session number 1. This will be followed by the MSR oration, which will be delivered by Dr. Mohan Abraham. And then we are going to have the conference inauguration. The inauguration ceremony will be presided by our chief guest, Dr. Bhagwat Rao Karad, and guest of honor, Dr. Snehata Deshmukh. Then after the lunch session, we will have the free paper sessions on urology and neonatal surgery. So after the lunch session, we will have 2 parallel halls running at the same time as Hall A and Hall B. So all the delegates can enter either of the 2 halls through the conference lobby once they log into the conference website. I would request all the members to keep themselves updated about any kind of information they are looking for on our conference website of iapscon2021.com. So everything that is changed or updated is instantly posted on the website for the information of all the members. I would now request Professor Mahajan to take over for the next session. We are due to start at 9:15, and we will be strictly keeping the time because we have to start the inauguration session on time, as a cabinet minister is joining us, and there will be a minute-to-minute following of the steps of the program. So the two sessions before that, the Swapna Datta session and the oration, will be as per the time schedule. Mahajan sir, over to you. Professor Mahajan is a professor of pediatric surgery at PGI Chandigarh. He will be chairing this session along with the other two judges for Swapna Datta award session. He's a very avid pediatric urologist and has done several research work and a lot of clinical work in the area of pediatric urology. And Mahajan sir, over to you. I would request you to kindly introduce the other two judges and then take a roll call of the participants. Over to you, sir.
Thank you, Ravi, for your kind introduction. I welcome all the delegates to Swapna Datta Urology session. It's my privilege to introduce, though they don't need any introduction, my fellow judges, Professor Y.K. Sareen from New Delhi and Professor Satish Agarwal from New Delhi. Welcome both the judges. And now we will just Sugandh Chadda is there. I can see Sugandh Chadda, Nihar Patil. So somebody may please make call to these participants. Nihar Patil.
I will do that, sir. I will do that.
So Dr. Archika Gupta is also not logged in. Then Ganana Chaitanya, Anju Verma. I can't see Anju Verma also, and Ram Mohan. So I think can somebody make a call to these fellows to join, please?
Sir, I will call them.
Okay, so should we start or wait for them to join?
Start time is 9:15. We'll start at 9:15. It is 9:08 at the moment.
Okay.
So maybe they are still joining.
Hello Mahajan ji, क्या हाल है? Am I audible?
Morning.
Very good morning. Morning Ravi. Ravi.
Morning, Satish. How are you?
Hello Ravi. I'm very well, thank you. So how are you?
All good, all good. Thanks.
Fantastic, fantastic. A very nice morning here in Delhi as well.
So good. I hope that there isn't much of a smog around.
No. For a change, it's doing good.
Excellent.
Dr. Archika Gupta is already logged in from the delegate link. Can somebody promote her to the presenter or the panelist link, please?
Yogesh, good morning. I can't see you.
Good morning. In this particular laptop, my video is not working.
Oh dear.
Yeah, I'll use the other laptop for the other sessions. Yes.
Hi Yogesh, I can hear your voice. How are you doing?
Satish, how are you?
Yeah, Dr. Sareen, good morning.
Incidentally, I've worked with both of them, Jay also, while I was in CMC Ludhiana, and of course Satish and Namsi.
Sir, first speaker is with us. Sugandh Datta is online.
देखो.
And I think we still have 6 minutes to start.
अभी है time, Archika, don't worry.
Yeah. Shilpa, good morning.
Has Archika joined? Amar?
Yes, Ravi.
I don't see her name.
Archika is on the phone with me. She said that she's already logged in from the delegate link. She needs to be promoted to the presenter link.
So she may have joined on a website. We don't see her in attendees here.
So what should be done? Can somebody contact her, please?
Sure, sir.
Yeah. Archika, somebody is going to contact you.
So how many presenters we have who have joined? Just one?
So out of 6,
We
the
have-
first one.
Only Sugandh I can see.
So the second presenter, Nihar Patil, he's having some hardware problem with his laptop. He's sorting it out.
Oh dear.
We'll see. So it is not necessary to follow the sequence which is written in the program. If somebody is not there, we can allow him to present at the end
And
to
okay.
make it within the time.
So our first presenter actually has a long inning to play till everybody else joins.
All coordinator, please start the timer whenever the presenter starts presenting, okay? It's an 8-minute presentation.
Sure, sir.
8 plus 2.
Hello, Dr. Mahajan.
Yes, sir.
So when it comes to marking, is
Yeah.
it that we have to keep on marking as the paper is presented, or we can kind of compare rough notes we can take and then compare all the papers and then do the marking after the completion of the session, or how do you want us to go?
I think Ravi will be better person to clarify this. Do we need to mark individually, or we can discuss and then mark?
Sir, it is better. I have provided the Google form sheet. You can mark as per your convenience. You can mark as the presenter completes, or you can mark at the end of the session.
Right, yeah.
And in the end, I will come and discuss with Dr. Mahajan with all the marks that are given by the other 2 judges. And then he can summarize and then choose the winner.
Yeah.
So is that okay, sir?
Yeah, that's a very good clarification. Yes, that helps. Thank you.
As per your convenience, if you have
Sure.
2 devices, on one you can listen, and on phone you can keep giving the numbers. Then in the end, Dr. Mahajan can summarize.
Yeah, that's what I'm doing. I'm keeping the mobile on, so I'll keep on marking. But just because we are having several papers, and once you have heard all the papers, then it becomes easier to kind of compare because there's an award session. But that's fine. That's a good clarification. Thank you.
Dr. Archika has joined.
Great. So who is missing now?
All Nihar Patil, Ganana Chaitanya, Anju Verma, Ram Mohan. None of them are there.
Good morning, Partha sir.
Good morning. All the best.
Thank you, sir.
Good morning, Partha sir.
Good morning, Mr.
Welcome.
President.
So Majid sir, I think it is time. You can start.
So what do we do after the second presenter? Others will join or what?
The first three have joined, except Nihar. We will just keep going on whosoever is present. Okay, so you can start with Sugan Chadda. She's
Good morning, sir. Can I share my screen, sir?
Yes, please. So good morning, ladies and gentlemen. We start with Swapna Datta's session. I request all the participants to keep to the time and leave enough time for discussion. So here we have first presenter, Sugan Chadda. So start presenting, please.
Good morning, everyone. I'm here to present my pilot study on safety and efficacy of Mirabegron in children with early wall bladder. The study was done at Sri Ramachandra Institute, Chennai. I have nothing to disclose. Mirabegron is a selective beta-3 adrenergic agonist and has been approved for treatment in overactive bladders in adults. Some papers have reported the use in children with overactive bladders and neurogenic bladder due to spina bifida or spinal disc graphism, but there has been no study yet in children with valve bladders. Valve bladder is an important cause of persistent hydronephrosis after a successful fulguration of posterior urethral valve, and if not dealt with aggressively, it can lead to early kidney failure. Anticholinergics and alpha blockers have been the mainstay of pharmacotherapy in such children. However, due to the detrimental adverse effects, the compliance is poor in kids. The aim of this pilot study is to assess the efficacy of Mirabegron in early valve bladders. The study group was recruited after getting an ethics approval and after obtaining an informed written consent from the parents of the children. Our inclusion criteria was children with no residual PUV, persistent hydronephrosis, daytime wetting and frequency, and urodynamic evidence of detrusor overactivity. We excluded any child who had an unsuccessful fulguration on MCUG or an active UTI. We had 25 such patients in our study, and a pre and post Mirabegron outcome over a period of 3 months was noted for all children. They were started on 0.5 milligram per kg per day dose. The tablets were reconstituted at the pharmacy according to the child's weight. 3 subjective and 4 objective parameters were analyzed, and children were monitored weekly to note for any changes in the heart rate, blood pressure, or ECG rhythm. The subjective parameters included frequency of urination or wetting episodes. That was noted by making the child maintain a voiding diary. The patient perception bladder condition score was also looked at. That is a questionnaire in which it had 6 points, one being the bladder condition causing no problem to the child, 6 being the bladder condition causing severe problems to the child. The objective parameters included a uroflow index, which is a marker of high pressure voiding, and a normal uroflow graph will usually be a bell-shaped curve, whereas a uroflow graph in a child with valve bladder will be a towering graph. The second parameter was voided volume ratio. That is an indicator of frequency and urgency in children. The third parameter was a maximum filling pressure that was noted by doing a urodynamic study and looking at the detrusor pressures. The fourth parameter was the Society of Fetal Urology hydronephrosis grading that was monitored using an ultrasound. This is the SFU grading that is usually used by getting an ultrasound done. It was done pre and post Mirabegron treatment, and usually children with valve bladder have a grade of 2 to 3. Coming to the results, we had 3 dropouts in our study. Only 22 children completed the study. The median age of the study group was 6.5 years. None of the children had any side effects or any changes in heart rate, blood pressure, or rhythm. This is the results showing the subjective result of subjective parameters. As you can see, there was a drastic reduction in the frequency and wetting episodes with some modest improvement in the patient perception bladder condition score. There was also an improvement in the uroflow index. The first curve being the pre-treatment uroflow curve, showing a towering kind of a curve. The second one is the normal bell-shaped curve that we obtained after completing the study. The voided volume ratio also showed some improvement. The child was able to void larger volumes. The improvement was from 50 to 70%. After performing an UDA study, also we noted that the detrusor pressures had reduced and patient had better detrusor stability. The SFU grading also showed an improvement in the hydronephrosis status. This is a consolidation of our results. As you can see, there is a significant improvement in the frequency and wetting episodes, along with the reduction in the detrusor pressures. There is a modest improvement in the patient perception bladder condition score, voided volume ratios, and hydronephrosis grading. Coming to the discussion, anticholinergics like oxybutynin and tolterodine alleviates the bladder overactivity and have been conventionally used, but they have side effects such as dry mouth, constipation, hyperpyrexia, cognitive disturbances, and myogenic failures. Hence, it is not very compliant in children population. Mirabegron, on other hand, improved the frequency and wetting episodes, and it also improved the patient perception bladder score and uroflow parameters. The voiding volume was improved. Detrusor pressures were reduced on UDA study, and it was devoid of the side effects that we see with the anticholinergics. After completing our study, we would like to propose a treatment algorithm for children with valve bladders. Children after PUV fulguration who have a persistent hydrourethral nephrosis and wetting should be evaluated to rule out a valve bladder. A VCUG should be done to exclude any persistent valve, and a UDA study to assess the bladder function. In case the child has large post-void residual urine, they should rule out a bladder neck hypertrophy and start the child on alpha blockers. In case they have a poor voiding pressure, underactive detrusor should be looked at, and they should be started on clean intermittent catheterization and nighttime drainage. Whereas children who have an overactive detrusor, they should be either started on anticholinergics or beta agonists like Mirabegron. The limitations of our study was, since it was a pilot study, we had a small sample size, and we only followed the children over a period of 3 months. We have still not stopped the drug, so we have no idea regarding the relapse after the drug withdrawal. The long-term effects of the study have not been looked at, and we still have to look at the improvement in GFR and renal function. I would like to conclude by saying that this study supports the use of Mirabegron as a safe and effective option in children with early valve bladder. In future, we would like to focus on the long-term effects of Mirabegron, along with the role of combination therapy of Mirabegron and solifenacin. These were my references. Thank you.
Thank you, Dr. Sugandh, for your presentation. I think you were well within time. So just one question, that what was the age of these patients at the time of fulguration?
The age of the children, we had an age group of newborn to 1 year of age, sir. We had fulgurated these children between 2016 to 2020. And on follow-up, we had noticed these effects in the children on routine follow-up when they came to our OPD. So we decided to start the treatment with Mirabegron in such children.
So interval between fulguration and start of treatment.
Yes, sir. Our study group included children between the age group of 4 to 10 years.
Okay. So over to other judges, Professor Satish.
Okay, so a good presentation, Sugandh, and you've shown that this is a very promising drug, isn't it? Now, my question is, how did you conclude that the valves have been adequately ablated or completely ablated? Was it?
We had done a MCUG, sir. In MCUG, we saw that the posterior urethra, there was no constriction and there was free flow of the urinary stream. And along with that, we had also taken the history regarding the stream of the child, if the child had any straining. So along with an ultrasound that showed that the blood.
Have you done a check cystoscopy to conclusively prove that there is no hookable leaflet there?
Usually, sir, after the usually in our treatment protocol, we usually do the check cystoscopy after the fulguration, 6 to 9 months post that.
Okay.
So these were the children who had presented late to us in our OPD as with the symptoms of wetting and frequency and
so the study population was actually 4 to 10 years, as you clarified, and therefore all these children were good candidates to undergo the objective assessment by urodynamics, uroflow, and etc. etc. So that's good. Now, when you say that oxybutynin and tolterodine is limiting factor is side effects.
Yes,
so what are the reported side effects of Mirabegron in the literature, and what is the safety of Mirabegron in children?
Mirabegron has still not been approved for usage in children, sir, because it is noted to have arrhythmias and some ECG changes like QTC prolongation. So we still have no idea if it was there in like in long term, if it will cause any side effects. We still want to look at it because we have only done the study for a period of 3 months, and all the children are still on Mirabegron, but they have not noted any side effects yet.
Right. Thank you.
Professor Serene.
We started doing something similar in Maulana just before I got transferred. So it's a kind of off-label use of this drug. My only observation is that probably 3 months is too early to know the effects. I mean, majority of these drugs, when we study the effects, we will do at least at 6 months of age. So I think 3 months a little too early, but if you got good results even after 3 months, very welcome. Thank you so much.
Thank you.
Good presentation.
So FDA approval for this drug has come just this year only. So your study period was before that or after that? This year, early this year only, this drug has been approved by FDA for use in children. Earlier on, it was being used in adults.
Yes, sir.
So your study period was before that or after that?
Before that, sir, we had obtained an ethics committee approval, and we also had an informed written consent from the parents. After that only we had started the study, sir.
So you have taken ethical clearance. That
Yes,
was
sir.
one of the questions from audience
Yes,
also. There is another question from audience. How would you compare Mirabegron with imipramine?
We have still not compared, sir, because these children were never put on any other drug. We had directly started the children on Mirabegron because we wanted to look at the efficacy and safety. We will in future do studies to compare it with other drugs and look at the combination therapies.
Okay.
Can I come back, Dr. Mahajan?
Yes, please.
When you say that you have not started on other drugs, but your study population is 4 to 10 years, and I'm
Yes,
sure
sir.
during the course of the treatment, they must have been subjected to some form of medication. So did you go back into the history and their charts as to whether they experienced any side effects of usual anticholinergics?
No, sir. Our study population, they had presented late with these symptoms. Initially, they never came with any other symptoms, sir.
Okay.
So sorry to interrupt. Yeah, discussion time is over.
Yeah, thank you. Thank you, Dr. Sagan. So you can unshare, you have already unshared your screen. We will go on to next presenter. Dr. Nihar Patil is not here. So I will invite Dr. Archika Gupta to start her presentation. Please share your screen, Dr. Archika.
Okay, sir. Am I visible, sir?
Not yet.
Sir, I have shared my screen, sir.
But your slides are not yet visible.
Sir, even presentation is not visible, sir?
No, no.
Ma'am, we can see you. Your video is on, but your slides are not visible.
Yes,
I have shared my slides, sir.
Yeah, now your slides are visible. Please go on to slideshow mode.
Yes, sir. Yes, sir.
Then start presenting.
Now, am I visible, my slideshow, sir?
Yes, yes.
Hello?
Yes, slideshow is still on.
Hello? Hello?
Hello, Archika. We can hear you. Hello, Archika.
Hello?
And we can see your slides. You can start.
Okay.
Please put them again in the slideshow mode. They are in.
Okay, okay. So now can I start?
Yes, please.
Yeah.
Good morning, Chairperson and all. I am presenting paper title Use of Limited Scrotoperineal Approach with Novel Skin Management for Bladder Closure with Hypospadias Repair and External Sphincter Approximation without bladder neck repair. In classic bladder exstrophy with a small to moderate bladder plate, stage repair is being practiced. It includes either bladder closure followed by Hypospadias repair in second stage or bladder closure and Hypospadias repair in one stage. In both the approaches, increase in bladder capacity is contributed by bladder closure itself and further by Hypospadias repair by providing safe resistance. We propose that if we combine external sphincter reconstruction with bladder closure and Hypospadias repair without bladder neck repair, it can further add to resistance safely and helps in increase in bladder capacity with preserved upper tracts. We have published a paper on a novel midline scrotoperineal approach facilitating innervation preserving sphincteroplasty and radical corporal attachment for reconstruction of exstrophy Hypospadias, and another paper on a novel skin management scheme in surgery of Hypospadias undergoing Cantwell-Ransley repair, a technique to improve the aesthetics and minimize complications. So the question is that, can we assess external sphincter using limited scrotoperineal approach, avoiding transverse perineal incision, and combine it with novel skin management and do external sphincter reconstruction along with bladder closure and Hypospadias repair without bladder neck repair? And to answer this question, we have studied the feasibility of limited scrotoperineal approach combined with novel skin management for bladder closure and Hypospadias repair with external sphincter approximation without bladder neck repair to provide safe level of resistance to aid in increase in bladder capacity without upper tract back pressure. From January 2014 to December 2020, 45 male classic bladder exstrophy with a small to moderate size bladder plate underwent bladder closure combined with Hypospadias repair without bladder neck repair. In all these patients, limited scrotoperineal approach combined with novel skin management was used for exposure of urogenital diaphragm to provide access to external sphincter and ischiopubic ramus for radical corporal attachment. Forthcoming videos will demonstrate the technique. In a patient of classic bladder exstrophy with small bladder plate, midline incision marked along bladder plate margin and urethral plate margin for bladder plate mobilization. Incision marked along the medial raphe of anterior scrotum and along the median raphe of penile shaft for the urogenital diaphragm exposure and along the preputial edge for the novel skin management. Inner prepuce is split off the outer preputial skin dartos complex up to the corona, and inner prepuce left attached to the glans, and then dissection is continued in subdartos plane to separate the outer preputial skin dartos renal dart flap. Then incision is carried along the median raphe of scrotum to expose the bulbospongiosus muscle and bulb. The lateral flaps of the outer preputial skin dartos flap along with penile skin is separated from the penile shaft. Further, the fibrofatty tissue dissected proximally over the proximal corpora to expose the ischiocavernosus and safe plane of dissection, as we can see here. On both sides, fibrofatty tissue dissection is done further to expose the laid open external urethral sphincter and muscles of the urogenital diaphragm, bladder mobilized, intersymphysis band divided, and periosteum along the anterior border of the ischiopubic rami incised, and radical corporal attachment is performed up to the ischial tuberosity. Followed by the corporal third separation in safe subfacial plane distally up to the glans and proximally in the safe plane that we have already demonstrated in previous video. On both sides, to expose the laid open, completely expose the laid open external urethral sphincter. Glansplasty is completed. Bladder is closed without bladder neck repair and ureteric reimplantation. Urethra is tubularized, and with the help of muscle stimulator, laid open external urethral sphincter identified and anchored over the tubularized urethra on both sides. Here we can see movement of the urethra with stimulation of sphincter. Corpora is approximated. Pubic bone approximated in midline. Renal valve approximated. Abdominal skin approximated. And penile skin cover is restored according to principle of novel skin management we have described in our paper. And this is the completed appearance after complete repair. Outcome measurement included intraoperative problem, postoperative complication, increase in bladder capacity, and upper tract status. In the results, no intraoperative problem occurred in any. In follow-up, we noticed increase in bladder capacity in all and upper tract remained preserved in all. This is the aesthetic appearance in follow-up. This is the serial cystogram performed annually that showed increase in bladder capacity from 50 ml to 100 ml over the period of 2 years, though we noticed reflux in these patients as we have not performed any anti-reflux surgery. But GFR and drainage remained normal on DTP scan and there was no scarring in follow-up. Retrospective analysis of our earlier patients of classic bladder exstrophy who had only undergone bladder closure and Hypospadias repair without external sphincter reconstruction took longer duration of more than 3 years to achieve similar increase in bladder capacity. So we conclude that technique of limited scrotoperineal exposure with novel skin management enables bladder closure and Hypospadias repair with external sphincter reconstruction without bladder neck repair in classic bladder exstrophy. Anchorage of the suture, anchorage of external sphincter over reconstructed urethra without bladder neck repair contributes to increased resistance with safety of upper tract preservation yet increasing bladder capacity. These are the declaration.
Thank you, Dr. Archika. You finished with your presentation?
We think
Dr.
their internet problem, sir. I think their internet bandwidth is low.
Her frame is frozen. Hello.
Hello.
Yeah, Dr. Archika, you finished with your presentation?
Yes, sir. So was I visible or not, sir?
Yeah, it was visible till
Okay,
the
sir.
declaration slide.
Okay, sir. Thank you, sir.
Okay.
Thank you, sir. Okay, sir.
Okay, thank you for your presentation. That was nice presentation. So, Professor Satish Agarwal, he's going
Video
with
on,
the
sir. Video
session.
on.
Okay, Dr. Archika,
Yes, sir.
well, you mentioned that during the surgery, there were no problems in any of the patient.
Yes, sir.
And I can understand that you are working in a setup where this surgery has been done for a long time under the guidance of Dr. Coril, who is an expert. But what would you like to pass on to younger generation surgeons who want to start this operation? What kind of difficulties can they face and how should they avoid it?
Dr. Archika, your video is paused.
I think again, she has internet problem. Dr. Archika,
Ma'am, can you hear us?
she's offline, I think now.
Hello.
Yeah, Dr.
Hello.
So did you hear? Yes, we can hear you.
Yes, sir. Sir, question of sir, what the question here? So, what is your question, Satish, sir?
Well, question is, you said that in none of the patients you faced any operative difficulty.
Yes, sir.
And I guess that's because you're working with Dr. Coril, who is an expert and you're trained well.
Yes, sir.
But for a beginner surgeon or for a surgeon who is experienced but want to start this operation, what caution will you like to give to him or her regarding the operative difficulties and how should they avoid it?
So firstly, I want to say that it's not a beginner surgery. He has to get trained in this surgery. And secondly, he has to respect the anatomical planes that we have described in our paper.
Okay. One more question. Everyone knows that the bladder plate or the quality of the bladder plate is very important for the long-term outcomes. Whether this bladder will grow or not will depend on the plate quality. So
Okay.
keeping that in view, what age do you recommend that this operation should be done?
So in our setup, our protocol is to perform a surgery beyond 90 days of age, not before that, 90 days of age.
Why?
So before that, we have found that there are the more chances of the failure, and after 90 days of repair, if we do repair, then the more chances of the success.
Out of 45 cases, how many of them have come off diapers and in what frame of time?
So in these patients are waiting for these continence surgeries. We have found that these bladder capacity has increased, but these patients are waiting for the continence surgeries.
But you said that you have not done any bladder neck repair, and you think that
That's why we have not done. We have not said that it is not necessary. So our message is that external sphincter reconstructor also helps in increase in capacity, sir.
Got it. Thank you.
Hey, Professor Serene.
Archika, I wish to know, you have already published papers on similar topic since 2011, 2013.
Yes, sir.
In this particular study, what is so novel that you're presenting it again?
So in this, we are want to emphasize the limited scrotoperineal approach to reach the external sphincter, because in our previous paper we have not described novel skin management, and also our incision is the more it's more large. It's involved complete scrotal incision and also transverse perineal incision. So there are chances of infection, local perineal infection, and this we have only anterior scrotal incision and combined with the novel skin management. So with this incision, with this approach also, we can also approach access to the sphincter also. So this is the main emphasis of the paper, sir.
So how long could these patients on average hold urine at one time?
So this some of these patients, even without any bladder neck construction continence procedure, can hold urine up to 15 minutes to 20 minutes, sir, with external sphincter reconstruction, sir. But we have not performed any continence procedure in these 45 patients, sir. These are waiting for the continence procedures, bladder neck reconstruction.
Thank you.
Okay, thank you, Dr. Archika.
Thank you, sir.
Have finished time also. So we will go on to next presenter. And next presenter is Chaitanya. So Dr. Chaitanya, please share your screen and start presenting.
Good morning, sir. Can you see my screen?
Yes, please, we can.
Okay. Good morning, everyone. I'm Dr. Chaitanya from CMC Vellore. Today, I'll be talking about ileocecal donut augmentation for bladder exstrophy. This was a retrospective study which included 96 patients operated from 2006 to 2020. 66 were males and 33 females. So why do we need another method of augmentation? Exstrophy children need augmentation sooner or later, either due to the small capacity bladder or a high pressure system and or incontinence. A bladder neck procedure further reduces the already available small bladder plate. Now this small bladder plate has to receive 3 reimplantations, which are 2 ureters and a mitrophenol. Of the 96 patients, 48 were post-primary repair, of which 40 had incontinence, 2 had high pressure bladders, and the other 6 had small capacity bladders. 45 were post-failed repair, and 3 required an augmentation along with primary closure. Preoperatively, children were evaluated clinically, biochemically, and with imaging. In the first image, you can see a small capacity bladder system. Second image shows a failed repair. And the third one demonstrates a high pressure bladder system, both on a cystometrogram and intraoperatively by a grossly dilated ureter. All patients had a minimum of 1 year of follow-up. The minimum period of follow-up was 3 years, 5 months. 68 patients had follow-up between 1 to 5 years, and 26 were followed up for more than 5 years. 3 children were lost to follow-up. The mean creat clearance was 124, which was normal. Of the 192 renal units evaluated with an ultrasound, 145 showed no hydronephrosis, 28 had mild hydronephrosis, 17 had moderate, and 2 had gross hydronephrosis. Of the 146 renal units evaluated with an MCU, BUR was demonstrable in 98 units, of which 36 had minor and 62 had major. 48 renal units were evaluated with a DMSA scan, of which 13 units had scars. So how do we help these children, and what is this donor type of bladder augmentation? We'll see in the coming slides. The bladder is open in the lower part of with a smiley incision to have the maximum bladder plate available for both ureteric reimplantations, and this low incision also makes YDL tubing easier. The terminal ileum and the cecum along with the IC junction is isolated on an ileocolic artery pedicle. In this image, you can see the appendix on the outer side of the segment, and we have to bring it onto the inner side of the segment. How do we do that? We create a window in the mesentery, and the appendix is delivered onto the inner aspect, which is clearly demonstrated in this picture, where you can see the appendix on the inner aspect with an ileum wrapped around it. Detubularization starts from the cecal plate, extends onto the ileocecal junction and the ileum, except the part of the ileum which is behind the appendix, and then again detubularized in the distal ileum. This is a schematic which shows how we start the detubularization, and this is the final image. This demonstrates an intraoperative image of a detubularized cecum, the IC junction, and a partly detubularized ileum, along with the untouched bowel behind the appendix. As you can see, the inner margin of the cecum is continuous with the inner margin of the ileum, and the outer margin of cecum is continuous with the outer margin of ileum. There's a stitch taken on the inner where the inner aspect of the ileum and the inner aspect of the cecum meet, and suturing progresses from the inner to inner margins, which is demonstrated in this schematic diagram. In this diagram, A dash represents the inner aspect of the ileum, A represents inner aspect of cecum, C represents the outer aspect, and C dash represents the outer aspect of the ileum, where B and B dash are points where the inner and outer margins meet. This bowel plate is sutured onto the bladder plate where a Ileoplasty has already been done. The suturing starts on the posterior aspect from the center and progresses on either side. Suturing of the inner margin continues and meets the outer margin on either side at B and B dash, giving the donut-like appearance, hence the name ileocecal donut augmentation. The ureterics and the SPC are brought out through a separate incision on the bladder. Finally, we fill saline through the SPC to check for any leaks in the appendix. As you can see, there are no leaks demonstrable near the appendix. Augmentation and exstrophy should be an adjunct to bladder neck procedures to achieve our goals of safe continence. Of the 96 children, 74 underwent Ileoplasty, 17 required bladder neck division, and no bladder neck procedure were performed for 5 children, and of which 3 are planned for bladder neck division later, and 2 are under follow-up. Postoperatively, all 96 had normal creatinine level. Creat clearance was calculated for 70 patients, which was normal. None of the 96 children had anemia, which is suggestive of normal B12 levels. 18 children had documented normal post-op B12 levels. Of the 192 evaluated again with ultrasound, 158 showed no hydronephrosis, 47 had hydronephrosis, of which 34 was mild and 4 were moderate. Of the 47 units with hydronephrosis detected preoperatively, 27 had complete resolution of hydronephrosis, whereas 8 showed decrease in degree of hydronephrosis. 171 renal units were evaluated with an MCU, and no VOR was seen in 144, and minor VOR seen in 9, and major VOR seen in 18 patients. This is an image of an MCU done post-operatively, which you can see resolution of the reflux and improvement of the size of the bladder. With a DMSA, 80 renal units were evaluated, of which 5 new units had scars. 41 patients were evaluated with a cystometrogram, most of which demonstrated a good compliance bladder. 74 patients were dry for 3 hours or more with clean intermittent catheterizations. 17 were dry for less than 3 hours with CIC, and 5 patients had continuous leakage. Complications, 89 patients had no metrophenol-related complications. 2 had stenosis, which required revision. 1 had prolapse, which required a redo with gastric metrophenol, and 2 cases of anastomotic leak near the umbilicus, which healed with tube drainage. 14 patients had adhesive intestinal obstruction, of which 12 required adhesiolisis. 2 cases of bladder perforations, which were repaired. 16 cases of wound dehiscence, of which 14 settled with conservative management and 2 required resuturing. 10 patients developed bladder calculus post-op, of which 6 underwent open cystolithotomy. 4 patients are being managed with soda bicarb washes. 13 patients had recurrent UTI, which was managed accordingly. 5 patients had a bladder cutaneous fistula, of which 4 required surgery. 2 of them required closure of the fistula site at the SPC, whereas 2 patients required remobilization of the rectus abdominis flap with a skin graft. To conclude, bladder augmentation and bladder neck reconstruction are 2 important adjunctive surgeries to achieve continence in exstrophy patients. Ileocecal donut type augment with its in situ appendix offers a safe and effective method to augment small exstrophy bladders. Thank you.
Thank you for finishing within time. Let's have questions. Professor Serene, your question, please.
Dr. Chaitanya,
Yes, sir.
were all the patients included in the studies were follow-up case of exstrophy bladder, or there were other indications also?
No, sir. Only ileocecal donut augmentation for bladder exstrophy. Those are the only patients which we included in this study.
So other indications, what do you do instead?
As in, sir?
For other indications of bladder augmentation, what procedure do you use instead?
We do ileocecal as well as a sigmoid augment also. Sigmoid colon can also be used. We have done.
So why do you choose this over others in exstrophy bladder patients?
Sir, this is a modification from CMC where we have done the donut type of augmentation that we want to demonstrate. That's why this study only included the ileocecal donut type of augmentation, sir.
No, my question is that why did you opt to move on to the donut rather than the other augmentations?
Sir, because the bladder plate which is available is quite small. And if you do a sigmoid augmentation, you need to do a Mitrofanov as well, because most of these children require CIC. And in that scenario, again, the appendix has to be brought in, mobilized, and it already occupies the bladder plate. Sir. It decreases the available bladder plate that we need for augmentation.
Not agreed to that, but fine. Your paper was good. Fine.
Thank you. Thank you.
Okay. So, Dr. Chaitanya, did you close bladder neck in all patients, or you?
No, sir. Only 17 patients bladder neck closure was done. Ileoplasty was done in 76.
Why bladder neck closure was chosen in those patients?
Sir, the bladder plate was very small. We could not reimplant the ureters, and normal YDL could not be done. So we decided to do a bladder neck division in those children. Because we have seen most children who bladder neck procedure was not done eventually are requiring a bladder neck procedure because they are having continuous leak.
Okay, Professor Satish.
So taking a cue from what Dr. Mahajan asked, as you said that majority of your patients of exstrophy will ultimately require division of the bladder neck.
No, sir,
So,
sorry, sir, please.
No, let me complete my question.
Yes, sir.
So is there any way from your study till now to identify patients who are ultimately going to probably require or a high chance of requiring bladder neck closure? And in those subsets, you do it right away, because going in that area again in a future date is going to be very, very tough. And most exstrophy patients will never gain full continence, even though you make a very nice bladder, very high capacity bladder, low pressure bladder, and there is a catheterizable channel above, still you can't ensure 100% dry.
Sir, most patients require some sort of bladder neck reconstruction, either a bladder neck procedure, either a reconstruction or a division. We have opted for a bladder neck reconstruction, and we've kept the patients on follow-up to see how many of them are actually dry for at least 3 hours or more. Most of our patients have been dry with just bladder neck reconstruction, which mostly we have done Ileoplasty.
Well, I mean, understandably, you would choose the patient for bladder neck reconstruction and reimplantation only for those patients where the native bladder plate is sizable enough for you to carry out a supratrigonal kind of reimplantation and bladder neck plasty, which may not be possible in all cases. Anyway, my question to you regarding the technique particularly is, because the appendix has to take a turn through the course through the mesentery, and it will take a certain degree of curvature. So how or what steps do you take during surgery to ensure that in future catheterization will be possible smoothly in this child?
Sir, some part of the bowel which was left untubularized supports the appendix on the outer aspects. That's what I described in the ileum. That's only the part
that
of
is
the...
to make it non-reflexive.
Yes, sir.
My question is, how do you ensure, like whenever you do a Mitrofanov, when you
Yes,
finish, you remove the catheter and pass it again. It should
Yes,
go
sir.
smoothly. So is there any modification in the technique that you will do once you find that, no, the catheter is not going so smoothly, so we should do this? Say, I'll give you a cue. Say, for example, how much push or how much pull do you put on the appendix when you pull it through the mesentery? You create a hole in the mesentery and then you pull it.
Yes,
Is
sir.
it? And then you
Yes,
wrap it around to make it anti-reflux, isn't it?
Yes, sir. Yes, sir.
So what step will you like to highlight to ensure that future catheterizability will be easy? Anyway,
you can answer that in the chat box. So we'll go on to next presenter.
Dr. Mahajan, one small question, if you don't, just 20 seconds.
Okay.
Dr. Chaitanya, have you ever done Arab's procedure? The bladder plate is so small?
No, sir.
All right. Thank you.
Thank you, sir.
Okay. Okay. Thank you, Dr. Chaitanya. So we will go on to next presenter. Dr. Nihar, are you ready?
So can you hear me, sir?
Yes, we can. So if you are ready, start sharing your slides, please.
Yes, sir. 1 minute, sir.
To other presenters also, I would request that be ready with your slides, please, so that we don't waste time in between.
I'm sorry, sir. I'm not able to share it as of now.
Okay, Dr. Anju. Dr. Anju, are you ready? Dr. Anju Verma. Dr. Anju Verma, unmute yourself, please. Are you able to share your slides?
Just a minute, sir. I'm trying.
And switch on your camera also. Yes, share your slides, please. So, Dr. Nihar, you fix up your problem in the meantime.
Yes, yes, sir.
Is my slides visible?
Not yet, Dr.
Anjuman, can you just go to share screen, please?
Yes, yes, I'm sure.
Yes, ma'am. And go to full screen, please.
Slideshow.
Perfect. Thank you.
So visible now?
Yeah, visible and audible. You can start, please.
Okay, sir. I'm sorry. Good morning, respected judges and teachers. I'm going to present association of bladder wall thickness with renal function in children with posterior wall urethral valve, work done in MAMC, New Delhi. Coming to introduction, POV is one of the commonest congenital disorder with incidence of 1:5,000 to 8,000 male live birth. It is potentially detrimental to proximal urinary system. Consequences to the bladder and kidney may be irreversible, leading to chronic renal failure and stage renal disease in around 30% of patients. High intravesical pressure causes reflux nephropathy or impaired emptying of urine from upper tract. Absence of VUR is taken as a favorable prognostic factor as it indicates a low intravesical pressure state. Though the absence of VUR may be consequent to the constrictive effect of thickened bladder wall itself. Thick bladder wall is known to be a poor prognostic factor in POV. Therefore, we assess in bladder wall thickness, level are any way associated with functional outcome of the kidney. So our main objective, primary objective was to study the unit bladder wall thickness in association with renal function in children with POV. And secondary objectives were to identify the frequency of occurrence of VUR in children with POV and to study the effect of VUR on renal function in children with POV. Coming to the method, it was a cross-sectional study over a period of 19 months. And in the inclusion criteria, POV patient undergo treatment for POV in the Department of Pediatric Surgery, MAMC, up to 12 year age were included, and neonates with need of urinary diversion on account of POV, children with unstable clinical condition due to urethral syndromic illness and coexisting other urological pathologies were excluded from the study. The data was collected. All the patients fulfilling the criteria underwent clinical assessment, blood tests including CBC, KFTs, electrolytes, blood gas, urine test, ultrasound, KUB, MCUG, nuclear scan, GFR calculation. Sonographic parameter measured was status of upper urinary tract and ureter, including APPD, molar thickness, corticomedullary differentiation, degree of hydronephrosis, renal echogenesis, and status of ureters. And bladder wall thickness was measured on full bladder. It was defined as with clamp catheter when the bladder volume reaches the expected bladder capacity for the age of the patient. Start having catheter leak in non-toilet trained person, and in the toilet trained children, it was defined as when the children had urged to micturate while the bladder volume is comparable to the expected bladder capacity, or when the patient was unable to bear the distension. Bladder wall thickness was measured as anterolateral, lateral, and posterolateral position, and a mean of these three positions were taken. MCUG was done in all the patients. Both filling and voiding phase were observed. For neonate who failed to micturate, suprabig pressure was used. Finding noted for vertebral and oblique bladder wall characteristics, bladder neck hypertrophy, dilatation of posterior urethra, and VUR. Nuclear scan was done in all the patient, and the neonate we waited till 4 weeks of age. After that, we have gone for nuclear scan. And GFR was calculated using modified Schwartz formula, which is 0.413 into height divided by 3 creatinine. Now, the patient was classified in two groups. The group A, which is having bladder wall thickness less than or equal to 3 mm, and group B, bladder wall thickness more than 3 mm. Statistical analysis, quantitative data was tested by manual view test, and qualitative data was used by test by chi-square and Fisher-Tropsch test, and p-value was less than 0.05 was considered significant. Coming to the results, over a period of 19 months, total 50 patients was enrolled. Mean age was 30.5 months. 34 patients was found to have antenatal hydronephrosis. Coming to the symptom, most common symptom was dribbling of urine found in 52% of patients, and more common sign was poor steam was found in 50% of patients. In the laboratory finding, anemia is found in 26% of patients, and raised creatinine in 32%, and hypertension in 28% of patients. In the urine analysis, around 42% patient was found to have a calcium proven UTI, with the most common organism was E. coli, and 46% patient was found to have albuminuria. In the age-wise distribution, in the group A, only 8 patients was there, and all were less than 4 years of age, and in group B, 42% patient over there, and all out of these, 80% were under 4 years of age. When the various data were compared between group A and group B, we found significant result only for urine albumin. In the rest of the findings, we don't found any significant result. So further moving on, we have taken mean, median, and standard deviation of GFR, and an ROC curve was plotted to identify the cutoff bladder wall thickness to predict the CKD, and we found a value of 4.1 mm of bladder wall. Now the data were again compared between less than and more than bladder wall, 4.1 bladder wall thickness, and we found a significant difference between the raised creatinine level, urine albumin, hydronephrosis, presence of VUR, and mean GFR. Around 46% of patients have VUR in our study, and when the data were compared between presence and absence of VUR, we found significant statistically significant value for mean creatinine, mean bladder wall thickness, positive urine culture, and mean GFR. Coming to the discussion, the renal function outcome patient with PUV is the interplay of 3 main factors, that is renal dysplasia, VUR with UTI, bladder dysplasia. All these factors can be correlated with the developmental anomaly of urogenital tract. Among all the 3, the bladder dysplasia got maximum bearing with the final functional outcome and can dictate the long-term outcome. Intravesical obstruction leads to alteration in organization of function of bladder smooth muscle and deposition of abdominal collagen depletion. This deposition in the extracellular matrix and ratio of collagen 1 and 3 lead to overall increased collagen accumulation in bladder wall of growing fetus. And this can be seen as a physiological response to protect muscle when they are stressed by preventing their overdistension. May also manifest as hypercompliance and causes hypertonic bladder filling, leading to back pressure on the developing kidney. Can cause high pressure bladder system that can interfere with the optimal urethral emptying. So in our study, mean age of presentation was 30.5 months. 50% patients were infants. Most common presenting symptom was voiding dysfunction. Raised serum creatinine was found in 32% of patients, and mean bladder wall thickness was 4.2 mm, which was far more than 3 mm quoted in literature. And only 16% patients had bladder wall thickness less than 3 mm. Our sign and symptoms was correspond to the study by Ileocolic and also by Tambo et al. Study done at 10-year audit. As per Sigrid Jaguar, the upper limit are 3 and 5 mm for a full or empty bladder respectively, regardless of patient's age and gender in the normal patient. As a study done by Swing-Lee, the retractor muscle more than 1.3 mm on ultrasonography was an independent prognostic factor for bladder failure, but they have taken bladder wall thickness when the bladder was 50% full. So when analyzed different cutoff for bladder wall thickness with VUR, significant difference in percentage of subject having VUR in less than and more than 4 mm.
Sorry for intervening in between. The presenting time is over.
So coming to the conclusion, high bladder wall thickness is associated with poor renal function. Serum creatinine, positive urine culture, and urine albumin are found to be significant association with high bladder wall thickness. We have identified that in children, a high bladder wall cutoff hints at higher adaptability for bladder muscle in young children. This will give more margin of time to pediatric surgeon and give them scope for bladder muscle relaxing agent to improve outcome in young subjects with UV, as maximum damage occur due to VUR in high bladder wall thickness as observed in our study. These are my references. Thank you.
Thank you, Dr. Anju. Just one question. How did you ensure uniformity of measurement of bladder wall thickness? Who did this measurement for you?
Yes, sir. So we have the ultrasound was done by only one senior radiologist in all the patients, and we have done at least twice the ultrasound, and we have checked that the bladder is almost full as per their capacity.
So only one observer. Okay. Yes. Professor Serene.
Anju had been my student, so in all propriety, I will not ask her questions or mark any. You do need to mark for her. Thank you so much.
Okay, thank you. Professor Satish.
Dr. Anju, yes, I would have to comment that you rushed through your slides and lot many things were not very, very clear. But still, if I got you right, the measurement that you did for the bladder wall thickness was in the radiology department, and yes, the catheter was put in and the bladder was filled in to the expected bladder capacity, and then an ultrasound was done.
Yes, sir.
So that means you're creating an artificial condition where the child is there in the radiology department, there is a catheter in C2 in one room, and then the child is shifted to ultrasound. So what kind of practical difficulties are there in this kind of setup, and how do you propose to correct it?
So it was a catheter was put in the smaller children who were not able to tell that bladder is full. And we have a separate room in radiology where we put the catheter and child was properly fed so the bladder can be filled properly. And then we have gone for ultrasound and we have checked that bladder is not full. Then we have filled the bladder and then we have taken the bladder wall thickness.
Okay, fine. And do you expect that these thick bladders will fill to the expected capacity?
No, sir, not all the time. We have, in the many patients, the 80% of expected bladder capacity, the bladder was full and pericatheter leak was started.
So when the pericatheter leak started, you measured?
Yes, sir.
Right, okay. Are there any nomograms available for normal bladder wall thickness in the general population?
So mostly they said that in the full bladder it is less than 3 mm and in the thick empty bladder is 5 mm. There is no change regard with age and gender mostly. In the male there is slightly thicker bladder wall, but there is no such nomogram.
So do you think we have a need to develop nomograms in normal children and then compare them with children with valves?
Yes, sir. There are many studies, but there is no cutoff. So we have to make a cutoff to compare.
Thank you. Thank you.
There's one question from the audience. Dr. Ramesh Babu is asking,
Yes, sir.
How do you ensure fullness in presence of bladder fullness in presence of reflux? So when do you say that bladder is full? When do you say it is not full in presence of reflux?
So when the bladder is full, at least around 80% of the expected bladder capacity. 70 to 80%.
Okay, thank you.
Thank you.
Thank you, Dr. Anju.
Thank you.
So we'll go on to next presenter, Dr. Ram Mohan. Are you ready?
Yes, sir. I am ready, sir.
Share your screen.
So is it visible, sir?
Slideshow, please. Yes, start presenting.
Yes. Hello, good morning, everyone. I'm Dr. Ram Mohan from CMC Vellore. I'll be speaking about the use of bubble tubes in as a urethral substitute in complex urethral reconstruction. Complex urethral reconstruction is one of the difficult surgeries performed for various causes. The aim of the study was to emphasize the use of bubble tubes in a complex urethral reconstruction of the urethra. The study includes 25 patients who underwent a transpubic urethroplasty in 2 institutes over a period from 2005 to 2021, of which 2 were girls and 23 were boys.
Hello.
Of the various causes for which a patient had for the various causes for which the patients had underwent a urethroplasty, 9 wide duplication of urethra, 6 had aphalia, 3 had congenital posterior urethral stenosis, 2 had traumatic urethral stricture, 3 had ARM with urethral transection, and 2 were for other causes, which include a bulbar structure following a bacterial anomaly and a bulbar structure post PUV fulguration. 11 of them had associated genitourinary anomalies, of which the most common was a solitary kidney. 3 had associated anorectal malformation, and 2 had spinal anomalies. All of these patients were investigated with X-ray, ultrasound, MCU, and an RGU. Left is an image of wide duplication of urethra showing a narrowed dorsal urethra. Right one is a MCU and RGU image showing a long segment traumatic urethral stricture with MCU showing bilateral grade 3 BUR. All of them underwent a transpubic urethroplasty through a transpubic approach. Then either a sigmoid or ileum was used as a use alone or in conjunction with a preputial tube for the reconstruction of urethra. Ileum tube was was fashioned by a procedure described by Monti and modified by Young. The sigmoid bowel use of sigmoid bowel is a novel technique which was based on a sigmoid branch of an inferior mesenteric artery. The image on the left shows the ileal tube, use of ileal tube in the reconstruction of urethra. The right one shows a sigmoid bowel used for a reconstruction of urethra based on sigmoid artery. Then the image on the left is a reconstruction of the urethra. You can see the entire length of the urethra can be replaced using a sigmoid tube. This has been anastomosed to the bladder neck and then brought out through the penile tip. The image on the right shows the length of the sigmoid colon that has been brought till the penile tip. This is an operative image of a child with aphalia who underwent a sigmoid tube reconstruction for the urethra. All patients had appendicular metrophenol as a safety procedure. They were post of the periurethral and the metrophenol catheter was kept on drainage for 3 weeks, following which a contrast study was done through the metrophenol. Voiding fillings were taken, and then the periurethral catheter was removed. All patients were followed up for a mean period of 34 months. They were followed up with serum creatinine, USG, KUB, and uroflowmetry. This is an image, MCU image showing reconstruction of the urethra. The posterior one is a reconstruction with using a sigmoid colon. The middle portion is of a preputial tube, and the distal one is a native urethra. This is one of the voiding image of one of a child post sigmoid bowel reconstruction showing a normal bell-shaped curve. These are some of the post-operative voiding images of a child. This is first one is a child with aphalia post ileal tube reconstruction showing a voiding film. Second one is a child with a PUV post bulbar structure had a reconstruction of the sigmoid colon voiding image. The third one is a girl child with a pelvic trauma had a sigmoid colon reconstruction for a complete urethral transection for which a reconstruction was done using a sigmoid colon. This one is a child with a wide duplication of urethra, voiding film and wide duplication of urethra post sigmoid colon reconstruction. Outcome: all patients are voiding regularly through the penile tip. They're asymptomatic without a UTI. They have a normal creatinine and no significant post-void residue. Two of the patients are waiting distal urethral repair with a buccal mucosal graft. Two are dependent on CAC because they had a neurogenic bladder, that they are doing CAC through the penile tip. Two patients had complications. One had meatal stenosis, for which we did a urethroplasty, and one had a urethroperitoneous fistula, for which a revision was done. The advantage of sigmoid tube is that it's readily available, and the entire urethra is replaceable in small children with a sigmoid tube alone. The disadvantage of both sigmoid as well as ileal tube is that both has a mucus discharge, but the disadvantage of sigmoid colon is that it can't be used if the sigmoid colon have already been used for a sigmoid colostomy. But both has mucus discharge, which can be managed conservatively. To conclude, bowel tubes are effective urethral substitute where a long segment urethral replacement of anterior or posterior urethra is required. The long-term results are good. Thank you.
So thank you, Dr. Ram Mohan. The question is that is there a space constraint when you are using bowel tubes for urethra? Appendix is all right, buccal mucosa is all right, but using sigmoid tube or ileal tube, did you face any space constraint?
No, sir, because we'll be cutting the pubic bone, we'll have good enough space for reconstruction. Sir. We'll be exposing the bladder also till the bladder neck.
So what is the age of the patients you operated?
Sir, age of the patient range from 5 to 11.
Surgery.
Sir, 5 to 11 years. 5 to 11 years.
Okay. Professor Satish.
Well, a nice paper, Doctor.
Yes,
now, use of intestinal segments is nothing new for urethral reconstructions. My question to you is, you said that you used transpubic approach in all of the patients. Yes. So did you use the transpubic alone or along with the perineal approach?
Sir, if the entire urethral reconstruction was required, only posterior urethra was required, then only transpubic was used. But if entire urethra need to be reconstructed, then perineal approach was also
when you are replacing the posterior urethra, you still need to do an anastomosis between the anterior urethra, yes, the upper end, yes, and the substitute. So have you faced any particular difficulty while approaching it through the transpubic? And the second question is, when you use transpubic, do you use a partial pubectomy or you use a pubotomy and then use a retractor?
So partial pubectomy, so we'll divide the pubic symphysis almost 2 centimeters on either side and then fashion it to the tube.
Well, okay. I mean, I have used a combined perineal and transpubic approach, but that's besides the point. The other question is, you said 2 of your patients are on CIC through the penile tip.
Yes, sir.
Now, if I remember correctly, when you use... Sir,
I'm not able to hear you. Sorry.
Dr. Satish, unmute yourself.
Right. Can you hear me now?
Yes, sir. Yes, sir. Yes, sir.
So 2 of the patients who are on CIC through the penile tip.
Yes, sir.
I guess the catheter is going through a tortuous route of the sigmoid or the ileum, whatever.
These patients who are on CAC, they have direct tube. There was no perineal route. We from the bladder neck, it is brought straight down into the penile tip. So it's easy for them to do a CAC to the penile tip. And we didn't have a tortuous course of the urethra, sir. We had a straight course.
So they have a straight course despite there being a Monty tube of the sigmoid or ileum. Yes,
we brought directly from bladder neck to the penile tip as a straight course.
So why have you not used the Mitrofanov? You've done Mitrofanov in all patients.
Mitrofanov is there for as a safety procedure for all of them, sir.
But you don't use it if it is, yes, sir, doable through the penile tip. Okay. Okay. Thank you.
Okay, Professor Siri.
Dr. Ram Mohan, you said many of these patients had anastomosis, proximal anastomosis right to the bladder neck.
Yes, sir.
So what were the incontinence rates in such patients and what is your definition of incontinence?
The majority of them didn't have incontinence because we didn't divide the bladder neck, sir. We anastomosed just at the bladder neck. We didn't divide the bladder neck, so they don't have the problem of incontinence.
So none of the patient had incontinence in your series?
No, sir. No, sir.
Because majority would have, posterior urethral injuries or if there is some other issues. Okay, you good. Thank you.
Thank you. Thank you, Dr. Ram Mohan. Now we go on to the last presenter, Dr. Nihar. Now start sharing your slides, please.
Yes, sir. Are my slides visible, sir?
Not yet.
Are they visible now, sir?
No. Please take help of somebody around you, because we are running short of time.
Can you please see now, sir?
No.
Dr. Yogesh, are you able to see the share screen option at the bottom of the screen?
Yes, sir.
Okay, just
Since
click on that.
I'm using it on my phone.
Okay, which phone is this?
Android, sir.
Android. So
actually, I have not got an email of the Zoom.
So it's the same link that you connected to now, sir.
Sir?
It's the same link that you connected to now. Do you have any desktop?
But they have sent it on WhatsApp. Yes, sir. Can you, if I get an email, I can log on immediately. I'm using my phone. That's why.
Okay, so your meeting ID, if you can see it here, I'll just copy it down on the chat box for you to make it simpler for you.
Sir, mine is Nihar Patil is my name. My email ID is niharpatil@gmail.com.
I'm sending you immediately right now. Okay.
I have sent on your email. Nihar, check now. I have sent it on your email.
Yes, sir.
We have sent it multiple times on all the presenters' email. We have strictly advised not to use mobile device while making presentation in such a major session.
Yes, sir. I am logging on, sir. I have got it now. Yes, sir. I should be ready in another 2 minutes. In another minute, sorry.
So once he presents, Majan sir, I don't think we will have time for questions for him, because 10:30 we have to be on the oration proceedings.
Okay, so after his presentation, we'll close.
Yeah, provided he makes it, provided he is able to share and.
Recording in progress.
Yes, sir. Yes, sir.
Recording in progress.
He is on 2 devices. Remove his.
Dr. Nihar, can you log out from your mobile? Dr. Nihar, please log out from your mobile first.
Can I be heard, sir, now?
Yeah, you're audible and visible. So please start your presentation.
Today I would be, just a minute, sir. Today I would be presenting on dorsal onlay substitution urethroplasty with buccal graft in pediatric urethral strictures. I have no disclosures to be made. Oh, I'm sorry. Sorry. There is paucity of literature in the management of children with non-hypospadias long segment anteurethral strictures. The pediatric urethra presents a small challenge because of its smaller pelvic anatomy, decreased caliber, and increased tissue fragility. These strictures are usually with an acquired etiology. It could be trauma, iatrogenic, or a complication of a hypospadias surgery. Management options for short segment urethral strictures less than 1.5 centimeters could be urethral dilatation, internal urethrotomy, and end-to-end anastomosis. Strictures longer than 1.5 centimeters require some kind of substitution using a prepuce or a buccal mucosa. The dorsal onlay buccal mucosal graft urethroplasty utilizing the Kulkarni and Barbagli techniques are safe and feasible approach in children with good long-term outcomes. We have aimed to review our experience of buccal mucosal graft urethroplasty in children with long segment non-hypospadias anteurethral strictures and to evaluate the long-term outcomes. This is a single center retrospective study conducted between 2009 to 2019. 78 children were referred to us with urethral strictures and 28 children satisfied our inclusion criteria. This was a protocol that we followed when a child was referred to us with a urethral stricture. An initial retrograde uretrogram and a voiding cystourethrogram was performed to ascertain the exact location and the length of the stricture. A uroflowmetry was performed in all the toilet trained children, and a Qmax of less than 10 ml per second was considered abnormal. The strictures were classified as penobulbar and isolated bulbar strictures. Children who are uncircumcised, hypospadia strictures, completely obliterated strictures, short segment strictures, pelvic disruption strictures, children who underwent recurrent surgeries, other procedures, and pan-urethral strictures were excluded. Children who are circumcised with long segment strictures underwent a single stage dorsal buccal mucosal graft urethroplasty. That is, the penobulbar group underwent the Kulkarni technique and the isolated bulbar group underwent the Barbagli technique. Catheter was placed for 3 weeks and all were followed up post-operatively, initially at 3 months and then annually. General anesthesia via the nasal route was instilled so that the oral cavity could be free for a graft harvest. Children were placed in lithotomy position with a guide wire across the strictured urethra. Grafts were harvested from single or both the cheeks depending on the stricture length, and two-team approach was implied, that is a perineal and oral cavity team, to reduce the operative time. Children who had penobulbar strictures underwent the Kulkarni technique, that is a single stage dorsolateral onlay buccal mucosal graft urethroplasty with one side urethral mobilization. An initial incision on the perineum is placed and the penis is everted into the wound. Stay sutures are taken. A guide wire is passed across the strictured urethra and the urethra is laterally mobilized. The entire length of the strictured urethra is laid open and the adequate length of the buccal mucosa is harvested from the oral cavity and is placed over the corpora and buttressed using 5060 polyglactin sutures. Then the medial border of the strictured urethra and the lateral border of the buccal mucosa is sutured in continuous fashion with proximal and distal interrupted sutures. Then the penis is inverted back into the wound and a 10 or 12 French Foley's catheter, age appropriate, is placed across the strictured urethra, and the lateral margin of the strictured urethra and the medial border of the buccal mucosa is sutured once again in the same fashion. The dartos is closed over it and the perineal incision is closed. Isolated bulbar stricture children were managed by the classical Barbagli technique, which is a single-stage dorsal onlay buccal graft urethroplasty with circumferential mobilization of urethra. An incision on the perineum is made, stay sutures are taken, a guide wire or a Foley's catheter is passed across the strictured urethra. The bulbar urethra is isolated and is looped up and is rotated 180 degrees so that dorsally an incision can be made along the entire length of the strictured urethra and an adequate length of the buccal mucosa is placed on the corpora, and the corresponding sides of the strictured urethra as well as the buccal mucosal graft is sutured in continuous as well as some interrupted sutures at the proximal and distal end. Then the wound is closed. Post-operatively, catheter is kept for 21 days. Children who had bladder spasms were started on oxybutynin. At 21 days, if no evidence of complications, catheter was removed and the urinary stream was assessed. All children were followed up initially post-operatively at 3 months and then annually with a uroflowmeter and then a urinary stream was assessed. Retrograde urethrogram was performed only if required, that is, if there was any suspicion of a urethral stenosis. Our success of management was described or was said to be if the Qmax was more than 10 ml per second at the last visit and if no secondary procedures were required. Of the 78 children referred to us with urethral strictures, 28 children satisfied our inclusion criteria, 16 had penobulbar strictures who were managed by the Kulkarni technique, and 12 had isolated bulbar strictures who were managed by the Barbagli technique. The median age at presentation in the penobulbar group was 7.5 years. In the isolated bulbar group, it was 5.5 years. In both the groups, the commonest symptom was poor stream of micturition, and in both the groups, the commonest etiology was iatrogenic, either instrumentation or catheter induced. The mean length of stricture in the penobulbar group was 4 centimeters, and in the isolated bulbar group, it was 2.5 centimeters. The median pre-op uroflowmetry was 7 ml per second in the penobulbar group and 6.5 ml in the isolated bulbar group, which was abnormal. The operative and post-operative details were that majority of the children had a single graft that was used from a single cheek. The mean operative time in both the groups was 128 to 130 minutes, and the mean days to catheter removal was 21 days. The mean days of hospitalization was 3 days. In the complications, one child developed a urinary fistula in the penobulbar group, for which a primary closure was done. One child developed a surgical site infection, which was managed with local dressings. One child developed a urethral restenosis with a Qmax of less than 10 ml per second, for which a single sitting of urethral dilatation was performed and the Qmax improved. One child developed a mild CORDY, which was no intervention was required. One child had oral cavity complications, which were managed by local applicants. One child in the isolated bulbar group, one child had a urinary fistula, which was managed with primary closure. One child developed a urethral stenosis, which was managed by a single sitting of urethral dilatation. These 2 children in each of the groups were considered as failures of our management. The median follow period in both the groups was 90 to 96 months, and the median post-op uroflowmetry in the penobulbar group was 16 ml per second. In the isolated bulbar group, it was 15.5 ml per second. The success rate in the penobulbar group was 87.5%, and in the isolated bulbar group, it was 83.3%. The advantages of dorsal onlay urethroplasty, that is the Barbagli technique which is used for isolated bulbar strictures, is the graft is fixed to the surface of the corporeal body, providing excellent blood supply with good mechanical support. The risk of graft shrinkage and CODY is reduced, and problem of ventral circulation is also reduced. The added advantages of modified technique of lateral mobilization, that is a Kulkarni technique for penobulbar strictures, is preservation of one-sided bulbar artery in addition to maintaining the native lateral vascularity at the meatus and distal urethra. There is abundance of literature on the usage of buccal grafts in various configurations for adult anterior urethral strictures, but very few large case series with long-term outcomes in children. The youngest child in our review was a 2-year-old child with penobulbar stricture and 3-year-old child with isolated bulbar stricture, which was managed. I would also like to stress on the role of uroflowmetry as a non-invasive tool for assessment in toilet-trained children. The success rate of our management was more than 80% in both the penobulbar stricture and isolated bulbar stricture management. I would like to conclude by saying that dorsal onlay graft techniques, that is the Kulkarni and Barbagli techniques, serve as a safe and feasible approach in children with good long-term outcomes. The morbidity, especially in children of stage surgeries and recurrent surgeries, can be completely avoided. Thank you.
Thank you, Dr. Niyar. Dr. Ravi, we have time or no time?
Just one or two short questions with short comments.
Professor Serene, one question, please.
No, it was an excellent presentation. I think I can let go the questions.
Thank you, sir.
Dr. Satish, your question.
How do you choose between this and BRCAs? Any case selection?
Sir, one thing is BRCAs is a 2-stage procedure. So we would avoid a 2-stage procedure. As I mentioned, that the morbidity in a child having 2-stage procedures is always much more difficult than a single-stage procedure. And the results show that we had an 80% success rate in both the penobulbar as well as the isolated bulbar group. And the other thing in BRCAs is, one thing is that the graft, the main disadvantage is the buccal mucosa shrinks after placing it on the corpora.
Okay. So about the removal of catheter, you said 21 days.
Yes, sir.
So do you straight away remove it, or do you do some kind of bladder training? How much time before removing the catheter do you stop tropan and oxybutyn-like things?
Sir, if they have bladder spasms, they are started on oxybutyn, and usually we keep it only, our protocol was to keep it for 3 weeks. So if there was any symptoms, like if there was any kind of a leakage prior to the catheter removal, then we would prolong it and we would keep it for longer time. Otherwise, we would remove it and then we would assess the urinary stream.
Any bladder training before you remove?
Yes, sir. We would always tell the parents that the child should not force while passing the urine and he should pass at a comfortable level.
No, sorry. Anyway, you didn't get my question right. Thank you.
Yes, sir.
Thank you, Dr. Nihar. That was a nice presentation.
Thank you.
So with this, we close this session, and I thank all the presenters, and I thank my fellow judges, Professor Satish and Professor Serene, and thank you organizers for giving us opportunity to judge this session. Thank you very much.
Thank you, Dr. Mahajan. Thank you, Dr. Ravi and Dr. Ravi Kanoji and Ravi Ramadwar, Dr. Partha Pratim Gupta. Thank you so much.
Thank you, sir. Thanks. Very sincere thank to all the 3 judges sticking to time. So we will now start the proceedings for the oration. Scheduled time is 10:30. It's almost there. Give me a second to share my screen. Yeah. So Ramadar sir, is my screen visible?
Yes, sir.
Okay.
Yes, it is visible.
We have Dr. Mohan Abraham in the session.
Yeah, he's joined in.
He's joined. Okay. Okay. So welcome everyone. We will now start the proceedings for the IAPS MS Ramakrishna Oration. We have earlier declared that this year's Ramakrishna Oration is going to be delivered by Professor Mohan Abraham. He will be talking on VUR, where we are. So before we start the proceedings, I would like to tell the audience here that last Sunday on 17th of October, we had arranged an in-person ceremony for all the IAPS awardees. And during that time, we were fortunate that Dr. Abraham was present there physically in Mumbai, and he was handed over the award plaque and the shawl and the citation scroll by the IAPS president and the president-elect. You can see the pictures of that ceremony. Abraham sir, we would have done this in person in the auditorium had we had the actual physical conference. So this is a virtual form of felicitation for you. So this is the citation. I would request President Dr. Ravindra Ramadwar to read out the citation, which is customary before the start of the oration, and invite the orator on the dais for delivering the oration. Over to you, Ramadwar.
On 17th, and was really happy to put a shawl around his shoulders and felicitate him with the award citation and the plaque. So I would just read out the citation which goes for this important oration, which is a very traditional and a very vital oration of IAPS conference. So Dr. Mohan Abraham, he completed his MBBS in 1976, MS in 1981 from CMC Ludhiana, and MCH from Trivandrum Medical College in 1985. He has worked as a consultant pediatric surgeon in City Hospital and previous hospital after that, and later joined Amrita Institute of Medical Sciences, where he organized the Department of Pediatric Surgery and started DNB and MCH programs. He is currently working as a professor and head of Department of Pediatric Surgery and Pediatric Urology. He is well known for his invention of urethral valvotome. He has contributed to the development of pediatric surgery in the form of many research publications and innovations. His techniques of vesicoscopic reimplantation of ureters, modified technique of Focker's procedure, laparoscopy-assisted retroperitoneous pyeloplasty, intravesical pressure, a new prognostic indicator in congenital diaphragmatic hernia, a simple and safe technique for pneumatic reduction of intussusception are some of his contributions. He has many chapters in reputed books to his credit. His field of interest is pediatric urology and fetal surgery. He was the founder chairman of Pediatric Urology chapter of IAPS. He established the first comprehensive fetal care center in India in Amrita Institute of Medical Sciences and has been pioneering the fetal care program in India. He is also the instructor course director for immediate life support course organized by Trauma Life Support Society of India and instructor of advanced life support course of American College of Surgeons. IAPS is extremely proud to present this prestigious award and confer it on Professor Mohan Abraham, the IAPS MS Ramakrishna Oration. Ladies and gentlemen, please welcome Mr. Mohan Abraham or Dr. Mohan Abraham on the dais with a loud hand of applause.
Thank you.
Over to you, sir.
Thank you, Mr. President, Dr. Ramda, for the nice words. I like to thank the President and the Secretary and the members of the Executive Committee and the organizing team to bless me with this oration in the name of such an eminent person like Dr. M.S. Ramakrishnan, who was one of the pioneer Can you see my slides?
Yes, sir, we can see.
Okay. He was one of the pioneer pediatric surgeons in India, and he did his master's way back in 1950. And even then, during that time, he was interested in research work and contributing to the society. He is known for his, claw hand correction for leprosy in Tamil Nadu. Then he took an interest in pediatric surgery, went to Canada in 1959 to be trained as a pediatric surgeon. He returned to India in 1961 and established the first chair of pediatric surgery in India, started the MCH course in 1967, and he was the president of Indian Association of Pediatric Surgeons for 2 terms. He was also the vice president of Asiatic Association of Pediatric Surgeons, president of the Association of Surgeons of India, and he was also a member of British Association of Pediatric Surgeons. He was a visiting professor to many hospitals and universities, especially the Alda Hay Children's Hospital in Liverpool, UK. He has given many orations like Elizabeth Mithai Endowment Oration, Colonel Pandalai Oration, etc. His significant research has been in tuberculous lymphadenitis in children, replacement of diaphragm with synthetic materials, incidence of congenital malformation in consecutive live birth, lymphadenographic studies in malignancies in children, and rectal and mucosal biopsies in children with chronic constipation and Hirschsprung's disease. The first formation of tumor registry in Institute of Child Health was his brainchild. After his retirement, he started Childress Hospital. I don't need to tell you about Childress Hospital. It is an accredited hospital for National Board of Examination, both for pediatric medicine as well as pediatric surgery. Apart from numerous original articles, his original work on anterior sagittal urethroplasty, congenital short column are well recognized. He got numerous awards, which is a testament to the recognition to his qualities as an excellent pediatric surgeon. He went to his heavenly abode in 1991, but I'm sure he will continue to live in our hearts and continue his work through his trainees. At this time, I'll also like to thank God, the Almighty, and my teachers, Dr. Egliston, Dr. Raman Nair, Dr. Surendran, Dr. Maninanan, for making me what I am, for initiating me into the field of surgery and teaching me the basics of pediatric surgery. Thank you once again from my bottom of my heart. I'd also like to thank Dr. Ravi Kumar, who has been mentoring me right from the time I passed my MCH. I still remember writing to him about anovestibular fistula, and he's sending me Ravi's flap diagrams. Those days there were no emails. So he drew the whole thing in a piece of paper and sent it to me by post. And I was used to do Ravi's flap on those days. So thank you, Dr. Ravi Kumar. And I also like to remember my other friends who have been encouraging me in my journey through pediatric surgery, Dr. VVS, Sujit Chowdhury, Sripati, Kuril, Ramesh, Sarin, DK Gupta, and Minu Bajpai, without whose encouragement I would not have been able to continue. And of course, my team in Amrita, who has been the support, the encouragement, and probably my second brain, who gives me the ideas, who execute it, and many of the time I am an observer or a supervisor. So thank you all once again. Coming to VUR, etiology, the genetics is something which we surgeons tend to underestimate. Now we have to remember about 34 to 45% of affected patient siblings will have reflux between birth and 18 months of age. That itself talks a lot to the genetic component of the problem. Now we have shown that if the VUR using system, 24 out of 36 offspring, that is 66% of offspring exhibited VUR. And if it is a part of a syndrome, then it is much more. Now we know that abnormalities in the ureteric bud can produce defects in the differentiation of nephrogenic mesenchyme, creating dysgenesis. And we also know that in KRD mutant mouse, PAX2 gene, when deleted, it produces ureteric dilatation. So the whole thing may be part of a same problem. Like ureteric dilatation is the dysgenesis is the, and many times we tend to contribute the damage to the kidney as a result of reflux, while it is part of the whole picture. Now, what are the risk factors? The studies have shown that the reflux grade, history of urinary tract infection, and age at diagnosis were the independent risk factors for renal parenchymal damage. Angiotensin converting enzyme, genotype, and gender were not significant. I'm not going into clinical presentation because all of us know what it is. Now, coming to investigation, one of the most important investigation that we do is a micturating cystourethrogram. And now, if it is not done properly, it leads to misdiagnosis or missing a reflux altogether. Now, many times you would have seen that the radiologists inject the dye into the bladder with a syringe. And as we were discussing in the previous session, the bladder volume varies from patient to patient. You can't calculate by the formula, either ICCS or cause formula to decide how much is the volume. In a PUV bladder, it may be much smaller, the thickened contracted bladder. In an infrequent voider, it may be a large volume bladder. So the way to do MCU, this is why American College of Radiology and Society for Pediatric Radiology came out with a parameter or practice parameter. The contrast media probably 12 to 18% weight by volume, and that is important because I've seen MCUs, 1:1 concentration and very thick. It look beautiful because it looks like as if it is painted, but then it masks if there's a urethral, if there's a stone, or if there is a diverticle on the posterior aspect of the bladder, it is masked by the thick contrast. So contrast should make the bladder visible, but not obliterate the details. So that's why 12 to 18%. And it is the gravity method, like you do in UDS. It has to be a drip method and fill the bladder, because if you fill the bladder with a syringe, it goes into a reflex contraction, because sudden filling will create a reflex, and you may feel that it's a small contracted bladder when actually it is an artifact. So it has to be filled at 30 feet, 3 feet high, or 100 centimeters of water. Reason being, that is a maximum voiding pressure a male child can produce. So that's the physiology. So hang the bottle at 100 centimeters, allow the thing to drip in, and then take the fillings. And another inadvertent advantage is that when the bladder is fully full like this, you remove the catheter and the child will void reflexively. You don't have to use suprapubic pressure and create artificial pressures in the bladder. If a recent surgery has been performed, then of course you have to be careful. You start from a lower level and gradually raise the bottle till the child feels discomfort. In infants, because they are crying, the bladder may not fill properly, and you may miss a reflex. So you can repeat it 2 or 3 times, refilling, the cyclical filling, that will reduce the chance of missing a reflex. Now coming to the laboratory investigations, urinary alpha-1 microglobulin creatinine ratio has been seen to be diagnostic for vesicular reflux with a sensitivity of 90% and specificity of 70%. And so this is something which we can use and maybe at least as a screening method. There was no direct correlation between blood pressure and plasma renin activity, plasma creatinine concentration, or even degree of scarring. So checking on the plasma renin activity may not help in predicting the severity of the disease. Analysis of blood pressure standard deviation scores, however, suggested an excessive rise in blood pressure during the 5 years. And that's something which we also have found. When we do it in the newborn period, we always tell them, like you have done a valve ablation in the newborn period, we tell them to come back at 5 to 6 years, because that's the time we have seen that these children develop blood pressure or hypertension. So we ask the parents to come back or go to a pediatrician with the appropriate cuff for the BP measurement to check the blood pressure at that age. And also we have seen that it usually occurs when the in the DMSA shows a parenchymal amount of less than 20% compared to the opposite side. So that is where when we think that the child should be careful. Now, the data continue to support the role of renin-angiotensin system in the observed rise of blood pressure in reflex nephropathy, but individual PRA measurement do not appear so far to predict reliably the onset of hypertension in affected patients. Then we come to DMSA scan, and I'm sure all of us are doing it. But earlier, when I was being trained in 1985-82, we were told that do not operate on children before 1 year of age. The logic was, by 1 year of age, the child start walking, and the gravity will help to, resolve the reflex. And also it was thought that as a child grows, the submucosal tunnel length increases, and that also will lead to reduction of the reflex. But at that point of time, we did not know about the damage that the kidney is undergoing. We are going by the blood urea creatinine rate. And blood urea and creatinine won't rise unless until 2/3 of the total kidney substance is damaged. So we were unaware of that, but by the coming of DMSA scan, we can pick up scars much earlier. So if there is increasing scars in spite of conservative management, that indicates the need for intervention. Nothing else. Not the age, not the grade of reflux, nothing else. But if there is increasing scars, then you need to go in. Now, how do you manage? Of course, conservative management is the mainstay. And how about antibiotic prophylaxis? It's a very gray area. There are papers of conflicting conclusions. Now, this paper say our findings imply that discontinuing antibiotic is reasonable and safe in patients in whom respiratory reflux fails to resolve. There's another paper that said discontinuing prophylactic antibiotic in selected school-age children is a safe practice. Now, if you go to Cochrane database, it says, again, it's not sure about the efficacy. Compared to no treatment, the use of long-term low-dose antibiotic may make little or no difference to the number of repeat symptomatic and febrile UTIs in children with VUR. Again, the added benefit of surgical or endoscopic correction of VUR over antibiotic treatment alone remains unclear. So we don't have an answer from Cochrane also. Now, there was this important study, which is known as RIVER study, which was conducted in 2014. And it is a good study. It's a 2-year multi-site randomized placebo-controlled trial involving 607 children. And they concluded that antimicrobial prophylaxis was associated with a substantially reduced risk of recurrence of UTI, but not renal scarring. Now, that's a paradox. So far, we have been thinking it's the infection that is producing the, the scarring. So here, the infection is reduced, but not the scarring. So we had to look at it. Why this paradox? And probably this article will give the answer. It says, until recently, it had been thought that the sterile reflux posed little risk for subsequent nephropathy. However, ultrasonic and nuclear medicine studies have commonly demonstrated areas of dysmorphism, loosely called scars, that occur even in the absence of infection. So it may be wrong to think that the infection is a culprit, and if you can avoid infection, you can go on any number of times. I had patients coming to me where this advice is given: 3 years, no infection. After 3 years, I advise a DMSA, because the people over, was seeing them before, some adult urologist said, if you are not having infection, you don't have to bother. Just go on for 5 years. And in 5 years, if it hasn't subsided, then we'll operate. So they just kept quiet. 3 years, somewhere somebody directed them to me, got a DMSA scan, and the kidney had 18% function. The parents were very upset. I said, maybe that the child had only 18% to start with, because no DMSA was done before. So I just consoled them and prevented a litigation. But something which we have to think about is sterile reflux can produce scars. Now we come into bladder dysfunction. What is in the common bladder dysfunction in this case? Because PUE we intend to pick up very fast, because child is symptomatic. What is not usually what is missed usually is a diffuse sphincter dysenergy and bladder neck hypertrophy. Here the child comes with staccato voiding or a poor stream, which the parents may not notice, especially if they are in the nappies, or if they are they go to school and nobody bother to watch the stream or whether there is staccato voiding or not. So what we do is we give alpha blocker therapy. This is an alpha 1 blocker, so which has specific action on the bladder neck and the upper urethra. Terazosin, because that is what is FDA has approved so far. So we give a test dose of 0.02 milligram per kg, because there is a theoretical risk of creating a hypotension, even though it does not have a systemic effect. For this practice, I mean, we have been giving this for quite a long time now, almost for 10 years, but we had only one case in which there was a transient hypotension. So what we do is we keep the patient in our OPD after giving the test dose. tell them to wait for 2 hours after that, and if there and tell them to give a lot of water to drink. And if there is no hypertension, no problem, then they are sent home. They start with 0.04 milligram per kg. We call them back every 2 weeks because it takes about 2 weeks for the terazosin effect to come in fully. Then because the receptors has to be saturated, then we increase it by 20% each time till PVR becomes normal, staccato voiding or intermittent voiding disappears. So once that point is reached, we continue at that level. We may not have to give the maximum dose we can give is 0.4 milligram per kg. But what we have seen is most of the time we can manage with 0.2 milligram per kg. So you start with 0.02, go up to 0.2, but most of the time we don't need. Only very rarely we had to go up to 0.4 milligram per kg. We published an article with our experience in post-urethral valve. So we had 42 children, and we had about 95% of cases, about 40 patients with terazosin. The PVR was reduced more than 85%. And when we tapered the terazosin, the PVR came back again. So which means that it is a PVR, it is a terazosin that is reducing the post-void residue and not any other factors. So this is published in Pediatric Surgery International in 2009. There are other articles also which support our view. This particular article says that 60% decrease in reflux grade was observed in treatment group compared to 17% in placebo group. And this is because when you give alpha blocker, even in a primary reflux, it reduces the voiding pressure because the bladder neck opens up, and the moment it reduces the voiding pressure, naturally it reduces the reflux also. And over a period of time, if it's a secondary reflux or if it's a reflux due to a bladder neck problem, that tend to resolve itself. If there is diffuser hyperactivity, either clinically because there is wetting or UDS show hyperactivity, then we give oxybutynin. Our follow-up is we repeat when the patient is on conservative management, repeat DMSA scan after 6 months. If there is no scars, we continue with the management and repeat MCO after 1 year. And after 1 year, if it hasn't subsided at all, if it is reduction, we can continue more time. If there's no reduction in the grade, or if there is increase in the grade, then we take it up for surgery. If breakthrough infection occurs, then we repeat DMSA maybe a month after the infection to see whether new scars are formed. Coming to endoscopic management. Now, this is what the company has given me because I put it up so that nobody will say that I haven't done it properly. So you give an injection, this is a double hit. You give an injection into the ureter till the orifice is almost obliterated. Then you take out the thing and inject it peripherally under the ureteric orifice till a good mound, like a volcano, comes up. It should be really tense because there's about 20 to 30% loss of volume with time when you use deflex. So you just press it with the tip of the needle to see that it is really tense. Now, there are various studies on this, various publications, and all of them said there's about, like this study says, about 62.5% were cured with a single injection, 78 to 79% with subsequent injections. This study also said the same thing. Overall success rate was 67.2 and 85.9 after 2 injections. Now, this is a company pamphlet which I have put up because this is only what the company claims. Whatever you and me say is immaterial. Their study has shown that in a randomized study, 12-month success rate is 69% and non-randomized 54%. And second study of non-randomized is 60%. So that's what the company claims. So have no dreams about this efficacy. Now, there's another article that came up in 2012 with a double hit, which I was showing you earlier, is they said 93% clinical and 93% radiographic, intermediate, and long-term success rate. But I could not find another article that supports this finding. So that's it. Now we come to laparoscopic extravesical reimplantation. This is the port size. You start with 3 ports and put an additional port later on. I will show you in the video. An incision is made at the peritoneum level where it is going behind the bladder. So once the bladder is exposed, you hitch it up to the anterior abdominal wall. Then the vas should be reflected along with the peritoneum. Thereby, you are not devascularizing the vas. You mobilize the ureter carefully, close the urethral adventitia. And then once you have got enough length of the ureter, you can go around the ureter, not dorsally. I will come to that in a moment. And then create a submucosal tunnel. You just divide the detrusor so that the mucosa bulges out. Then I introduce a 4th port. The advantage is if you retract it, you'll be able to find fine strands going across the mucosa. And if you don't divide that, it may tend to strangulate the ureter. So once you've got sufficient length, you have to, as I say, extend around the ureteric hiatus, but no, don't go beyond that. Don't go more dorsally. Then you hitch up the ureter and make it lie on the submucosa, on the mucosa. The first suture is put on the top so that the ureter will remain hitched up. Then the rest of the, the detrusor is closed over the ureter. The peritoneum is closed, so there is no raw area that is left. Now, what I do is I give a little Lasix at the end of the surgery just to make sure that the ureteric tunnel is not very tight and the ureter is emptying properly. You can watch it here, the ureter getting distended and that empties into the bladder. These are the port size at the end of the surgery. Now, the articles published on laparoscopic extravesical reimplantation, there's 20 children, but they had the problems of mucosal perforation and 1 distal urethral necrosis. That is if you really devascularize the ureter towards the end. But the real problem with extravesical is the nerve damage. Now, the Fung reported he had about 26, that is 17 cases out of 90, only almost 20% needed catheterization for more than 2 weeks. It was lucky that he could remove the catheter after 2 weeks, but we don't know whether the children were having a subclinical neurogenic bladder, which in next 30 to 40 years will manifest as renal damage. So we don't know that yet. And then more research went into it, and listeners said the main portion of the pelvic plexus was located about 1.5 centimeter dorsal and medial to the uretrovesical junction. So we thought we know where it is, and so we can, if you avoid that, then we are safe. And he also said if you perform the dissection close to the urethral adventitia, following a cleavage plane of thin fibrous sheet termed mesoureter, there is virtually no risk of damaging the pelvic plexus. So everybody was happy with that. Then came this article in 2013 challenging this concept. He said, is pelvic plexus nerve documentation feasible during robotic assisted laparoscopic ureteric reimplantation with extravesical approach? And they found that even though the nerve fibers were visually identified, you are unable to consistently and reproducibly record compound muscle action potential after stimulation of protective pelvic plexus fibers at the dorsal ureter. And they said this may provide a reason to re-examine the intraoperatively expected location of pelvic plexus nerve fibers. So the bottom line is we are not sure where the nerve fibers are, where the plexus is, and which also means that the chance of the likelihood of damaging that is also high. Now, another difficulty is in PUV bladders, the mucosa is so adherent to the muscle, and there are so many diverticula, you may tend to open up the mucosa and create a leak. So we come to viscoscopic ureteric reimplantation. This is done through the bladder. The normal Cohen's reimplantation run through the bladder viscoscopically. And the Inderby Gill was the first to do it way back in 2001, almost 20 years back. What his technique was simple. He just cut the mucosa from the ureteric orifice to the proposed new ureteric orifice, and then buried the mobilized ureter in that trough and closed the mucosa over it. He had 3 patients and success rate in cure in 2, improvement in 1. Now, Kutikov picked it up in 2006 and he did it in 32 patients with a success rate of 92.6% and 80% for obstructive megaureter. The complications were urine leak in 12.5, stricture 6.3, and he had problem in smaller children or bladder capacity of less than 130 cc. But we have done it successfully in almost 70 cc of bladder capacity. Cystograms revealed a bladder leak at the camera port in 2 patients, at lateral port in 1 patient, and a neo-urethral anastomosis in 1 patient with POM and tapering. Now, important thing is all leaks at port sites were intraperitoneal, or you are landing up with a urinary ascites or a urinary peritonitis. Other problems were extravesical dissection of the gas, because when the gas escapes through around the trocar, it goes around the bladder and compresses the bladder from outside. So you lose volume within the bladder, and then you have to abandon the surgery or convert to open. And another problem is once this bladder slips out of the trocar, you cannot put the trocar back because your bladder cannot be distended again. So overcome this problem, people designed techniques, cystoscopic visualization of the refilling of the bladder. And then they put 3 ports, just like we put in the laparoscopy. The only thing is the camera was inside the bladder. So with visualization of the bladder, you just put in your ports and inflate the cuff and then pull it back so that the bladder remain attached to the anterior abdominal wall. The problem was the cuff ports are available only in 5 mm, apart from the fact that they are expensive. And 5 mm means you are making a larger hole in the bladder and increased chance of urine leak. So Ramajayanti came up with another technique. What it does is put in a needle and a loop through it, a proline loop through it. It goes into the bladder, and this is cystoscopic vision. Then he put in another needle like this through the loop, and he pass in a proline through that, and then remove the needle and pull the loop back. And so the bladder get fixed to the anterior abdominal wall at that point and where the ports are put. Now, the disadvantage is extra time required for cystoscopy, and this suturing is a little difficult. And the main thing I was worried about was a potential injury to the bowel. And when I say potential injury to the bowel, if you look at this video, this is a laparoscopic vision. As you fill the bladder, there is a recess coming up on the top of the bladder and also on both sides of the bladder. See, normally this space is occupied by bowel. Now there is gas, so everything has fallen back. But it's quite possible if you are going to put a trocar through this or a needle through this, you may go through the bowel that is lying between. That was a little scary. So we designed another technique, which many of you are familiar with. This is a patient position. You fill the bladder at about 20 centimeters of pressure, because I don't want to over distend the bladder, and you make the camera port 2 centimeters below the dome of the bladder. Lateral ports are made at the level of the anterior superior iliac spine. Then the skin and the fascia, subcutaneous tissue and fascia is cut, the muscle is divided. A curved dilator is passed from below through the urethra and made to point at that point. You can see the bladder wall coming up. So you know for sure there is no bowel in between, you are not damaging anything else. The bladder wall is fixed to the anterior abdominal wall. Then that bladder wall is incised, allowing the dilator to come out. And then your port, 5 mm port, is telescoped onto it and then taken into the bladder. So thereby you're sure that your port is in the bladder and nothing else is damaged. Same thing is done for the lateral ports. Here the ureteric orifices are catheterized with 5' feeding tube. The bladder is mobilized using a hook cautery. You have to be careful that you pull away from the ureter when you're doing this, because you should not accidentally touch the ureter or allow the current to pass through the ureter. And once sufficient length is obtained, you make a submucosal tunnel. And once this is made, you bring in a needle holder or a dissector from the other end. Earlier I was using dissector, now I am using a needle holder. You will notice at this point that the ureter has slipped down over there. So now what I'm doing is this: I bring out the ureter, I attach it to the detrusor at that point. This is another patient actually. And then before pulling through, I just cut that stitch. So this will prevent the ureter from slipping back. Now the ureter is pulled into the sac, into the bladder, and it is stitched, or it is attached to a detrusor at the point just below where you are wanting to cut it off. So the ureter is trimmed. You have to make sure at this point that it is bleeding from the tip. It's very important, because sometimes because of the excessive traction and dissection, you may have an avascular segment there, which may not be visibly noticed. Then the detrusor defect is closed, the mucosa is closed, and you put a Foley's catheter and the ports are removed. We normally keep the Foley's catheter for about 3 days, and then it is removed and the patient is sent home. Now, if you have a large dilated ureter, we can do plication and stenting through the same technique. You just attach this ureter to the opposite bladder wall like that, which will put it on stretch. And then you can do either a star plication or a Kalinske. I'm using Catgut here, but nowadays we are using 50 micro. I usually put a stent whenever I plicate, because it can produce some edema and produce some obstruction. If you have a parauretic diverticulum, that can also be taken care of. Like you catheterize, like in your normal case, pull out the parauretic diverticulum, incise it and excise it. And then the reimplantation goes on as earlier described. We published our technique in Pediatric Surgery International in 2011, and I'm sure many of you are doing it now. We have done about 118 cases in the last 5 years, that is 2016 to 2020, and the total number of units is about 184, and the youngest was about 3 months, and with a median of about 44 months of age. We had about success rate of 98.8%, which is not surprising or anything to take credit of, because what we are doing is actually basically a Cohen's procedure, which is a time-tested procedure. How do we follow up? We had to monitor bladder function, especially the PVR. Look for recurrent UTI. We had to tell the parents, because your surgery per se doesn't mean that the child is not going to get UTI. Child will get UTI till the dilatations have subsided and the bladder start functioning properly. So we have to warn them about that. We check the blood pressure regularly. And this is a formula by the American College of Surgeons, 80 plus age into 2. So that will be systolic pressure, and 2/3 of that will be diastolic. This is just a rule by the thumb. There are graphs to tell you exactly how much it should be and what is a normal range. But this is in the OPD. This is something which you can use. If it is above that, then you have to go back and check the graphs regularly. Of course, we monitor the renal functions with creatinine and blood urea. What are the long-term effects? Now, Jacobson studied 30 patients, and 10% of these patients had progressed to end-stage renal disease and 23% to hypertension at the time of follow-up. That is way back in 1918, and he said that, but nobody noticed it. Now, there are other papers that has come up, long-term effect. They noticed moderate to severe hypertension in 16 out of 88 patients. And 18% developed end-stage renal disease. Preeclampsia occurred in 18% of women. This we don't, as pediatric surgeon, we don't come across this, because the patient pass out from us, they graduate to the adults, and adults are not aware of the problems of a childhood pyelonephritis. So they also don't check the BP, they also don't check the renal function till the patient goes into renal failure. This is another study, long-term effect follow-up of adults with reflux nephropathy. 38% hypertension and were on antihypertensive therapy. 24% had creatinine clearance less than 70. 15% had urinary tract infection. 18 patients suffered from urinary calculus. So reflux is not something that we have to take lightly. Reflux is something like a cancer which eats away the kidney gradually. Child may be symptomatic or he may not notice a symptom till we come to an end point where we need a renal transplant. So I think this is a message we have to pass on to our pediatric medical colleagues as well as our adult urology colleagues, that if you get a patient with pediatric pyelonephritis or pediatric urinary infection or pediatric patient with reflux surgery done, look for renal failure, look for blood pressure. That's all I want to leave with you today. Thank you.
Over to you, Ramador sir.
Thank you very much, Mohan Abram sir, for a wonderful disposition on your journey in management of vesicular reflux, your thought process, and the way things you have developed over a long period of time. It's been really an eye-opener for many people and encouragement for many youngsters that there are many things which they can do, and make sure that you do the things the way you want to do it and develop it the way you want to develop it. The technology is available for all of us for many years now. Making a rational use of technology and giving the best to your patients is what will make us unique as a specialty. So thank you very much for your wonderful oration. As is customary, we do not have a question answer session after any oration. A big round of applause, ladies and gentlemen, for Dr. Mohan Abram for a superb oration. We will all remember this for a long time. Thank you.
Thank you. Thank you.
Thank you, sir. Thank you so much. So, President sir, with your permission, I would like to end this oration session now.
Yeah.
We will be starting the conference inauguration program exactly at 11:30, which is the scheduled time. Dr. Karad has already joined in the room. Madam Deshmukh is already there. We will just take 5 minutes to set up things, and we will start sharp at 11:30.
Yeah, sure. I would like to welcome Karad sir and Deshmukh madam for the inaugural function. Thank you very much for taking your time out, and we will start in a short while after setting up the podium. Ravi, over to you.
Yeah, so we'll take 5 minutes. Everybody can stay where they are and give us some time. 11:30 we will start.
In the meantime, the panelists can have an informal discussion by the time we are ready. So thank you, madam, for joining. Thank you for taking time out from your busy schedule. And I'm glad that you are here.
Thank you for inviting me.
Madam, you are my teacher and guide. And you are teacher and guide to Dr. Karad sir also. So you have to be here.
I'm seeing madam after ages. The last I saw was in the Bombay conference where Dr. Kapoor was the organizing chairman.
No, Partha, madam had also attended the Golden Jubilee conference at Bombay in 2015. You were there.
Yeah.
Yeah.
मैडम राहू देख, हाँ राहू देख मतलब
We have another 7 minutes to go. 1 minute to go. Hall coordinator, can you add the spotlight to Dr. Karad's video as well?
Sure, sir.
President sir, it is time now. Do I have the permission to start the proceedings?
Yes, Ravi, please get started. I think we are on time.
Yeah, thank you, sir. Respected senior members of IAPS, dignitaries present in the forum, delegates of E-Iapscon and friends, I welcome all of you to this inauguration program of 47th Annual Conference of Indian Association of Pediatric Surgeons. This is our second virtual conference, and as a tradition, we are conducting this virtual inauguration ceremony. Had this been a physical conference, we would have done this in person, but the pandemic has forced us to adopt this form of organizing the conference. So I would now like to invite the dignitaries to be seated on the dais. So I would first invite our chief guest, Dr. Bhagwat Krishna Rao Karad, who is the Minister of State Finance, Government of India. He is a cabinet rank minister. Our guest of honor is Dr. Snelata Deshmukh, past president of IAPS and a very senior member of IAPS. Madam, welcome. Dr. Ravindra Ramadwar, President IAPS, and Dr. Amar Shah, Joint Secretary IAPS. I welcome all of you, and please accept our virtual greetings and felicitation for this event. So as a tradition, before starting any academic meeting, it is customary to invoke the blessings of Ma Saraswati. I would now invite all the dignitaries on the dais to come forward for the lamp lighting. We will be doing this virtually. So I will be playing a small clip to symbolize this step.
या ब्रह्माच्युत शंकर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्म विचारसार परमा आद्यां जगद्व्यापिनीं वीणा पुस्तकधारिणीम् अभयदां जाड्यान्धकारापहा हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम्।
Thank you. Thank you for lighting the lamp. I will now introduce Dr. Ravindra Ramadwar, President IAPS. He, although requires no introduction to the fraternity of IAPS, but I would try and make an attempt towards this. He is a well-trained and avid laparoscopic surgeon. He has been a mentor and a great human being. He has experience of more than 30 years in his field of pediatric surgery and pediatric laparoscopic surgery, and has got several surgical firsts to his credit. He left a well-settled permanent job in London to come back and serve his countrymen. He has been the past chairman of PESI and has frequently demonstrated in operative workshop across various forums and has been a flag bearer of IAPS for past many years now. Sir, I invite you to deliver the annual presidential speech for the E-Iapscon 2021. Thank you.
Thank you, Ravi. Respected Chief Guest, Dr. Bhagwat Karad, sir, Honorable Minister of State for Finance, Government of India, who is also a senior pediatric surgeon from Aurangabad, which we are very proud of. Respected guest of honor, my teacher and guide, Professor Dr. Mrs. Deshmukh, who has been my teacher and professor of head of Department of Pediatric Surgery at KEM, as well as Dean of Sion Hospital, where I did my MCH. And I was the first student of the department, which I am very proud of. And she was also ex-Vice Chancellor of Mumbai University. Distinguished guests, my teachers, seniors, juniors, and dear friends. I welcome you all for the 47th Annual Conference of Indian Association of Pediatric Surgeons. At the outset, I offer my congratulations as well as a very sincere gratitude to the organizing team of the E-Iapscon 2021, which they are doing it for the second time. So they conducted the E-Iapscon 2020 as well as E-Iapscon 2021, the only team ever to be executive committee members as well as the organizing committee of any conference, led by our young dynamic secretary of IPS, Dr. Ravi Kanodia, dynamic joint secretary, Dr. Amar Shah, and the entire young, enthusiastic, and motivated members of the executive committee for excellent organization of this entire conference over a period of 8 days in 2 subsequent years. Fantastic job, guys. Well done. Very, very proud of your achievements. Last year, we conducted series of webinars from national and international speakers. The 46th annual conference was also conducted online under the leadership of past President Dr. Partha Pratim Gupta. Combined online elections of Indian Association of Pediatric Surgeons and 3 chapters of IAPS, namely Pediatric Urology, Pediatric Endoscopic Surgery, and Pediatric Oncology, were conducted successfully as a combined episode for the first time online. When I took over presidentship, many activities were planned and goals were set up. I'm happy that despite all the issues of COVID pandemic and subsequent lockdowns, our IAPS Executive Committee did a wonderful job. Our secretary will give a very detailed report of that during the general body meeting. However, some of our noteworthy achievements are regular monthly newsletter of IAPS despite all the issues, giving updates and publication of standard treatment guidelines for pediatric surgical conditions, keeping in mind variations in infrastructure across the country. These were prepared with the help of many members of IAPS. We hope these guidelines will be adopted by the National Medical Council and will provide standardized care for pediatric surgical conditions across the country. They also compiled 150 patient parent information sheets in 10 different languages of the country to make it very easy for parents to understand what the child is suffering from. Guidelines for pediatric surgeons. One of the wonderful achievements was a mapping of pediatric surgeons across India to help us identify states and districts where there were no pediatric surgeons. And this is very, very important, useful information for junior colleagues whenever they want to start their career. Another most important landmark was a breakthrough in getting insurance cover for neonatal surgical conditions. This was achieved in the private insurance sector with Star Health. Myself, Dr. Ravi Kanodia as secretary, Dr. Amar Shah, Dr. Ramesh Babu, his wife, Dr. Madhumati, who is a pediatrician and is a vice president of, had a long meeting to discuss this issue. I am glad that we were able to convince Star Health to come up with an insurance policy that will cover all congenital anomalies, whether internal and external, from neonatal age group. The proposed policy is already with IRDA awaiting clearance. Once it is cleared by IRDA, I am sure other insurance companies will follow the suit. This, we all believe, will be the game changer for providing quality services for neonates and infants. I would like to request our Honorable Finance Minister, Dr. Karad sir, to help us in getting the insurance for all pediatric surgical conditions from all the insurance providers. The Executive Committee managed to send birthday cards to every single member who is on the database of IPS. So this was a very, very welcome gesture for the last 2 years. A tradition started by my predecessor, Dr. Partha Pratim Gupta. Pediatric Surgery Week celebration has been going on for many years, and last year we focused on antenatal diagnosis of congenital malformation with the preparation of posters for display in hospitals, OPDs, and private clinics. We also made a table calendar to be distributed to general practitioners, pediatricians, and obstetricians to create awareness in general population. We had a meeting with NITI Aayog member Dr. Vinod Paul, which was organized by Dr. Meera Luthra and Dr. Ketan Parikh, to discuss funding for pediatric surgery procedures for under various schemes like Ayushman Bharat, RBSK scheme, for which Dr. Ravindra Vora has been working for last almost 10 years trying to get some coordinated effort into that. CGHS schemes, various state government schemes, etc. The problems of differential procedure charges as compared to adult procedures, delays in payments to the hospitals, private hospitals not paying treating surgeons, etc. were discussed. The difference should be based on whether the services are provided in small hospitals, NABH accredited hospitals, JCI accredited hospitals, as well as the overheads will be different if the hospitals are in a town, in a city, or a large city, or a metro. So all these issues were discussed at length for almost an hour with him, and there have been certain guidelines which we have going to come up with. There was a proposal of formation of Academic Council of IAPS to address issues related to curriculum, various courses, and fellowships in pediatric surgery, and to approach National Medical Council and National Board of Examination with many suggestions to popularize pediatric surgery. A very interactive website of IAPS is still under development, which will have all the information which patients would require in the form of information leaflets, directory of pediatric surgeons near their home, all the newsletters, a specific members area with important documentation and information, as well as an arts and music corner. We also managed to update our IPS directory, which was circulated to all members last year. I'm extremely proud of what we have been able to achieve in these last 2 years. The current executive team is fantastic. These youngsters have done a wonderful job since last 2 years during the ongoing COVID pandemic. Despite their hospital commitment, despite doing COVID duties, looking after families, patients, as well as society. They are the future leaders of IPS. We must encourage them and nurture their talent. Please give them a big round of applause. Dear friends, we all know that every year 2.8 crore babies are born in India. Approximately 4.2 lakh neonates will require surgical intervention every year. The last census has shown that in our country, there are 52 crore children below the age of 18. Excluding cardiac and neurosurgical diseases, approximately 4.7% of this population, that is 2.5 crore children, will require pediatric surgical care every year. Our infrastructure is not ready at all. And we will need to really boost to provide world-class treatment to all the children across the country, whether they are in metropolis or whether they are in a village. We request our Honorable Minister, Dr. Karad sir, to help us in communicating this vital information to our Health Minister, to emphasize the need for setting up the pediatric surgical services and to help us in coordinate with Planning Commission, that is called as NITI Aayog these days. The way forward for pediatric surgery, as I see it, is one, increase the number of departments and MCH and DNV pediatric surgery seats. Start 6-year course. The proposal for this is already submitted to the National Medical Council by Professor Minu Bajpayee and his team. The proposal is with the President of Postgraduate Medical Education Department awaiting their clearance. Convince Director of Medical Education and Research of every state to remove requirement of compulsory bond for MCH pediatric surgery, because that seems to be the main stumbling block for students joining MCH these days, because they are doing 3 years of bonded service to the government. To attract trainees, we have to encourage juniors, give them freedom to choose their specialty and work towards it. We have to work with the central and state government to create more jobs for pediatric surgeons right up to district levels. We have to expand the horizon of pediatric surgery by including adolescent care for complex congenital malformations, because as we know, once they grow beyond the age group of pediatrics, the adult surgeons are not really keen to look after these complicated cases. They are interested in very simple, quick answer cases. So we need to really grab this area, which is a completely neglected field. The teaching departments in various medical colleges should try and raise the age limit from 12 years to 18 years, and maybe, as I said, include adolescent surgery also. We must encourage rotation of trainees in different departments to expose them to different subspecialties, including pediatrics and NICU care. We should also encourage good clinical and laboratory research. We need to create some glamour around our specialty, and we have Karat sir, we have Deshmukh madam, we have so many seniors to create that kind of a glamour around our specialty that will help us in kind of making the specialty as a very popular specialty. We must identify more young individuals who can actually do this job of glamorization of our society. We should delegate responsibility to young, enthusiastic, interested members. They can be junior members in department or private practice. It doesn't matter what they do, but they are interested in developing our specialty, and we must encourage them. We have to create an all-inclusive, healthy atmosphere in the IAPS. And this is something which we all have to work for and maintain the decorum as well as the sanity and common sense to run the departments and to run the association to make sure that this becomes one of the best associations in the country. Every year, some ongoing projects will be completed, like we completed some new projects will be started, which will have to be carried forward by the subsequent president, secretary, and the executive committee. I believe that a continuous progressive path taken by IAPS will go a long way to make a very impactful organization. At this stage, I would like to thank IAPS Executive Committee members who have been dear friends, and I hope the friendship lasts for life. Senior members of IAPS like Professor Ravi Kumar, Dr. D.K. Gupta, Dr. Minu Vajpayee, my very close friends, Dr. Rasik Shah, Dr. Ketan Parikh, Dr. Ramesh, Dr. Prakash Agrawal, Dr. Raju Savji, Dr. VVS, Dr. Kishore Panjwani, and many more colleagues across the country to help me in making my year as IAPS president very smooth and successful. Everyone's blessings and encouragement has helped me in doing some activity and helped me to grow as an individual. I thank everyone for that. At the end of this conference, the new executive committee will be elected under the leadership of President-elect Professor Yogesh Sareen. My best wishes to Professor Yogesh Sareen and the new incoming executive committee for a very productive, fruitful year ahead. Long live IAPS. Jai Hind.
Thank you, sir. Thank you, President. I will now introduce and invite Madam Deshmukh to speak a few words of wisdom to the audience. So, Madam Deshmukh does not require any introduction to the fraternity of IAPS, but I will still complete the customary ritual. Madam Deshmukh is an eminent pediatric surgeon of India. She was a pioneer and one of the founders of the neonatal department of KEM Hospital. Madam Deshmukh was born in Ahmednagar, Maharashtra, and her father was also a surgeon at Lokmanya Tilak Hospital, Sion in Mumbai. Following her father's footsteps, Madam climbed even higher peaks of success. She is a graduate from GS Medical College, and in final MBBS, she stood first among all the students and wanted to become a cancer surgeon, but eventually pursued further education in pediatric surgery at GS Medical College. After completing her education, she gained a reputation as a renowned surgeon. She also received many honors in the medical field. Around the age of 50, she decided to step into the field of medical administration. For this, she went to Delhi and completed the course of medical administration. In 1990, she joined Lokmanya Tilak Hospital in Sion as the dean. During her 5-year career, she focused on creating the necessary facilities for patients and doctors. During her tenure, the work of the Research Society was given special priority. She was instrumental in setting up the milk bank called Breast Milk Bank for mothers who are unable to breastfeed their newborn due to medical reasons. This dairy bank is a boon. The incidence of malignomyelocele was very high in Dharavi slums. During her tenure, Madam and other doctors at Sion Hospital worked on the issue and proved that this was caused by deficiency of folic acid in the mother's body. After that, folic acid tablets were distributed to pregnant women in Dharavi. Madam became the Vice Chancellor of the University of Mumbai from 1995 to the year 2000. She is a BC Rai awardee in the year 1998 and Dhanvantari Award in 2005. She has been the past president of Indian Academy of Pediatrics, Association of Surgeons of India, and Indian Association of Pediatric Surgeons. We see her as a mother figure in the fraternity of IAPS, and she has always blessed us with her presence and guidance. Madam, thank you very much for gracing this occasion of IAPS inauguration. I would request you to kindly give us your blessings and speak a few words. Please unmute.
Ravi, ask the host to unmute, madam, please.
All coordinator, please unmute, madam.
Just a minute, sir. Ma'am, please unmute once, please. Ma'am, there's a button at the bottom, ma'am, on the left corner for the unmute, ma'am. So please hold, sir. Ma'am, there is a.
If there is somebody around, madam,
Yes, please get some help. Just give her a few minutes. I think the coordinator should be able to unmute the host.
No, sir, we cannot unmute.
We cannot button on her computer screen.
Can you hear me now?
Yes,
Yes.
madam.
Yeah. Sorry for the delay of a minute. And I will speak less for 1 minute to compensate this delay. Well, ladies and gentlemen, the chief guest of today's function is a very, very dear friend of mine. So people say that he's my student. Actually, I learned a lot from him. How to come to a conclusion, how to see that life is very important and to have this life for the children. He has selected an area of politics rather than being only a pediatric surgeon. Congratulations, he is not only an excellent pediatric surgeon, he had his own hospital at Aurangabad, which I happened to inaugurate. After that, the hospital functioned very well. He was a great help to many children, but as luck would have it, he chose to be more successful in not only creating a hospital and seeing to it that he helps children to live a normal life. He felt that he can create a lot of other things by being in the finance as a minister. So congratulations, Dr. Karan, for being a minister of finance. You could have been a minister of health, but I think more than health, finance is more important nowadays. So we expect a lot from you. Ravi Ramadwan, another student of mine. So in Sanskrit it is said, Shishya Ichet Parage. The Shishyas are more important than the teacher. So you both have made us very, very happy, and you are looking at your success. I feel great. I feel that I have achieved something in my life, because it's not only the surgery that matters, it is creating good surgeons that matters to me. So I have been able to create good, not only good surgeons, but good human beings. We are both great human beings. Ravi, I know you are in Mumbai, so I come in contact with you many more times than I could to contact Dr. Karaj. But whenever I phone up Dr. Karaj, he leaves everything else and answers my phone call. That is a quality. Otherwise, I have seen many ministers. I have even met the chief ministers. But Dr. Karaj is an excellent human being. So that quality is very important. In children, it is said that with no language but a cry, they tell Mr. Surgeon. It's always Mr. Surgeon, whether the surgeon is a lady or a gent. It is Mr. Surgeon. Look, Mr. Surgeon, correct my abnormality at the first time. Give me proper amount of fluids. Give me proper amount of blood and be a good human being to understand what difficulties I have. And that is why Karad and Ravi have become excellent surgeons. Dr. The secretary, the joint secretary is the son of my very dear colleague, Anirudh Shah. His name is Amar Shah. So he is also set up a very good hospital at Ahmedabad, and I had the pleasure of inaugurating his hospital. I didn't inaugurate. It was the Prime Minister, Mr. Modi, who inaugurated the hospital, but I happened to be there. It's a very nice hospital with all amenities, and what is most important is the family is together. The father feels that my son should achieve much more than what I achieved, and his mother takes care of him. So it's an excellent family. Do visit their hospital and do visit their family whenever you are in Ahmedabad. You will learn a lot as to how the hospital should be, how the staff should be looked after. What is very important is the nursing staff, the menial staff, which contributes a lot to the life of the child. I myself learned a lot from the nursing staff. At present, the work that I am doing is called the Garbha Samskar. That is, you all do fetal surgery, but we do fetal samskar. Samskar is something which is different, and it's in Sanskrit, it is samskar. The importance of Sangeet, that is music, was found out by our nurse. 2 groups we made of very low birth weight children. And when we made these 2 groups, the first group was given everything, that is medicines, injections, milk, everything. The second group also was given all this, but we also put soft music whose beats increased slowly. And that group put on more weight earlier by about 12 to 15 days. So I was surprised that is it the music that has done this trick, or what is it? But my nurse was very intelligent than me. She said, "Madam, I have this observation. Whenever this group is given milk and the beats of the music increase, their sucking reflex also increases. And that is why probably they have put on more weight now, earlier than the first group." What an observation. So it is the observation of the pediatric surgeon, the pediatric physician, which is very, very important. So not only examine the child, not only treat him, but observe what actually is more important to him. That is what I wanted to say when I saw Dr. Karad here. Dr. Karad is a thinker. He is a great thinker. He keeps on thinking of everything and comes to a conclusion. So that is a quality of a good doctor. When I was writing a book on In Search of a Good Doctor, I wrote that thing which Dr. Karad does always. He thinks ahead of time, and that is why he has reached this stage. Similarly, Ravi Ramadwar also continuously thinks. He reads, he writes, thinks, and it is the thinking which our previous president, Dr. Abdul Kalam said. Abdul Kalam said, "Thinking is our capital. Entrepreneurship is the way." and hard work is the solution. So all these three qualities should be there in a pediatric surgeon. Ladies and gentlemen, I have taken a minute more, so I promise that I'll speak less. I've taken a minute more. I have come here to bless all of you, to give you all the blessings, and that is why the blessings are in again Sanskrit. Tushtirastu, Pushtirastu, Arogyamastu. What is very important today, it is not Tushti and Pushti, it is Arogya which is important. In days of COVID, it is the Arogya which is going to steer you through all these problems. Ladies and gentlemen, let me appreciate all your efforts that you have put in and the younger team that is going to put in more. So we learn a lot from the youngsters. Today, I have learned a lot when I listened to Mohan Abraham in his speech. Another thing which I want to appreciate very much is the CME of this conference was outstanding. I have never heard a CME. I have been attending all CMEs online. I have never heard such a CME, which was very well organized, well thought of, well executed, and very useful to the youngsters. So Ravi, continue your efforts, though you may be a past president now, but continue your efforts towards the betterment of the society by contributing to the pediatric surgery. Thank you very much.
Madam, thank you so much. Thank you for your blessings. Thank you for your words of wisdom. And we always see you as an inspiration. Thank you very much. So I will now introduce our chief guest, Dr. Bhagwat Krishnarao Karad. Dr. Karad is a cabinet minister in Sri government. He's serving as the Union Finance Minister of States in July 2021. He's a member of Rajya Sabha from the Maharashtra state since August 2020. He also served as a member of the Parliamentary Standing Committee of Petroleum and Natural Gas and Consultative Committee on Power, New and Renewable Energy. He is the most qualified member of the serving Union Cabinet and has been a medical practitioner for 4 decades. Born and raised in Chikli village in Latur district of Maharashtra, Dr. Karad completed his school education in his village itself amidst hardships. His father was a farmer and he could earn barely for sustenance of his family. However, Dr. Karad's thirst to gain knowledge pushed him to walk 5 kilometers daily to attend school and to reach where he is today. He is the first pediatric surgeon and the highest qualified one from Marathwada region of Maharashtra. During his electoral and political journey, Dr. Karad had held several important posts in his journey. The list is endless and I may not be able to mention all in the given time, so I will just mention the major undertakings by him. He served as the mayor of Aurangabad Municipal Corporation. He was the house leader of Bharatiya Janata Party in Aurangabad. He was the general secretary of BJP Aurangabad district. He was the president of BJP Aurangabad from 2001 to 2004. And he served as the secretary and vice president of BJP Maharashtra from 2014, 15 and 2015-20 respectively. For us, sir, we see you as a member of the IAPS fraternity, and we thank you for joining this congregation today. Sir, we now request you to address the gathering as the chief guest and bless the audience with your words of wisdom. Thank you, sir. Thank you for joining us. Over to you.
On the occasion of inauguration of Indian Academy of Pediatric Surgeons 2021, the chief guest or guest of honor, Honorable Srimati Madam Deshmukh, Honorable Chairman of IAPS, Dr. Ravi Ramadwar, Honorable Secretary Ravi Konzoria, Joint Secretary Dr. Amar Shah, Dr. Totla joining from Aurangabad, and all my dear colleagues. I am really happy to join this conference after a long time. Few years back, we have taken a master chapter quarter in conference in Aurangabad. But I was listening about the madam's speech, and she is a great lady, great teacher. I remember when I was in the pediatric surgery department, she was taking care of all the resident doctors, and she was teaching very well. In those days, when I have done MCH from KEM, Professor late Dr. R.K. Gandhi and Dr. Madam, they have started a neonatal surgery intensive care unit, I remember. And it was the first of kind in the country. But now, the pediatric surgery has developed very well, that I will come later on. Madam has trained almost more than 100 pediatric surgeons all over the country, and she has seen that all the inaugurations of the hospitals, she used to go for inaugurating the hospital. Not only that, I remember some patients come to the Mumbai in KM, then she always tell to the patients that their pediatric surgeon is available in Aurangabad, and you can do all these things there also. So I remember some patients coming from Mumbai KM to my hospital for the treatment. But I, as her student, we have always maintained Guru Shishya Parampara. Always I respect her, always I call her, I even try to meet her also. As mentioned about me, I was mayor of Aurangabad twice. I was deputy mayor of Aurangabad also. But when I used to go to the hospital, I always feel bad because I have left the medical science and I am doing the politics. But it was my fate in politics. Anyway, because of the Honorable Prime Minister's Ashirwad, I am now in his cabinet. I am really proud that the population of our India is around 135 crore, and he has selected 75 persons or 75 ministers, and I am one of them. Not only that, he has selected 8 persons from the Maharashtra, and the population of the Maharashtra is around 12 crores, and I am one of them. As Madam said, when the list was declared ministers, I was expecting that Honorable Prime Minister will do me the health minister. Because there are 3 doctors. One doctor is MBBS, other doctor is MBBS DGO, and I am MBBS MS MCH. So I am the senior most doctor, and the health portfolio will be given to me. But the portfolio which is given to me is a finance, and it is a very, very important portfolio. It is a number 2 portfolio in the ministry. Just I want to tell about my portfolio. The budget of this country is around 35 lakh crores. So we have to handle this 35 lakh crore every yearly. The health budget, it is around 2.34 lakh crore. So anyway, although I am not directly attached to the medical field, I can say, but indirectly, as Madam said, I am almost attached to all the health activities that I used to go to the health minister and deputy health ministers also. In those days, the pediatric surgery was unknown in our area. I remember when I started my practice, when I used to go to the MBBS doctors to tell them that I have started a pediatric surgery, they were not knowing what is MCH, what is DM. They used to say, you have done MBBS, DCH, and then you have done MCH, like this. They were not knowing the MCH degree also. And it was a raw area, means Marathwada and some other surrounding, part of the Vidarbha, part of the North Maharashtra, part of the Paschim Maharashtra. So I used to get patients from the 14 districts. So it was a really pleasure. I used to operate around 4 to 5 patients per day in private hospital. But fortunately or unfortunately, I am in the politics. Now I am in the माननीय मोदी साहब के कैबिनेट में मैं हूँ. तो मैं इतना ही बताना चाहता हूँ. यहाँ जैसे मैडम बोला कि जो कुछ है मैं सोच के ही करता हूँ, और यहाँ भी एक मैं परफॉर्मेंस बताऊंगा. अभी जो प्रेसिडेंट हमारे बोल रहे थे कि जो इंश्योरेंस के बारे में बात कर रहे थे, तो आई एम इन द फाइनेंस डिपार्टमेंट and our finance minister, Madam Nirmala Sitharaman, has given me the Department of Financial Services. That includes all banks and all insurance. So there was a reference of IRIDA. So IRIDA is under me also, under me only. The IRIDA chairman, MDs and everything, they are working under me. So naturally, whatever the problems of the insurance of the pediatric surgery or neonatal surgery, I will try to help them. The other things which were mentioned by the Honorable Chairman, that is National Medical Councils, National Boards, then Health Ministry, Niti Aayog, all these peoples are part of our Ministry of the Government of India. So naturally, anybody from our members or from the body, that I will be able to contact with them and I will be able to help them. In our days, the fetal surgery, laparoscopic surgery, minimum invasive surgery, robotic surgery, artificial intelligence was just a dream, but now it has become fully operational and a reality. There are a lot of advances in pediatric surgical techniques. So I feel very happy to learn that their advances are there in the pediatric surgery. As I am a minister of state minister, somebody referred me as a cabinet minister, but I am not a cabinet minister. I am a state minister of finance. So naturally, I am sitting in the Mantralaya now at present, and 4 days I sit in the Mantralaya only. One day I go to the different states, and probably Saturday, Sunday, I remain in the Aurangabad for the local constituency. Just I want to mention that although I am a minister, although I am in parliament, but I am attached to the ground. So I know the difficulties of the poor people. I know difficulties of the farmers. I know difficulties of the laborers. So I am here to solve the problems of all these people. At the same time, I know difficulties of the learned people also. So naturally, the knowledge which I have got from our Department of Pediatric Surgery under the guidance of the Deshmukh Madam, all my colleagues, so this will be help to increase the health paternity of our country. And here we are very much guided by Honorable Prime Minister. Yesterday we had a meeting of 4 hours under his presidency. So 15 days, every 15 days, he guides us. Naturally, any problem in health, they ask me also. So on this occasion, just I congratulate all the office bearers, Mr. Chairman, Dr. Ravi Ramadwar, Secretary Ravi Konzaria, Joint Secretary Dr. Amar Shah and his team, congratulate them and wish them for a good conference and good CAB. And I declare that the inauguration of this conference is done. Thank you very much.
Thank you, sir. Thank you for your words of wisdom. Thank you for your blessings. So I will now invite Dr. Amar Shah, our Joint Secretary, to give a vote of thanks. And then after that, we will have the national anthem. Dr. Amar, over to you.
Good afternoon. Honorary Chief Guest and Minister of State for Finance, Dr. Bhagwat Karad sir, respected Madam Deshmukh, our guest of honor, IAPS President and Organizing Chairman of E-Iapscon, Dr. Ravindra Ramadwar sir, immediate past President, Dr. Parth Pratim Gupta, IAPS President-elect, Dr. Yogesh Sarin, IAPS Secretary, Dr. Ravi Kanojia, all our Executive Committee members, senior members of IAPS, and all the delegates attending E-Iapscon 2021. Good afternoon, everybody. At the outset, I would like to thank our chief guest, Dr. Karad sir, for taking the time out from his busy schedule and honoring us with his presence at this meeting. It is really a proud moment for us, sir. Not only the entire organizing committee of E-Iapscon, but the entire Indian Association of Pediatric Surgeons to have you amongst us. Thanks a lot, sir, for all your appreciation for our hard work and efforts. Special thanks to Madam Deshmukh for kindly gracing this occasion. Madam, you have always been a great source of inspiration to many generations of pediatric surgeons, and your words of wisdom and advice have helped us to guide through tough times. Thanks a lot for your kind words and appreciation for me and my family. As our president, Dr. Ravindra Ramadwar, said earlier, the last 2 years have been extremely challenging for all of us. The present executive committee of IAPS was also no different. However, under the able guidance of our presidents, Dr. Parth Pratim Gupta and Dr. Ravindra Ramadwar, and the enthusiasm of the entire executive committee, we could successfully accomplish more tasks than we had planned during our tenure. Dr. Ravi Kanodia would of course give details of the same in his secretary's report. I would like to convey my heartfelt thanks to all the presidents and the entire executive committee for being there for all of us. We have been fortunate to organize 2 back-to-back E-Iapscons, which is one of the firsts in the history of the Indian Association of Pediatric Surgeons. Last but not the least, I would like to specially thank the IAPS secretary, who is one of my closest friends, Dr. Ravi Kanodia, for the exemplary work that he has done over the last 2 years for the betterment of IAPS. He is indeed a technological wizard and has raised the bar very high for his successors. May I request a big applause for this very hardworking man. And finally, thanks to all the IAPS members for your help, support, guidance, and positive criticism during our tenure. This has helped us to bring out the best in all of us. We will continue our efforts for the betterment of our association. Thank you all. Thank you very much. Jai Hind.
Thank you, Amar. Thanks a lot. I would request the hall coordinator now to start the national anthem, and we will all rise for the national anthem. Hall coordinator, there is no sound in this clip. Share the sound.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे।
Thank you, everyone. With that, I would request the President Ramadwar sir to allow this session to be closed. President sir, if you have any remarks or anything to say, you can say now.
Yeah, Ravi, I think we are well in time, so extremely well done, guys, everybody. Really appreciate Madam Deshmukh and Bhagwat Kara sir's input. And we really look forward to developing pediatric surgery as we all have in our minds with their blessings and guidance. Thank you, everybody, for coming for this session. I declare the session closed.
Thank you, sir. Thank you, everyone. So we will reconvene. This online room is going to stay open, and we will reconvene for the post-lunch session. We will be running two parallel halls after 2 o'clock. Hall A will have the urology presentations, and Hall B is going to have the neonatal surgery, trauma, and robotic surgery sessions. So hall coordinator, you can run the conference slide and leave the room open. We will reconvene at 2 o'clock. There will be a commercial presentation from one of our sponsors, Bluenem, at 2:15.
Yes, sir.
thing came on the top and it covered my entire
Hi, good afternoon. Can I talk to someone from the host team, please?
Yeah, hi, good afternoon, ma'am.
Hi, I just needed to confirm the time for the urology session. We start at 2:25, right? There is a sponsor lecture between 2:15 to 2:25?
Yes, ma'am.
Okay, fine, great. Thank you.
Hello, just confirming if you're able to hear me.
Yes,
Yes,
Dr.
Vishnu.
Vishnu, we can hear you.
Thank you so much.
Ravi, sir, good afternoon.
Good afternoon. I just finished my lunch. Sorry, I'm a little late.
No worries, sir.
Good afternoon, Dr. Ravi.
Hi, good afternoon, Mr. Vishnu.
Good afternoon, Dr. Saha. Good to
Yeah,
see
good
you.
afternoon. Good afternoon. Yeah. We have not received the judging sheet yet. I mean, is it, are we supposed to judge?
Yeah, you are the.
I have sent an email to all the 3 judges. Please check your email, check your spam folder also. I have sent it on 3 occasions actually.
I found the link for the joining. Okay, I'll just check. Okay.
So it's just because that I am sending out so many multiple emails. It
Okay.
in that
No.
list. Have a look. Search
Yeah.
for score sheet Ravi Kanodia. Put that in the search bar.
Right.
Hall coordinator, can you let me in on the hall B side also?
Sure, sir. Sure. Can you just please raise your hand, sir?
Yeah, I did.
You must have got the request, sir.
Thank you. Thank you.
Sure, sir.
So we have another 2 minutes to go, Mr. Vishnu. We'll start the way we discussed.
Sure. Dr. Ravi, I found these things. I found definitely 3 mails with the joining link, but
I'll send again. I will send again. Don't worry.
yeah, okay.
Virendra, do you have the scoring sheet?
I have mine, so yes.
I have sent you for this session also. I think the 3rd judge is missing.
Okay.
That he won't be able to join. So you can mark the papers for this session and act as the 3rd judge.
All right, sir.
So the 6th speaker, Dr. Kanishka Das, will also not be joining, sir.
Okay.
Okay.
Okay, so let us start. This session we have kept as a special session for our sponsors. So BlueNem is our prime sponsor for E-Iapscon 2021. Let me just say a few words about BlueNem. We have the chairman and the managing director, Mr. Vishnu Bhatt, with us. BlueNem Medical Devices is an India-born medical device company producing world-class products in India. It is headquartered in Bangalore, and they are a recognized brand in urology and interventional radiology. And they are now venturing into the area of interest for us, that is pediatric surgery. And I've gone through their brochure and their catalog and the portfolio. There are a lot of things which actually are in our daily use from the urological procedure point of view. DJ stents, catheters, and other PCNL sets. And there are so many things actually. So probably Mr. Vishnu is going to apprise all of us about their product portfolio. I will hand over the stage to Mr. Vishnu for his presentation. Thank you, Mr. Vishnu. Please share your screen and start your presentation.
All right. Thanks a lot, Dr. Ravi, I'll just share my screen. Are you able to see my screen?
Yes, sir. It's perfectly visible.
Okay. So, Dr. Ravi, first of all, thank you so much for this opportunity and good day to all of you. It's really wonderful to be amongst you. And thanks a lot for this opportunity to talk to you all. First of all, our salutations and regards and our sincere heartfelt appreciation for all the things that you do, the pediatric surgeons of this country. You are indeed a unique group of surgeons, and when I look at the different practices that we work with, and especially when I think about the pediatric surgeons of this country, you're indeed a unique community of doctors and surgeons. You're unique because you deal with children. Children who are darlings of our lives today and the future generation of this country. And this is something which actually has its own uniqueness to it because you deal with very young lives. They can't speak for themselves. And that actually brings in an enormous amount of responsibility on your shoulders as pediatric surgeons and doctors. And that indeed it's in itself a unique challenge. And you end up doing things that are quite unique. You fix things that what we call as Almighty forgot. And that itself is a challenge on its own. At the same time, you also have to fix things that has to last a very long time. It is about providing a solution that lasts a lifetime. It's not about the 5 or 7 years of survival. You have to work on situations that actually is a lifetime ahead of the child, which is about 70 plus years. And that itself is another challenge that you deal with. So all in all, the complexity is large. You also have to deal with the emotions that we all feel for our children, the parents, the complexities of parents, and so on and so forth. So you are indeed unique from several angles. So it's a pleasure to be associated with the pediatric community of this country. And that is where I think we want to spend quite a bit of time of our approach working with you all in the future as well. There's another challenge that comes to fore when we look at the challenges of pediatric surgeons. This is the challenge of India or the developing world. We have our own challenges as part of this ecosystem. We have challenges of economics. We have challenges of parent compliance. And this itself has its own set of complexities that come in our way. And this could be in the form of situations that you have to deal with, which is not typically addressed in the Western world. And you also deal with situations where you may not have the required devices and frameworks that addresses the need of this complexity. Either the devices could be too expensive, it could be not meeting your specific needs, the felt needs of a pediatric surgeon. And all this put together itself becomes a challenge. And several Western practices does not necessarily fit into the template of the pediatric surgeons of India and the developing world. India, with about 25 million births per year, which is about 50 births every single minute, is bearing the brunt of this challenge. And as pediatric surgeons, you are at the forefront of this challenge itself. This is where we really feel that we understand the felt needs of pediatric surgeons, and this is where we want to step in and partner with you all to make this felt needs a reality in the form of medical devices that we can bring to you. Blue Neem Medical Devices, we have been in business now for the last almost 10 years. We are a globally, we were founded with the aim of creating a globally respected medical devices company in India, delivering value. And also at the same time, deal with the complexity of the country itself. When we started off, we looked at the current scenario of the country where about 75% of medical devices are being imported. And that did not sit too well with us because a country of 1 billion people with 75% of medical devices being imported is not something that sits well. So we said we can do something to change that. So we have been able to work very closely with several practitioners in the country. Today, we are a reasonably recognized brand with tremendous amount of support from urologists and intervention radiologists. And we have been able to cater to several of their needs in the form of medical devices that make sense. And this is being done typically in a way, what we call as an industry practitioner and academia collaboration. It's only when we collaborate and come together that we are able to create value. And that's really where our focus has been, working very closely with the practitioners, working very closely with the clinicians, really taking your inputs, understanding your felt needs, and creating that the strength of this ecosystem to really deliver what is required for the practitioners of this country. And now, in this case, with the pediatric surgeons of this country. This is where we would like to step in, really understanding your felt needs, really understanding the gaps of pediatric surgeons in India and the developing world, and transforming that into creating a robust set of products that actually addresses your felt needs. And when we look at creating this ecosystem in India, we have been really focusing on building a very robust framework for design, development, and manufacturing of medical devices. And that is when we really can see the value of the innovation coming to the fore, wherein we are able to really understand the felt needs of the pediatric surgeons and come out with the best we can do. And if you look at it, our promise has been to partner. Our promise has been to understand. Our promise has been to learn. And really help develop medical devices that really are the requirements of the community, and also help standards to deal with unique situations. Because when we look at several needs, and especially when we talk about the challenges we talked about earlier of having the situation in the developing economies and India in particular, how do we really partner to create those standards? And the promise is also to design and develop medical devices for the specific needs, for the specific felt needs, with precisely defined intended use. And we also promise to build safe and biocompatible products, which are friendly for the children and safe for the children, and particularly focusing on avoiding the use of PVC and materials containing DHP. At Blue Neem, we have really taken patient well-being to heart. It is at the corner of our value system. We ensure that when we make decisions, we keep the patient well-being, in this case, our dear children, as part of our in focus when we make decisions. So our children deserve the best. So we are committed to partnering with you to ensure that we deliver the best for our children. I'm really happy today to announce the first tranche of products in pediatric range. As Dr. Ravi mentioned earlier, we have been in areas of urology and intervention radiology, and now we are venturing into spaces of interest to you. We have designed and developed products now in the space of pediatric urology, pediatric GIT, thoracic and abdominal surgeries as well. We have a list of products that you can take a closer look at, which are available today for you to use, as well as the ones under development. And if you look at it from a long-term standpoint, our promise is to look at this for what is required for the future. We will continue to work with you. We will continue to get your feedback, and we will continue to work very closely with the range of products that you need for your practice. And eventually, our joint initiative that we can work together, I'm sure will address a lot of your requirements in the future as well. We request you to visit our booth and take a look at the products in detail. You have a link in there to request for samples. So we request you to get some of the samples that we have on offer. And we look forward to your feedback, because ultimately for us, it is to ensure that we hear you and we hear you well. And this is a long-term journey. For any of our initiative to be successful in the long run, a robust foundation is critical. And your support and collaboration is the bedrock of this foundation. And that's really how we have built our organization and come to this stage. So once again, I think it's a pleasure for us to be associated with the pediatric surgeons of the country, and building on the promise of ensuring that we will create viable solutions for you in the country, partnering with you, listening to you, and working very closely with you. We look forward to a very strong future together. Once again, thanks to the organizers of this event for giving us this opportunity to sponsor this event, and the opportunity to talk to you all. So thanks once again, and we look forward to working with you in the future and for a long term to come. Thank you, Dr. Ravi, for this opportunity. And if there are any questions that you may have, glad to answer them. Please visit our booth. We also have a chat bot in there so that you can ask any questions that you may have. So please feel free to ask your questions on the chat bot and download information that we have made available in our booth. So please, I welcome you all to visit our booth and take a look at what we have there.
Yeah, thank you, Mr. Vishnu. It was really pleasant to hear to you and know more about BlueName. I'm sure that members will find interest in the products which your company has to offer.
Right.
And thank you for sponsoring this event. You are the prime sponsor for the E-Iapscon 2021. And it is really nice to have a firm which is putting so much of R&D into pediatric products. Nowadays, it is very difficult to find companies which are putting finances and R&D into things which are used in pediatric surgery and small patients.
Right.
Otherwise, the entire world is oriented towards the adult world.
Yeah.
Nobody focuses on the pediatric part. So
no,
that
absolutely.
is,
And I think, and that's a great point you make, Dr. Ravi, because as I said earlier, our children are the future of our country, and really being focused on what is important for India and the developing world. This is a natural progression for us. And as I said, you are a very unique. You are in a very unique position dealing with multiple challenges and unique situations, and we want to step in. We want to step in where there's a gap, because that's a promise we have made to you all and to India. So thank you for this opportunity, and look forward to working with you all.
So I will just request all our delegates, we'll put it in our mailer group also, that all the delegates should make an attempt to visit the booth and try to find out more about the products of BlueName. So once again, thank you to BlueName, thank you to you. And I think we can close this sponsored session now.
Yep. Thank you. Thank you, Doctor.
Virender, now you can start with your urology session 4. Please take over.
Sure, sir. Thank you. Well, good afternoon, everyone, and welcome to an afternoon and evening which promises to be full of urological discussion. The urology session is broadly divided into 4 sessions consisting of about 8 to 10 papers each, and roughly each session is for about 1 hour. We begin with session 4, which has about 8 papers. Just a few note points for the presenters. All the papers would be marked on the originality of concept, the response to questions, as well as finishing in time. There's a small change. Rather than the sequence, Dr. Shailesh Solanki, which was as the 3rd paper, he needs to present first because he has an overlapping presentation elsewhere. So I'll just, before starting the session, may I invite our 2 judges. Dr. Vikesh Agarwal, are you here? Have you joined? Dr. Saha, I can already see you. So you are muted. I can't see Dr. Vikesh on board, so I'm not sure whether he's around. And Dr. Pavai will not be able to join us. So I'll be marking as the 3rd judge.
I will give a call to Vikesh. You can start with the first presentation.
Sure, sir. So Dr. Shailesh, you can please go ahead with your presentation. So Dr. Saha, this is the 3rd paper presented by Dr. Shailesh Solanki.
Right. Thank you.
Please start sharing your screen.
Shailesh sir, can you share your screen, please?
Yeah.
There's a green button at the bottom. Just go to the Zoom once.
It is asking something.
What exactly it's asking, sir?
System preferences.
It's a Mac laptop?
Yes.
Go to Apple icon on the left top corner.
Yes.
Go to system preferences now.
Yes.
System, these are security options. Huh?
Yes.
Have you reached security and privacy?
Yeah. Privacy, Zoom daughters. I allowed it.
Now go back and share your screen. You have to unlock your key lock before you do that.
Yeah. Yes.
Passcode. Yeah. Are you able to do that? Oh. I think he logged out.
Yeah, seems so. So I guess we can take.
Dr. Vikesh is there now.
Right. Good afternoon, Dr. Vikesh, and welcome.
Sorry, actually, I got busy in one of the inspection today. I'm extremely apologetic for joining late.
No worries. So we are just starting out. So you haven't
Please
missed
proceed with the
anything.
meeting.
Sure, sir. Do you have the
Please.
marking list with you, sir? Judgment
Yeah,
sheet?
I do have. Don't worry.
Okay. Okay. So maybe Shailesh is still joining us. In the meantime, Dr. Tanvi, can you please start sharing your screen and we'll begin with your paper.
It's number 1, I think. First one.
That's number 1.
Yeah, right.
Outcomes of management.
Is my screen visible now?
You need to share your screen first.
I am sharing my screen.
Okay, your internet is low, ma'am. We can see that. So what I can suggest is switch off your camera so it saves the bandwidth.
Okay.
And then unshare your screen and share it again. Yeah, perfect. We can see your screen now.
Is it better now?
Yes, ma'am, it is.
Okay. Should I start?
Yes, please.
Good afternoon, everyone. I'll be discussing outcomes of management of unilateral pelvic junction obstruction in children. Pelvic junction obstruction is the most common cause of antenatal and neonatal hydronephrosis and urinary obstruction in children. Unilateral cases account for 1 in 5 to 8,000 live births. So the aim of the study was to analyze the outcome of management of unilateral POGO treated over a span of 10 years, with the primary objective of assessing the outcome of non-operative management in these cases, those with a function of more than 40% on renal dynamic scan. And the secondary objective was to compare this group with those managed operatively, either with upfront operation or later, and to assess the need for surgery. We had a total of 312 patients to start with, and a total number of 165 patients were analyzed. This was a retrospective study at a tertiary care center from March 2008 to May 2009 with a minimum follow-up of 24 months. There were 2 broad groups. Group 1 was those who underwent early pyeloplasty. That is, they were either symptomatic or had a function less than 40%. Group 2 was those managed conservatively. They were asymptomatic with a function of more than 40% to begin with 2 subsets of either delayed surgery or those who continued on conservative management. This is a flowchart of the number of patients and the indications for surgery. So the mean differential renal function of the affected kidney across all groups was around 35% to begin with. And around 100 patients who were operated, the function was less than 20% in 16 to 20% of the patients, 21 to 40% in 45% patients, more than 40% in 35% patients, whereas it was more than 40% in all those managed conservatively. So at end point of the study, the function improved in the early pyeloplasty group, and there was a decrease in the patients from 20 to 11% in the less than 20% function bracket. In the conservative group, there were 44 patients who were managed, and only 9% showed a deterioration in function, but still it was above 40%. And in those who underwent delayed pyeloplasty, the final function continued to be more than 40% in 70% of the patients, and had fallen to less than 20% in only one patient. So we can see here that the function remained above 40% in majority of the patients. The debate regarding the best time to operate pelvic junction obstruction started in 1980s, and in 1985 it was Ramsey et al. Who first stood up for conservative management. Since then, there have been several studies regarding the timing and indication for surgery in these patients, and the discussion has been ongoing regarding the conservative versus operative management of these patients till date. With standard investigative modalities now, the differential renal function of kidneys with less than 40% functions, they seem to do well with pyeloplasty, except those who have function less than 10%. But those who are asymptomatic and have a function of more than 40% remain the most controversial group. Should they be managed with surgery or with observation? What should be the indication for surgery in this group? Till what level of follow-up should we follow? What is the level of permanent damage? What is the level of recovery of function? There are many questions which continue to plague us. So the controversy regarding the best management of unilateral pelvic junction obstruction persists. But with our management protocol, we did not notice any serious or irreversible loss of function, and it was maintained across subgroups. Thank you.
Dr. Saha, any questions, please?
Yeah, I would like to thank you for a very lovely presentation. Now, one thing is, have you heard of something called renal resistive index ratio? And does it have anything to do with predicting which cases need surgery? That's number one. And number two is, we often find that in a unilaterally affected PUG obstruction, that particular affected site shows on the nuclear scan a higher percentage of function. That's a false high percentage. So how does just the DRF helps in you in deciding, which case to operate?
Sir, we had not taken just the DRF into consideration. We had also taken the patient with symptoms like symptoms or any other clinical manifestations like hypertension or lump to in consideration, and the function in kidneys, we had a subset of patients with more function, but with an obstructive pattern, with an unequivocal obstructive pattern on renal dynamic scan, but they had symptoms and so they underwent the surgery. Regarding renal resistive index, I have heard about it, but I am not able to recall the exact parameters.
Dr. Vikesh, any questions?
Yeah, only two quick questions. Were there any patients in the delayed group where you found that pyeloplasty was not required and patient improved? And secondly, have you compared the complications between early and a delayed pyeloplasty in relation to recurrence or any other operative complication like failure to pass a DJ stent or something like that, or leak, urine leak?
Yes, sir. Sir, for the first question, sir, there were some patients that who could be managed, but in our delayed surgery, the patients had an improvement of function, except in one patient who had a fallen function less than 20%, and 3 patients who remained in the 20 to 40% bracket. So there was 3 to 4 patients who did not improve despite surgery in that group as well. And for the second question, sir, there were complications that were noted, like urinary leak. Initially, there were surgeons who were performing with a nephrostomy.
Was there any difference? Was there any difference?
So we did not do the complications difference analysis.
You did not measure the complication. I think that is a very important point, because early in delayed pyeloplasty, one is concerned about the complications. That's why people decide about the age of the pyeloplasty.
Yes, sir.
Okay.
Right.
Thank you.
Thank you, Dr. Tanvi. We move on to the next one. Dr. Shailesh, you may please start sharing your screen. Yeah, it's visible now. We can't hear you, Shailesh, so please unmute.
Yeah, I'm audible?
Yes.
Yeah. Can I start?
Yes, please.
Yeah. Good afternoon, everyone. I am presenting our study on correlation between intraoperative anatomical variation with histopathological parameters in cases of uretropelvic junction obstruction in children. So
just click on the presentation once on the presentation slide itself.
Yeah. Okay. As we all know that UPJO has wide range of clinical presentation and can present at any age. As a pediatric surgeon, we always noticed intraoperative anatomy is not the same always. So it was a prospect to study from 2017 to 2020, and all children less than 12 years of age with UPJO were enrolled in the study. All children underwent Anderson-Heinz open pyeloplasty. Intraoperatively, the findings we noticed were type of the pelvis, extrarenal or intrarenal, insertion of the ureter, high or normal, presence of lower pole crossing vessel, negotiation of UPJ segment via 3-French DJ, and length of the narrow segment at UPJ. So this is the resected specimen showing 3 different regions marked with the 3 different color suture: pelvis above, UPJ, and the lower ureter below. So all suture-oriented specimens were glossed and sectioned from the representative area and assessed by expert histopathologists who were blinded for the intraoperative details. The histopathological parameters which we were assessed were fibrosis, edema, acute inflammation, chronic inflammation, and smooth muscle hypertrophy. All were graded. So a total of 49 patients were enrolled in our study and 39 patients fulfilled the inclusion criteria. These were the epidemiological parameters and intraoperative findings. 17 were less than 1 year old, 30 were male, 5 had intrarenal pelvis, 16 had non-negotiable PUJ, 9 had high insertion of ureter, and 16 had internal narrowing more than 1 centimeter at UPJ, and 6 had presence of crossing vessel. So once we got all the information regarding the histopathological parameters and their grading and intraoperative details, we did a statistical analysis and chi-square test was applied. Then we got this R correlation plot. This dot is showing the statistical significant correlation between the 2 parameters. If I put it in a simplified manner in words, so at the pelvis area, all cases showed smooth muscle hypertrophy and positive correlation between the edema and chronic inflammation with high insertion of ureter, presence of crossing vessel with chronic inflammation, internal narrowing more than 1 centimeter showed correlation with chronic inflammation and smooth muscle hypertrophy. At the UPJ area, all cases show smooth muscle hypertrophy and fibrosis. Internal narrowing showed correlation with smooth muscle hypertrophy, and fibrosis were less in crossing vessel and negotiable UPJ. It was negative correlation. At the ureteric area, presence of crossing vessel showed more chronic inflammation and less fibrosis. So there are different theories regarding UPJ pathogenesis, and in the literature, histopathology is contradicting studies are there, because when we analyzed those studies, we found certain confounding factor in those studies because they were retrospective studies, site of the histology not marked clearly, and the intraoperative findings were not considered in any study. If we see the clinical implication like vascular hitch procedure for crossing vessel, so the success rate mentioned were different. So we can understand that in many cases it is just because of external compression. In other cases, it might be because of internal narrowing. Similar with high insertion of ureter, the obstruction to urinary flow may be because of external compression and urethral kicking from an expanding renal pelvis, or it is because of internal narrowing. In our study, we also found that when high insertion of ureter present with patent UPJ and with non-patent UPJ, so their histopathology were different. So we concluded in our study that all UPJ cases has some common histopathological changes, 4 intraoperative findings and their combination, that is crossing vessel, high insertion of ureter, length of internal narrowing, and negotiable UPJ, alter the histopathological finding, especially smooth muscle cell hypertrophy, fibrosis, and chronic inflammation. Thank you.
Thank you. Dr. Saha, any questions, please?
Yeah, thank you, Dr. Shailesh. So would you tell us, I mean, how this study of yours will help you in dealing with UPJ obstruction in future? I mean, what's the take-home message from this? That's number one. Number two is, as far as the histology is concerned, do you know of any particular score which helps in prognosticating the late onset, I mean, recurrence or whatever? I mean, any histological score which prognosticates the UPJ obstruction? These are the two questions.
Yeah. So regarding the first, like I would say that all the confounding factors, whatever we observed, can mitigate in the Anderson-Hayes pyeloplasty. So in Anderson-Hayes, we are excising the, even if it is high insertion ureter, we are doing the dependent anastomosis. If it is the internal narrowing, then we are cutting in the crossing vessel. Also, we are doing anterior to it. So regarding if we are doing Anderson-Hayes, then we have not worry about this variation. But if we are planning to do something new like vascular hitch procedure, so we have to make sure the patient selection. So like in vascular hitch procedure, some people did intraoperatively test so that it's only the external narrowing or internal narrowing is there. Similarly, for there's a high insertion ureter, I mentioned, I put a picture also, pelvis cutoff pyeloplasty, in which Palmer did a pelvis cutoff and put it at the lower end without dissecting the PUJ segment. So again, you have to make sure when you are doing something new to get the proper result. Regarding grading, I have not came through any grading of histopathology, but in few papers they have mentioned regarding the long-term recurrence in and the correlation with the histopathology. So if there's a more fibrosis at the lower end, then there's a more chance of recurrence in future. Thank you.
Thank you. Actually, it's the collagen ratio between the collagen and the smooth muscle fibers, which with the trichrome Mason stain, we have a score. So if it's more than 0.5 or 0.7, then it indicates that prognosis. Thank you.
Thank you, sir.
Dr. Vikesh, any questions?
Yeah, I remember similar study you did in your own institute, PGI, maybe 10, 12 years back, where you assessed the neuromuscular structure of the ureter, UP junction, and that too by using S100 protein staining. So I think that if that would have been added to this study, would have been more fruitful, which helps us to decide like how much spatulation you have to do and how much ureter you have to excise, especially in long segment narrowing. Are you aware of that study you have done in PGI years back?
So similar study I have not came across any study which compare or correlate intraoperative finding except the crossing vessel. There are many studies which show histopathological difference on crossing vessel, but there is no study which is showing any histopathological correlation with the high insertion of ureter or the patency of the UPJ.
Yeah, that is additional point in your study. It was good study.
Yeah, thank you.
Thank you. We move on to the next presentation. Dr. Praveena.
Yes, ma'am.
Please start sharing your screen. Yes, please. Yes, please. Yeah, your screen is visible. Please start.
Good afternoon, everybody. This is Dr. Praveena from ESI Super Specialty Hospital, Hyderabad, and I'll be presenting on the role of preoperative RGP in children undergoing pyeloplasty. And I have none to declare. Coming to introduction, pelvic junction obstruction is the most common cause of hydronephrosis in children, diagnosed by ultrasound and dynamic renogram. And other error causes like congenital meduretic stenosis, obstructive megaureter, duplex moieties, etc. are difficult to be diagnosed only on ultrasound, especially in neonates and smaller infants in whom the dilated pelvis may obscure the dilated ureter. And RGP prior to the definitive procedure not only helps in visualizing the anatomy and orientation of the kidney, but helps in identifying the rare causes and prevent intraoperative surprises. So our aim was to know the role of preoperative retrograde pyelogram as an adjunct tool in all children planned for pyeloplasty. It was a retrospective study of RGP findings done in children with a probable diagnosis of PUJO over the duration of 9 years. And after informed consent, all the children planned for pyeloplasty with diagnosis of PUJO underwent an RGP in the operation suite just prior to the planned surgery. And after doing cystoscopy, the ureteric orifices were identified and cannulated using a 3 to 4 French ureteric catheter, and about 5 to 10 ml of the contrast was injected, and images were taken at the same time, visualizing the ureter and the pelvis. And after 20 minutes, we took a delayed image, and our findings were confirmed. The radiation exposure is minimal, as the cumulative time exposed with fluoroscopy screening is about a minute, and the median time taken for the procedure was about 25 minutes. Coming to results, a total of 101 children underwent RGP for suspected PUJO, 76 were boys and 25 girls, age range between 35 days to 12 years with a mean of 2.4 years. And results, RGP confirmed PUJO in about 91 patients, helping us in identifying the location and orientation of the kidney. It gave additional information regarding high insertion of ureter, helping us in planning the incision and surgery. There were about 58 left-sided PUJOs, 28 right-sided PUJOs, and we had about 5 bilateral PUJOs. However, RGP completely changed the diagnosis in about 10% of the cases, wherein we had about 5 cases of obstructive megaureter, 3 cases of congenital mid-ureteric stenosis, 1 case of VUR, and 1 case of duplex with a lower moiety PUJO. This is RGP showing the congenital mid-ureteric stenosis and the intraop findings. There's another case showing the congenital mid-ureteric stenosis. This was a spectrum of obstructive megaureter, where you can see that most of them were small infants, just like between 1 to 3 months of age, where it was diagnosed as left-sided hydronephrosis. And on RGP, we found that 2 of them had duplex moiety and 2 of them had VUJO on the left and 1 had right VUJO. And these were the RGP pictures of the child showing right VUJO, and this is the one showing lower moiety PUJO. And coming to discussion, doing an RGP and visualizing the anatomy and orientation is slowly emerging as an adjunct tool prior to pyeloplasty. Although a few previous studies have stressed the importance of visualizing the ureters prior to pyeloplasty, the role of RGP is still debatable. Apart from establishing or ruling out PUJO, RGP helps to identify other anomalies like polyps, multiple sites of narrowing, longer segment of narrowing, and simultaneous VUJO obstruction. And in our study, RGP changed the diagnosis in about 10% of the patients, wherein the management plans were changed. In the rest, RGP helped in planning the incision well, especially in hugely dilated pelvises. So conclusion, pre-op RGP in cases planned for pyeloplasty is a feasible, simple adjunct procedure. It can be used as an objective tool to help avoid intraoperative surprises. Thank you.
Dr. Saha, questions, please.
Yeah, thank you. Now, suppose your institution has a facility for a good quality MR urogram for all patients. Would you still consider this as a priority, or would you go for MR?
Sir, see, MRU as such, it's very difficult for in small infants for MRI to be done, because we don't get the proper sedation first of all, and taking them under GA again would be a little risky. So RGP, anyway, we have taken them under general anesthesia, and just about taking 20 minutes out and visualizing the pelvis and the ureter which actually helped us diagnose the obstructive megaureter and congenital mid-ureteric stenosis and all. So, sir, in cases where we saw obstructive megaureter, we actually did an MRU also. We stopped the procedure and we went for an MRU, completely delineated the anatomy, and we went for either like, depending on if it was a small neonate, we did a distal and cutaneous urethrostomy and reimplantation later on.
Yeah, thank you. Did you take this opportunity to put in a stent also, PJ stent?
No,
in any
sir,
of the patients?
No.
Okay. Thank you.
Thank you.
Yeah. May I, Virender?
Yes, please, sir.
Yeah, one observation which I made is like there was high incidence of associated anomalies in your study, like mid-ureteric stenosis, megaureter, which are usually not missed so commonly on ultrasound. Like you can see a dilated ureter. Anyways, another question, like Dr. Saha said, MR urography. Why not intravenous urography for selected patients where you are likely to encounter such problems? And second question is, suppose you encounter a mega ureter on RGP. So would you still do a pyeloplasty, or you will do just reimplantation and consider it as secondary PUJ?
No, coming to the first question, RGP gives us better delineation and all in case of rather than IVP, sir. IVP is like we have a CM in our OT where under controlled conditions we have a hold of the thing. IVP again we have to take them down and depend on the radiologist and will not get a proper picture as such. And these are all cases diagnosed as hydronephrosis first and suspected to have PUJ obstruction. So that is why we did an RGP first.
Routine RGP, I think many people won't agree to this thing. One thing which is a good use of RGP is like placing the DJ stent. That's why Dr. Saha asked that. Like in pyeloplasty, which you are doing laparoscopically, then it's easier to place a DJ stent retrogradely. And what about my second question? Like a mega ureter, would you still do a pyeloplasty?
No, sir. When we see a mega ureter, we are going for a MRU. Now that the child is under GA, we take the child down to our MRI room and then we do a MRI urograph. Depending on the diagnosis, we do. Like
under anesthesia, you will shift the patient for MRU.
Yes, and to MRU, and then whatever we see, depending if it is just obstructive mega ureter, it's small baby. We had done a distal cutaneous ureterostomy, and once the child grew about 1 to 2 years, we done a reimplantation. I'm talking about obstructive mega ureter as such.
Yeah, that is what I'm saying. So you mean to say that your patient is under anesthesia and you will do MRI urography at that moment only, you will shift patient under?
In case when we had taken up for RGP and in that child, when we had seen that it was an obstructive ureter,
you will
now that
you will withhold the procedure, no? You will stop the procedure.
Yes, we will stop the procedure and we'll take the child down for an MRU, and then
so that's what we were pointing out. Why not do a MRI urography beforehand?
So
it's okay. I mean, it's a preference. Yeah, fine. It's okay. But these are the, drawbacks of RGP. Okay, RGP as a routine, many people won't agree. But that's a matter of debate. But it was good paper.
Right. Thank you. We'll move on to the next paper, please. Dr. Shweta Reddy. Yes, we can see your screen.
Hello. Yeah. Good afternoon, everyone.
Dr. Shweta, sorry. There's a lot of background noise or echo. Can you use some headphones, please?
Or maybe one of the devices needs to be switched off. I think two devices are on.
Just 1 minute, sir.
Please log out from second device, ma'am.
Hello.
Yes, Dr. Shweta, much better.
Please.
After reviewing, can I start with my case?
Yes, please.
Yeah.
Hello.
Yes, you may start, Dr. Shweta.
Please go ahead, ma'am.
Hello.
I trust she can't hear us now.
Am I audible? Dr. Shweta, am I audible?
I don't think she can hear us.
I'm not able to hear your voice. Hello. Can I start with my presentation?
Please start.
I'll just text her, sir. I don't think she can
Actually, ma'am, I'm just
I'm not able to
texting, but
hear.
she's not replying, ma'am.
Okay.
Okay. So, So after reviewing the data of 3 years, we found 12 patients who had presented with crossing vessels causing obstruction in 200 patients who presented with pelvic junction obstruction. That is, 4% of the patients in our study has crossing vessels causing PUJO. Sir, I'm not able to hear anyone.
No one is speaking right now. Only you are speaking. Please go ahead.
Okay. The age of presentation varied from 8 months to 9 years. And in our study, there are 8 patients who has presented with as males, that is male preponderance was seen, and left-sided is most commonly involved in my study. That is 9 patients had left-sided obstruction. Most common presenting symptoms was abdominal pain, which was mild and intermittent. The other symptoms were fever with UTI, abdominal mass, and the duration of symptoms varied from 1 month to 1 year. All patients had a normal BP for age on examination. Systemic examination of all patients was normal, except in one case, there was palpable renal mass on the left side. So blood investigations in our cases, all patients presented with a normal hemoglobin. Urine routine was normal with one patient having pus cells, and the serum creatinine values were within normal level for age in all the patients. So sonography abdomen was done, which was showing hydronephrosis of the affected side. AP diameter varied from 15 mm to 45 mm. All cases were reported as pelvic junction obstruction. One case has showed horseshoe kidney with dilated PC system with PUJO. No case was diagnosed on sonography with crossing vessels. So this was the EC scan, which was done in the case of horseshoe kidney, where there was an impaired drainage over the left side. So EC scan, which was done in all cases, has reported as delayed perfusion and delayed corticocalcium transit with impaired drainage. There was progressive accumulation of the radiotracer seen with no further drainage. All patients were diagnosed as enlarged hydronephrotic kidney with pelvic junction obstruction on the affected side. One case showed horseshoe kidney with delayed drainage over the left side. The function varied from 48 to 20% on the affected side. In 48%, there was the T-HOP was not achieved, and the AP diameter was 28 mm. Hence, we proceeded with the surgery. So, Anderson-Heinz pyeloplasty was planned in all cases. Flank incision was taken in all the cases, including case with horseshoe kidney. Extraperitoneal approach was done. In all cases, crossing lower pole vessels was an intraoperative finding. There was no intrinsic obstruction seen at PUJ in all these cases. So these are the intraoperative photos where these are the lower pole vessels which we can see causing the PUJO. Hydronephrosis, this was the hydronephrosis. So the ureter is dismembrant from the pelvis, and there was no intrinsic obstruction intraoperatively. The pelvic anastomosis was done. DJ stent was placed in all cases. This is the post-operative photo. On follow-up, the follow-up varied from 3 months to 34 months. DJ stent was removed post-operatively after 1 month. All patients were asymptomatic post-operatively. RDS showed improved drainage with non-obstructive pattern post-operatively. Renal function improved in all cases on an average of 10 to 16%. Coming to review of literature, the incidence of PUJO with crossing vessels was 11 to 20%. These children usually present at later age group as the growth of aorta and kidney happens gradually, which causes the obstruction. Most common presenting symptom is intermittent abdominal pain, as the obstruction may be obstruction is intermittent. Even though the presentation is late, all patients present with normal bed parameters. Sonography in all cases showed hydronephrosis with normal ureter and PUGO. Doppler sonography can diagnose crossing lower pole vessels in 80% of the cases, but is not required as a normal investigation in all PUGO cases. CT and MRA has more diagnostic importance for diagnosing crossing lower pole vessels. Renal function in patients with crossing lower pole vessels are usually normal as the obstruction is considered intermittent. The treatment is surgical either by open flank approach or by laparoscopy. Anderson-Hines pyeloplasty is the procedure of choice for crossing of lower polar vessels. Hellstrom procedure is vascular hitch technique described for crossing lower pole vessels. These are my references and thank you.
Dr. Saha, any questions? She may not be able to listen to us.
Sir, actually, I'm not able to hear.
I put it on the chat box.
Sure, sir.
Can anyone help me?
Somebody from the host team, maybe you can guide her as to why she can't hear us.
I put the question in the chat box if she can answer from there.
Yes. I think we'll wait for another 30 seconds if she can answer, sir. Otherwise, we'll have to give it a miss.
She can continue to answer in the chat box. So I think you can
Sure, sir.
skip to the next one.
Right. So we go on to the next presentation. Dr. Hira, please.
Yes, ma'am. Is my slide visible, ma'am?
Yes, ma'am, it is.
Can I start, ma'am?
Yes, please go ahead.
Good afternoon, respected judges, seniors, and my dear friends. I'll be talking about the functional outcome of infant pyeloplasty. We have nothing to disclose. The role of pyeloplasty is recognized to preserve the renal function and prevent further deterioration. Recent consensus reiterates early surgical intervention for maximal benefit. Previous studies have shown pyeloplasty in infants yields some functional recovery too. We look at this aspect in our study. Our aim is to study the renal functional outcome in PUJO after pyeloplasty in infancy. It was a retrospective observational study done over a period of 10 years. We've included all infants who underwent pyeloplasty and who had a split function of less than 40%. We have excluded single kidney status, bilateral pyeloplasties, and associated reflex. Both APD on ultrasound and split function on diuretic renal scan were compared before and after surgery. All had underwent open Anderson-Hines pyeloplasty with stent insertion. Follow-up renal scan was done between 3 and 6 months. The indications for surgery were SFU grade 3-4, APD more than 2, split function less than 40%, and who had progressive increase in the hydronephrosis on serial scans. Moving on to results, we had a total of 58 patients, of which all of them had ultrasound APD available. However, only 32 patients had both pre and post EC scan available, of which 22 patients had an initial function of less than 40%. This was our study group. Most of them belong to less than 3 months age. The mean APD had decreased significantly from a mean of 3.5 to 1.29 centimeter postoperatively. This graph shows a significant improvement in the split function from a mean of 32% to 41%. This is a linear graph plotted for all individual patients. As you could see, over more than half of our patients had achieved almost near normal function postoperatively. Regression analysis graph was done between the age at surgery and change in the split renal function, and it showed negative correlation. That is, earlier the age, better the improvement in the split function. However, we had less number of patients in the later age group, hence it was not statistically significant. No morbidities were observed. This was one of our patients. Moving on to discussion, the kidney growth is fastest during the fetal life and early infancy. This kidney growth curve shows volume of kidney increases by 50% between 40 and 60 weeks post-gestational age. A brief about the pathogenesis. Following obstruction, there is slowing of renal growth, which causes profound reduction in the number of nephrons. This delays the development of renal vessels and glomeruli, ultimately causing interstitial fibrosis. There was an animal study published in the year 2002, which showed that earlier the intervention bettered the recovery of renal structure and function compared to the late intervention group. They concluded that the relief of obstruction attenuates the renal hemodynamic and the functional impairment and decreases the renal fibrosis and apoptosis. Few literature search were done. One study by VVS et al. Had shown that there was a significant improvement in the split function from 23 to 45% in less than 1 year age group. Another study by Baubo et al. Had shown that the earlier group, where the mean age was 2.8 months, had shown that the split function improved from 34 to 37%. There was a recent study published in the year 2021 by Pradanya et al. Had shown that in neonatal pyeloplasties, the split function improved from 35 to 44%. We had few limitations in our study. It was a retrospective study with small sample size. Other confounding factors have not been studied. Hence, it needs a prospective study with large number of cases. Hence, infant pyeloplasty has good success rate with low morbidity. In our series, the split function increased from 32 to 41%. It was better in the earlier age, that is 1 to 3 months. Hence, I conclude that early pyeloplasty gives the growing kidney the best opportunity to recover its function. These are my references. Thank you.
Thank you. Dr. Saha, questions, please?
Thank you. Congratulations for highlighting a very, very important idea that when the fibrosis sets in, it's no longer reversible. So I would like to ask you, which age would you ideally prefer? Suppose it's diagnosed at birth and gradually things are increasing. So is there any cutoff that below which you won't operate, or what's the optimum age? That's number one. Number two is, did you, in these patients who were operated in infancy, did you find any increased late complications like secondary stenosis?
Sir, so answering to your first question, in our series, looking throughout the infancy period, we felt that the age group, the mean age that we operated was 2.8 months. So around 2 to 3 months is the best age group to go for the pyeloplasty. And the second question, sorry, sir.
Late complications like secondary stenosis, which people say are more apparently in the infants, operated in infants.
No, sir. We apparently we could not. We had not came across any other complications like recurrence or obstruction or anything.
Thank you.
Thank you, sir.
Dr. Vikesh.
One question to you.
Yes, sir.
It was a nicely conducted study. But did you compare complication rate between pyeloplasty done before 6 months and after 6 months, and the deterioration of function which could happen like after 6 months? Usually we consider at 6 months there is some fibrosis started setting in.
Yes.
So it would have been like more imperative or more pertinent to compare these two age groups in your
Yes.
data. Have you done
Sir,
that?
so we had less number of patients in the late age group. We had maximum number of patients in the earlier age group. So we could not achieve statistical significance, but yes, we have compared the difference.
Usually the debate is like a neonatal pyeloplasty or a pyeloplasty in an infant, like if infant grows up for 2-3 months or 5 months. So normally most of the people, they do pyeloplasty before 6 months. It's a well accepted notion. What is new in your paper? This is what I want to ask, because your paper was nice, but you were not able to deliver what is new in your paper.
So, sir, I want to emphasize that the functional improvement in terms of split renal function improvement is more in the earlier age group, that is between 2 to 3 months when we operate, compared to the late group.
So, okay, I suggest in your data, you can do another receiver operating characteristic curve analysis and come to a cutoff value in months. Like Dr. Saha said, in that case, it will be more informative that after these many months, the pyeloplasty would be less advantageous as compared to the one which is done before that particular cutoff. This is my suggestion to you. You can do further data analysis.
Okay, sir.
Thank you.
Sir.
Thank you. I think your time for questions is already up, so we move on to the next one. Dr. Vijay Suman. I trust I was told that Dr. Kanishka is not presenting. Is there anyone from his team who will be presenting, or do we move on to the next one? Anybody from Dr. Kanishka Das's team for primary VUJO?
Respected doctors, we had a word with Dr. Kanishka and he was saying that he wouldn't be able to join.
Okay, fine. So we move on to our second last presentation for the session, which is by Dr. Vijay Suman.
Ma'am, actually, I am Dr. Aditya Manikar. Actually, Dr. Bijay, I am senior resident at AIIMS Bhubaneswar.
All right.
And Dr. Bijay Suman is having his exams today. So I'll be presenting on his behalf.
Sure.
Yeah. Yes, ma'am.
So
I'm sharing my screen.
Sure.
Ma'am.
Please go ahead.
Is my screen visible, ma'am?
Yes, it is.
Am I audible, ma'am?
Yes,
Clearly?
you are. Please start.
Sure, ma'am. I'm starting, ma'am. My study is the role of cortical transit time on diuretic renography in determining the need for surgery and evaluating the postoperative outcome in UPGO patients in children. And this was a prospective observational study. And now, as we all know, UPGO is the most common cause of antenatally detected hydronephrosis and also postnatal. And we need there is the need for identification of a test or a marker which is not non-invasive and which can accurately predict the severity of UPGO and need for surgery later on. Now, our study is based on this background that we can use the cortical transit time in diuretic renography, which can be a reliable predictive marker. Our primary objective was to evaluate this cortical transit time in determining the need of surgery. And the secondary objective was to note evaluate the role of postural differences of anteroposterior diameter of renal pelvis on ultrasound in cases of unilateral uretropelvic junction obstruction, and to evaluate the role of cortical transit time in predicting the early functional improvement. Now, this study was done in a Department of Pediatric Surgery from July 2019 to May 2021, and this is a prospective study. All cases of unilateral UPGO were included in the study, and cases with bilateral UPGO with VUR, with renal insufficiency with vascular obstruction, they were excluded from the study. And the statistical analysis was done by SPSS software version 23. This was the work plan which we followed, and the indication of surgery was a symptomatic case of UPGO, and on ultrasound showing parenchymal thinning, delayed perfusion, obstructed drainage, and differential renal function less than 40%, and progressive deterioration of differential renal function more than 5% on diuretic renography. Now, coming on to results, we included a total of 36 patients with a mean age of 2.15 years, and there were 28 males and 8 females, and these were comparable to the literature. And we found that if the cortical transit time cutoff is taken as 210 seconds, we can correctly identify 95% of patients those requiring surgery and 74% of patients who do not require surgery. Now, this graph shows the red bars show the mean cortical transit time, and the blue line shows the differential renal function. And here we can see that after surgery, we can there is a better improvement in the cortical transit time as compared to the differential renal function. Now this is showing the conservative and the surgical group, and we can see that the differential renal function, the graph is slowly rising as compared to the cortical transit time. And here we have also proposed that when the difference between the supine and prone APD is compared between surgical and conservative groups, it was found that when there is no variation in the supine and prone APD, the requirement of surgery is 100%. However, we could not find any significance in this because of the lesser patient size. Now we compared our study with other studies like Harper and Lee et al. And we achieved similar results, and the results were comparable. And we have proposed the cortical transit time cutoff of 210 seconds as compared to other studies, which mostly have taken 180 as the cortical transit time. Now we conclude that cortical transit time has a role in early prediction of need of surgery and early evaluation of early postoperative recovery. And the cutoff of cortical transit time to be 210 seconds is significant, unlike several previous researchers who have found out that the cutoff of 180 is significant. Yeah, thank you, ma'am.
Thank you. Dr. Saha, please.
Yeah, thank you for a very nice paper. Now, I would like to learn from you, I mean, how did you come to this level of 210? Because most of the papers previously described have come, was 180. That's number one. Number two is, most of the cortical transit time publications in international literature had done considered MAG3 scan. And
Yes,
of
sir.
course, you have done DMSA scan.
And
So,
we have done an EC scan, sir.
EC scan, I mean, right?
Yeah,
EC
right.
scan. So MAG3 and EC, do you think, is there any difference? I mean, in any particular areas which you'd like to tell us that these are the?
So generally EC scan, which we do, we are, if the patient is more than 1.5 months of age, we are doing a EC scan. MAG3 scan can be done in the neonatal age also. So in this EC scan, I mean, we could not include the neonatal patients. We had to wait for up to 6 weeks.
Right, perfect.
Right, sir.
And how did you come to that magic number of 210?
So that was the statistics which we achieved after comparing of the results.
Thank you.
Yeah, thank you, sir.
Again, what was the statistical model you adopted to come to that cutoff figure?
I mean, we use the receiver operative curve, sir. I mean, after tabulating the results in the Excel sheet, and it was subjected to the software, and we could find those values, sir.
What was the overall accuracy of this particular test in the ROC curve?
We got a accuracy of 0.86, sir, 0.806.
86% accuracy. Yes, and did you measure the intrapelvic pressure operatively
no, sir.
to relate it?
Intrapelvic pressure was not measured, sir. Yes, sir.
But differential function was inversely correlating with the
Yes,
cortical
sir. Yes,
transit
sir.
time.
Right, sir. And there was better improvement seen in the cortical transit time, early improvement at 3 months of age postoperatively, if we compared with the differential renal function.
Okay, thank you very much.
So I have one more suggestion for you. If you conduct further studies, as far as
Yes, sir.
ultrasound is concerned, as you were telling us that prone and supine position makes some difference. That's
Yes,
known
sir.
to make some difference.
Yes, sir.
Similarly, pre and post void also makes some difference. So you have to exclude all those issues and the degree of hydration of the patient. So all these three variables must be taken into consideration.
Sure, sir. Sure.
Okay,
Yes, sir.
thank you.
Thank you, sir. Thank you so much.
Thank you, Dr. Suman. We move on to the last paper of this session, that is by Dr. Kashish Khanna. Judges, may I request you to please check, because my marking sheet does not have that paper listed. If it's the same with yours.
Mine does not have to. What we can do is we have the one which is missing. I mean, we can mark in that.
Or Dr. Ravi, do we send it separately to you? How do we go about it?
You can mark it, select any paper, and there is a blank column of any comments.
Yes.
Right.
Write the title in that, and I will be able to identify that this is for that paper.
Sure, sir.
Thank you.
Kashish, please start sharing your screen.
Good afternoon. I'll just share my screen. Is my screen visible?
It is. Please start.
Yeah. Good afternoon. Greetings from All India Institute of Medical Sciences. I have no disclosures. Since the antenatal diagnosis of has come into vogue, the increasing number of cases of PUJ-O type obstruction, hydronephrosis, are being diagnosed. More so, some of these resolve spontaneously, either during pregnancy or at variable intervals postnatally. So now the latter period, that is the postnatal period, is unpredictable and indeterminate, and hence ultrasound, it becomes an important tool of follow-up in these patients. The current ultrasound parameters, they are unreliable and they measure only a 2D record of the renal pelvis. What we realized is that if we combine the inputs from other diameters like the AP diameter, the craniocaudal diameter, the lateral diameter, we can overcome this limitation. We also found that pelvic volumes, they were better reflective of the underlying biological process. And with this aim, we focus our study to find out the significance of these additional pelvic dimensions other than the anteroposterior dimension vis-a-vis all these stages of SFU grade. And we focused on the SFU grade 2 patients. So all patients with unilateral UPJ type obstruction with a split renal function of more than 40% with delayed pattern of clearance were included. Serial ultrasound measurements, including the RDS scans, were there. Any patient with the clinical symptoms pertaining to urgent surgery were excluded. Our study ranged over a period of 12 years from 2000 to 2012. The parameters we measured both AP diameter, both the renal and the pelvic diameter, the pelvis lateral and craniocaudal diameter, the cortical thickness of the upper and the lower pole, the renal length, and the volume of the renal pelvis. Other than that, renal dynamic scan, serum creatinine, and GFR were also done. So this cohort consisted of 87 patients. In the non-operative group, we had 41 patients. In those who underwent surgery, there were 46 patients. The mean age at presentation was 24 months and follow-up was of 36 months. When we plotted our data, we realized that all the pelvic dimensions and the renal dimensions, they showed an increase in measurement, which was statistically significant. However, during this included measurements like the pelvic AP diameter, the pelvic lateral diameter, and the most significant was this pelvic craniocaudal diameter, which was the earliest to rise. However, during this time, what we noticed that the split renal function and the glomerular filtration rate, they either remain static or above 40%. So when we plotted this data across the various SFU grades, we noticed that there was a consistent rise in the pelvic craniocaudal diameter and also in the pelvic volume in both the operated and the non-operated group. But what was of notice was that the pelvic volume, it decreased in the operated group just before the surgery, and there was a corresponding rise in the renal length in these patients. So this is a graph which represents that across all grades of the SFU, the non-operated patients, there was a rise in the pelvic volume, whereas in the operated patients, there was a decrease in the pelvic volume, but there was a corresponding increase in the renal length. This is a diagrammatic representation that probably when the pelvis had borne the brunt of expansion, it was transmitted to the kidneys, leading to a corresponding rise in the renal length. And these were the patients who actually underwent surgery. Again, when we just concentrated on the SFU grade 2, we found that there was an increase in the pelvic craniocaudal diameters as well as in the pelvic volume, which was statistically significant. However, the split renal function, it did not show much change. So a simple representation that even when the serum creatinine, GFR, and the split renal function do not show indications for surgery, it is the ultrasound parameters which can sound as caution to us. So to conclude, that ours is one of the first studies which has taken parameters other than the anteroposterior diameter to follow up such patients of pelvic junction type of obstruction who are in the dilemma of this long and indeterminate follow-up. SFU grade 2 especially, despite having preserved renal function above 40%, the ultrasound parameters, the pelvic volume, and the craniocaudal diameter are consistent with progression of the disease in its early stage. Thank you.
Thank you, Dr. Kashish. Dr. Saha.
Yeah, so I would like to ask you, Kashish, I mean, is there anything else than pelvic volume? We talked about pelvic volume. So did you hear anything called a CP ratio, which is popularized by Diwan maybe in mid 2000 2012 or 2013. That is the depth of the calyces as well as and the parenchyma, the ratio of the cortices. Because sometimes pelvis is overdilated, sometimes there is issues with the elasticity of the pelvis. So can a pelvic measurement alone not lead you to some trap, error trap? Like you to highlight.
Yes, sir. Thank you so much for your question, sir. As you have rightly pointed out, it is not just the pelvic dimension. In fact, I will take a step behind and I will point out to the pathology. What happens is, like, as the pelvis keeps on increasing because of this obstruction and the pressure keeps on building up, Koff has rightly pointed that this pressure, it transmits to the kidneys and subsequently the pelvis gives up, that is arexes. It is not no longer pliable to take those pressures. And because of this, when the kidneys bear the brunt, the cortical thickness starts to decrease. And that is where the CT ratio, it comes into picture, and the renal length keeps on increasing. So if we look back to our study, those patients who underwent surgery, the pelvic volume actually decreased, but the renal length increased. That is corresponding to the CT ratio. So this has rightly been pointed out by you, sir, and this is what we observed in the surgery, in our study, that not just the pelvic volume, but also the renal dimension in toto have to be taken into account.
Thank you.
Thank you, sir.
My only comment to your paper is, Kashish, you are always like a good presenter and choose good papers. It would have been more wise if you have correlated with the parenchymal thickness also. So that would scientifically prove what you have just now postulated and told us the hypothesis. You need to prove it also
Right,
in
sir.
your study.
So we have the cortical thickness measurements also in our study. We have taken total of 12 measurements on ultrasound, which does include the upper as well as lower polar cortical thickness. Just to highlight, it was the craniocaudal distance first, which showed early disease progression, but the cortical thickness has also showed change in the study group, sir.
Okay, could have been included in the presentation. And another point I would like to make, is there any implication of like pelvic volumetry in deciding how much excision of the pelvis you need to do during the surgery?
Right. So thank you for your question again, sir. So this would be an interesting point to take up next, that would this pelvic volumetry determine the intraoperative redundancy and trimming in pyeloplasty patients? So this could be a next step which we'll look into. But as of now, because some patients, they do a reduction, some surgeons do a reduction pyeloplasty and some do not. So I cannot comment upon the correlation between the preoperative pelvic volumetry and intraoperative reduction pyeloplasty, sir.
Okay, fine. Thank you.
Sir.
Thank you, everyone. That brings us to the end of urology session 4. So we thank all the judges and move on to the next session. Dr. Ravi, it was supposed to start at 3:50 as per the new timings. So what do you suggest? Do we move ahead? Because the time is a little...
Keep going.
Okay.
If the centers are all there, then we should not interrupt. We should continue.
Sure thing, sir. All right. And again, to the host, is somebody maintaining time? Because I can't really see a timer otherwise. So the first session had plenty of time, but the other sessions are, you know.
Yes, ma'am, we are having a check.
Sorry?
We are having a check on time, ma'am.
You are having a check on time. So would you highlight, because you never pointed out the ones who exceeded otherwise, no?
Sure, ma'am.
So can you put on a timer for everyone to see? Oh, that's not possible.
Not possible at the moment, ma'am.
All right, no worries. So I'll keep a timer on my personal front as well. So not a problem.
Yeah, we did that.
No, we were doing that, but this first session had plenty of time, sir, so that wasn't much of a concern.
Yeah.
But the next ones are really tight on time, so that is why maybe I'll time it. So anyways, so we begin with session 5 of free papers in urology. May I invite the chairpersons, Dr. Ramesh Babu, Dr. Dasmeet Singh, and Dr. Munir Malik. I can see Dr. Ramesh and Dr. Dasmeet. Munir, are you around?
Yeah, I'm here. Good evening, everyone.
Hi, good afternoon. And Dr. Ramesh, is your marking sheet sorted?
Yeah, I have got it. Yeah, thanks.
Okay, okay, great. All right, so we'll begin with our first paper for the session. Munir, can you point out the first one and we'll begin? My thing does not seem to open. The first presenter, can you please start your screen share?
Respected ma'am, Dr. Garvita Singh and Dr. Ashwita Shenoy, they are not presenting today.
Garvita and, all right.
We will move on to the third presenter, that is Deepti Pal.
Sure, please.
Shall I share my screen?
Yes,
now?
please. Yes.
Yes, ma'am.
Yes, we can see that.
Yes, ma'am. Just a second. Yeah. I'll start now, ma'am.
Please make it full screen and then start.
Good evening and greetings from PGI Chandigarh. I am presenting changes in urinary bladder morphology after fulguration in PUB patient and its effect on outcome. So it's a widely accepted concept that long-term outcome in PUB patient depends on maintaining bladder function and that no bladder will become normal even after fulguration. Although our past experience shows that there's a strong relationship between incomplete fulguration and poor outcome. So aim of our study is to compare pre-op urinary bladder morphology with its post-fulguration morphology and clinical outcome in PUB patients. It's a retrospective and a prospective study, including patients who have fulgurated, whose data was collected from a database and contacted between 2019 and 2020, excluding the patients who had other urethral anomalies along with PUB. Pre- and post-operative ultrasound and MCU findings were compared, and bladder diary data was collected prospectively. Pre-fulguration MCU findings were correlated with bladder diary records. Coming to results, we included 100 patients who were followed for a mean of 6.6 years. Ultrasound findings showed a significant reduction in bladder trabeculation and bladder wall thickening. While comparing pre-fulguration ultrasound bladder thickening to post-fulguration accidental leaks as per bladder diary, we saw that more than 50% patients had no leaks, and this was statistically significant. So coming to MCU findings, there was a significant reduction in bladder trabeculation, and also there was a reduction in prostatic to vulva urethra ratio over time, which was also significant. We also saw that VUR and bladder diverticuli decreased significantly in our patients. There was an increase in number of patients with the normal bladder shape, that's spherical, and a normal capacity bladder. While comparing association of pre-fulguration MCU finding to post-fulguration urine frequency, we found that patients with a spherical bladder shape had the least frequency of micturition in bladder diary, which was statistically significant. While comparing the bladder capacity, we saw the small bladder had the maximum frequency and the large bladder had least frequency, but this was statistically not significant. While comparing the other MCU findings with the bladder diary parameters like accidental leaks and urinary frequency, we did not produce any significant results, which shows that poor morphological characteristics of bladder also gave a similar outcome as a good morphology bladder. Coming to discussion, there are very limited studies which have compared pre-op bladder morphology to the clinical outcome of PUB patients. In our study, we found that there were more than 80% patients who had abnormal bladder morphology on ultrasound, which was also seen in other studies. And there was a significant reduction in wall thickening and bladder trabeculation. Our MCU findings showed that there was more than 80% bladder trabeculation in pre-op period, as shown by Teminger et al. Also, and adequate fulguration led to normalization of bladder appearance. While comparing PU-BU ratio, our findings were similar to that of Vanihani et al. And Menon et al., which indicates adequacy of fulguration. Farhat et al. In their study showed that 50% of patients had resolution of VUR after the surgery for PUB, and we had also similar findings in our studies. Coming to conclusion, after adequate fulguration, there is significant reduction in bladder trabeculation, diverticuli, and VUR on MCU. It also leads to improvement in bladder capacity. While comparing clinical outcomes, spherical bladders had better outcome as compared to elongated bladders, but there was no significant difference between clinical outcome of other morphological features, showing that poor bladders and good morphology bladders may fare similarly if adequate fulguration is done. Thank you.
Thank you, Dr. Deepti. Maybe we can have one question from each of the judges. So, Dr. Ramesh.
You mean to say that bladder morphology has to become normal to call it a successful valve fulguration?
Good afternoon, sir. Thank you for the question. Actually, we have shown that bladder morphology does improve after adequate fulguration, but we also concluded that even if it has not improved, the symptomatology of the patient improves. It's not drastically different, significantly different as compared to patients who started with a good morphology bladder, is what we are trying to convey.
Dr. Dasmeet, please.
Dr. Deepti, nice presentation. My question to you is that even though the morphology improves, is there any correlation between the clinical outcome, especially in the long term? So you have two scenarios, one where the morphology is not improving, and the second scenario where fulguration is improved with the good morphological improvement. And in the long term, you see any disadvantage or advantage?
Sorry, Dr. Dasmeet, there's a lot of background. Yeah. Maybe you can repeat the second half of the question, sir. I think Deepti would have missed it as well.
Did you get the question, Deepti?
So first half I got, I will answer
Yeah,
that.
basically the same thing.
Yes,
so
sir.
the clinical outcome, how well does it correlate with the morphological outcome? That's my question.
Yes, sir. Sir, actually, we only compared the pre-op morphology of the bladder with the final outcome clinically. We have seen that the bladder has improved, but we did not compare in the end if the bladder has improved in morphology, how is it doing in the end, and not in these tables at least. But what we saw is that even if we start with a very poor bladder morphology, they are not doing very, as in, it doesn't create a statistical difference as compared to a good morphology bladder.
I'm not clear on what exactly the point that you're trying to make.
So I'm trying to say that whether the bladder is good or bad morphologically to start with, it is not significantly affecting the clinical outcome as long as the fulguration is adequate.
Okay, so how are you defining clinical outcome?
So based on bladder diary data, accidental leak, frequency.
Okay.
Sure, I think we'll have to close the question here, sir. Munir, do you have a quick comment or a quick question? Otherwise, we go on to the next one.
Yeah, just one question. I just want to know whether you have excluded patients who are on bladder pharmacotherapy, because that can lead to bias.
No, sir, but we have also I had not shown in these results, but we did compare them with the outcome patients who were on pharmacological therapy as well.
Okay.
Right. Thank you, Dr. Deepti. Dr. Riaz, please start sharing your screen. Yes, it's visible. Please make it full screen and then start.
Can I start?
Yes, please.
So, greetings from Srinagar. I am Dr. Riaz Ahmedwani from Department of Pediatric Surgery, Super Specialty Hospital, GMC Srinagar. We are presenting our experience of congenital bladder diverticulum. The diverticulum is defined as a herniation of bladder mucosa between fibers of detrusor muscle. The first case of primary bladder diverticulum or congenital bladder diverticulum was described in 1959. So the characteristic feature in these diverticula is the bladder is smooth and there is no intravesical obstruction. That's why it's called as primary bladder diverticulum. So it occurs in areas of weakness in the embryological junction of incomplete muscle fusion, that is near the uretrovesical junction. So incidence is 1.7%, 90% are paraureteric, mostly single, more common in males, so posterior lateral in location, and often associated with VUR. There are certain syndromes associated with this entity: prone belly syndrome, kinky hair syndrome, Williams syndrome, Ehlers-Danlos syndrome, and etc. Presentation is usually asymptomatic, diagnosed prenatally or incidentally diagnosed, and symptomatic patients usually present with urinary tract infections and voiding dysfunction. Routine investigations are ultrasound KUB, MCUG is the gold standard, DMSA is usually done in patients with reflux, and cystourethroplasty is recommended just before surgery. Treatment is diverticulectomy with ureteric reimplantation, especially for patients who are symptomatic and high grade of reflux. So modalities of surgery are open surgery and minimal invasive surgery, including vesicoscopic, laparoscopic, or robot assisted surgery.
Dr. Vani, your screen is frozen. Can anybody else see or hear him?
No,
we can't.
We think it is due to Dr. Ria's internet bandwidth.
Yeah. So maybe we'll wait for some time and see if we can reconnect. Otherwise, Dr.
Patients over last 10 years.
Okay. Have we lost Dr. Vani?
He is here.
I thought he had just reappeared.
Yeah, he did and then disappeared. Oh yeah, he's back again.
Riaz, if you can hear us, please say hello.
You have to, yeah.
Hello?
Yes, Dr. Riaz.
Yes, we can hear you, Riaz.
Yes, there is some problem with the connection, internet connection. So is the screen visible?
It is visible. You were frozen from your treatment slide, so maybe you can take it up from there again.
Is it moving?
It is.
Okay. So these were the bilateral cases with bilateral diverticulae. And these are the intraoperative photographs showing the diverticulum. This is the bladder, this is the ureter. And the last picture on the extreme right is the lower extreme right is the bilateral diverticula with the ureters in situ. So we have a total of 24 patients, all were symptomatic, and there were 19 males, 5 females, age ranging from 3 months to 7 years. Voiding dysfunction and febrile UTA was the most common complaint. So unilateral were 19 and bilateral were 5, and the surgery chosen was approach was extravesical in all of them. Diverticulectomy with ipsilateral ureteric reimplantation was done in all of them, except in bilateral cases where the higher refluxing side we would do uretrostomy and wait for maybe 2 years. So follow-up was 6 months to 10 years, and we used to follow clinically sonography and cystoscopy at the time of stent removal. So to conclude, this congenital bladder diverticulum, the diagnosis is by MCUG, which is the gold standard, and surgical treatment is warranted in symptomatic or those associated with high-grade reflux, and results with extravesical approach are excellent. Thank you.
Thank you, Dr. Riaz. Dr. Dasmeet, we can start with your question.
Riaz, please unshare your screen. Yeah. Good lot of cases, I would say. 24 is a very big number. What is your experience about neurogenic bladder following surgery? Because generally, extravesical approach, especially in any large amount of dissection, would be a higher would lead to a higher incidence of postoperative neurogenic bladder. What has been your experience on that?
since all of our patients were symptomatic, so post-surgery, none of the patients, they improved significantly symptom-wise. So we need not evaluate much in those patients because they were symptomatically better. But yeah, if some of our patients comes with features of maybe UTI or any other symptom that can point us towards the entity, then we can evaluate, we can do urodynamic evaluation and other things.
No, even without urodynamic evaluation, the stream of urine, whether they go into retention after you remove the catheter, any such episodes, or they have.
Yes, sir. That's what I'm saying. None of our patients had symptoms during the follow-up.
All right. Fair enough.
Dr. Ramesh, your question, please.
I share the same concern with Dr. Dasmit. Postoperative retention after this diverticulectomy is well known, and I have myself seen in some patients. This is because you go very low down and then dissect outside. And sometimes you may have to go intravesically to repair the detrusor properly. Whereas when you go extravesical, you may not see the defect as well. And that's my feeling as well.
So we have done extravasically in all of our cases, and we have, I don't remember, we don't have done any intravesical thing.
Fair enough. Munir, any quick word?
Yeah, Riaz, you must be doing post-operative follow-up with the ultrasounds. Are you keeping a check on post-white residual urine in the patients?
Yes, sir. Yes, sir.
So anything
pre-operatively, yes, there have been a few of our patients where there was a significant retention, post-white residual, high volumes of post-white residual. It has improved. Actually, I have not. We have not included it in the slides. Yes.
that can be used follow-up.
Yes, sir. Yes.
That's it. Thank you.
Right. Thank you, Dr. Riaz. We move on to the next presentation by Dr. Varun. Please start your screen share.
Am I visible and audible?
Yes, you are. Please start.
Good evening, everyone. Greetings from ESIC Super Specialty Hospital, Sanat Nagar, Hyderabad. I am Dr. Varun, presenting long-term outcomes in children with posterior urethral wall undergoing primary wall ablation. I have nothing to declare. 25 to 40% of the PV patient develop renal failure at varying ages. So identifying the prognostic factors can help in planning the management and serve as a guide for parenting counseling also. So the aim of the study is to identify those factors and their significance. It is a retrospective cohort where the previous records have been noted, and 45 patients have been noted, wherein all PVs diagnosed were fulgurated using Bugbee electrode. Serum creatinine was measured in the lab using JAF reaction in analyzer, and GFR was estimated using Schwartz formula. Urodynamic study was done when the patient reaches 6 months of age, and oxybutynin is started if there is an indication. Whereas if in case of urodynamics are not available or not feasible, based on the MCUG and bladder diary and cystoscopic picture, we will start oxybutynin on empirical basis. So in the diagnosed cases, 16 patients had antenatal findings of hydronephrosis, unilateral or bilateral, but there was no oligohydramnias. The mean age at admission was 3 months, and at presentation, the creatinine, the median value was 0.5, and at follow-up, it was 0.4, and at follow-up, the estimated GFR is mean of 68.88. And the nadir creatinine was 0.4, and the follow-up period was 84 months with a maximum follow-up of 15 years and minimum of 1 year. And the VURD phenomenon was observed in 8 patients, and recurrent UTIs were observed in 8 patients. The vesicouretic reflux was observed in 21 patients in our cohort, wherein 6 had bilateral vesicouretic reflux. And those who underwent fulguration, majority were in the infantile age group of 33 number, among whom 17 were neonates. So among this cohort, 9 patients observed to have developed CKD and at various stages. So if we do the univariate analysis between the CKD less than 3 stage and CKD greater than equal to 3 stage, it has been observed that the presence of bilateral VUR, recurrent UTIs, high pressure system, and the presence of scars in DMSA and the nadir creatinine of greater than 1 observed to be a predictor for greater than equal to 3 CKD stage. However, because the numbers are low, the statistical significance couldn't be made. The urodynamics were available in 27 patients in the initial workup of the patient, wherein 19 had high pressure system. Subsequently, on treatment, 13 patients improved their bladder dynamics, whereas in 6 patients the compliance didn't improve even after the treatment. And oxybutynin was started in 29 patients, where 10 we have started on empirical basis. So based on this data, majority had a good renal outcome, which is comparable to the previous study, because in this study, majority presented in the neonatal infant age group, and very good urodynamic evaluation and oxybutynin use was done. And wherever appropriate, the CAC and triple time voiding was used in this study. There was no mortality in this study. These are the factors in literature which have been identified as a prognostic predictive factor for ESRD. And this is the predictive score developed by Vasconcelos et al., wherein based on the baseline creatinine, nadir creatinine, and proteinuria, different points are allotted so that the prediction can be done, and accordingly parents can be counseled and managed. And a study by Badudi et al. Also identified the plasma-reading activity also as a significant factor in predicting the renal outcome. The limitations.
Sorry for inconvenience. The time is over, sir.
Yes, sir.
You can finish your last slide.
To conclude, early diagnosis using Bugbee electrode provide good renal outcomes, and presence of VUR and nadir creatinine value predict the renal outcome and also help in prognosticating. Early urodynamic evaluation, bladder management with oxybutynin will help in improving the renal outcome. Thank you.
Right, thank you, Varun. Dr. Munir, we can start with your question.
Yeah, very good presentation, Varun.
Thank you, sir.
Very nicely managed patients. I just want to know about urodynamics protocol which we have followed up in this patient, the youngest patient where you've done UDS.
Yes, sir. So, sir, actually, our protocol is the catheter, the smallest size catheter available with us is the 6 French one. So,
no,
we can
ask timings about UDS. When do you do it?
At 6 months of age, sir. Actually, when the child is at 6 months of age, we will do urodynamic studies.
Normal urodynamics or the video urodynamics? Because good number of patients.
Actually, video urodynamics is not available, sir. So whenever viewer is present, sir, we will be referring the patient to the video urodynamic setup station, so that that fallacy of low pressure, the pressure will be counted, sir.
Okay, thank you.
Right. Dr. Ramesh, please.
How many newborns were there in your study?
So 17 newborns were there, sir.
Okay, and in the rest of them, is there any particular reason why you preferred a Bugbee over a hook electrode or hook resectoscope?
Sir, since beginning, it is a practice to do with the Bugbee electrode, sir. Yes.
Yeah.
Dr. Dasmeet.
I think since the time is up, no questions.
Sure. Thank you, Dr. Varun.
Thank you.
Dr. Akash, please start your screen share.
Is it visible, ma'am?
Yes, it is. Please start.
Good evening, respected teachers. I am Akash Mishra from Institute of Medical Sciences, Banaras Hindu University. I am going to present a preliminary study to determine the role of urodynamics in lower urinary tract dysfunctions.
Can you put it to full screen, Akash?
Sorry.
Yeah, that's okay.
Not to be clear, urodynamic studies have become common practice in the evaluation of infants and children with neurogenic or non-neurogenic bladder. Children are referred for UDS to determine the etiology of incontinence and or restlessness of lower urinary tract symptoms. The usefulness of UDS lies not only in its diagnostic advantages, but also in its ability to provide feedback and to give efficient treatment. Our aim was to characterize lower urinary tract function in an efficient, reliable, and reproducible manner to enhance understanding of lower urinary tract function in various disease states. The study was conducted in outpatient Department of Pediatric Surgery, Institute of Medical Sciences, BHU, over a period of 20 months from October 2019 to May 2021. And patients with lower urinary tract dysfunction, that is PUV, neurogenic bladder, neural tube defect with symptoms like daytime incontinence, patients having nocturnal incontinence were included in the study. Patients who refused for the study were excluded. Methodology in all the study was done in the patient using Levry urodynamics. Parameters noted were compliance, bladder stability, bladder capacity, detrusor pressure during voiding, detrusor sphincter dyssynergia, and post-voidal residual urine. Total number of patients were 20, posterior wall patients were 6, and neurogenic bladder patients were 14. Age ranged from 2 years to 14 years, and mean age was 4.5 years. Urodynamic finding in patients of PUV, 50% of patients had good compliance, and 33% of the patient had poor compliance. 66% of the patient had sustained detrusor pressure during voiding, and 16% of patients has unsustained, and 16% has myogenic failure. 50% of the patient has normal bladder capacity, wherever 33 has decreased bladder capacity. 83% of the patient of PUV have insignificant post-voidal residual urine. In patients of neurogenic bladder, 28% of patients had hyperreflexia, 42% of the patients had good compliance, and 28% had poor compliance. And 50% of the cases of neurogenic bladder has unsustained detrusor pressure during voiding, and 35% of the patient has sustained detrusor pressure during voiding. 64% of the patient has increased bladder capacity, and 21% has normal bladder capacity, and 14% of the patient has decreased bladder capacity. 64% of the patient has insignificant post-voidal residual urine. Coming to the discussion, in PUV patients, there is progressive stretch injury to the bladder, which leads to non-reversible changes in the cellular and extracellular characteristics of the bladder, leading to bladder dysfunction. 3 patterns of bladder dysfunction is seen in PUV, that is hypercontractility, hypocontractility, and myogenic failure. Hypocontractility seems to be the predominant pattern. Urodynamic pattern changes with age, and that hypocontractility was probably a step towards detrusor decompensation, which may lead to myogenic failure with time. Therefore, myogenic failure is likely end stage of bladder dysfunction in PUV with boys. The end result in the bladder is gradual loss of bladder compliance, reduction in capacity, and high storage pressure, bladder instability, and poor compliance. Urodynamics in neurogenic bladder shows 3 types of findings, including synergic in 24% of cases, dysynergic in 43% of cases, and complete denervation in 33% of cases. Sacral agenesis patient reveal acontractile bladder and extensive denervation in the urethral sphincter or detrusor overactivity. Coming to the conclusion, UDS can provide accurate clinical information for diagnosis and guide treatment decision in lower urinary tract dysfunction and neurogenic bladder dysfunction. A dedicated staff and facility with extensive knowledge of proper technique is the cornerstone for the success. Thank you.
Thank you, Akash. Dr. Ramesh, your question, please.
I want to ask, do you get a voiding cystourethrogram before aerodynamic study, or you do a video urodynamics?
Sorry?
Do you do a video urodynamics, or you get an MCU before, because you'd want to know the status of the reflex bladder outline?
Basically, we don't have video urodynamics in our setup, so we used to do a MCU prior to urodynamics, then we perform our urodynamics study.
Right. Okay.
Yes,
Dr. Dasmeet, please. I trust he's on the phone. Dr. Dasmeet, your question, please.
Yeah, actually, I got. First of all, it's a nice presentation, Akash, and especially because you gave the live feel. You're standing up and at a podium and presenting, so that is pretty good. Okay, my main question is that how did the urodynamics finally correlate with your clinical management further?
Sir, basically, with the urodynamics, we see whether the patient is having any overactive bladder or the patient is having if in case we find that patient is having an overactive bladder, we used to prescribe them anticholinergic like oxybutynin, so that patient can have relief symptoms. In cases in which there is neurogenic bladder and the volume of the bladder is very large, then we prescribe CIC, so that to prevent the further deterioration of the upper renal system, sir.
Any alpha blockers used?
Sir, till now we have given oxybutynin and tolterodine.
No, so nowadays we are giving oxybutynin by default to every patient. Yes. So how did urodynamics then finally help you?
Sir, it decreases the symptoms like the children who are having overactive bladder, continuous dribbling of urine, and it's in a follow-up of 6 months, we have seen that the frequency of dribbling has been decreasing in such patients which are prescribed with the anticholinergics.
Can I rephrase the same question Dr. Dasmith is asking? He's probably asking, do you have to do urodynamics because you're going to start oxybutynin in most of the patients?
Sorry, sir, I didn't get that.
Do you have to do urodynamics? Because there are many centers in India where you do not have urodynamics, and then you go by clinical methods and start pharmacotherapy.
Yes, sir. In cases there is, in cases like posterior urethral wall, where there is incontinence after the wall fulguration, or there is persistent infection, or there is persistent hydronephrosis, we usually perform urodynamics, sir.
Right.
Puneet, your question, please.
It seems you have studied detrusor pressures only. Did you put any effort to study the external sphincter function also?
Sir, our that electromyography things were not working after 3 cases. That's why, sir, we were not able to comment on.
Correct to label lower urinary tract dysfunction in absence of EMG.
Sir, in 3 cases it were included, and yes, sir.
Oh, that's okay.
All right, thank you, Dr. Akash. Next presentation will be by Dr. Sheshadri. Please start your screen share. Your screen is visible. You may please start.
Good afternoon. Does PAR correlate with effective ablation? A study of 47 children. Myself, Dr. Sheshadri. Warm greetings to all delegates. Hello.
Yes, you're audible. Please. Yeah.
Warm greetings to all delegates from Indira Gandhi Institute, Bengaluru. The aim of our study was to compare the posterior-anterior urethral ratio pre and post fulguration in posterior urethral valve. Our study design was a descriptive study of 14 months duration, a period January 2020 to March 2021 at our department. The PAR was calculated by dividing the maximum posterior urethral diameter by the anterior urethral diameter measured in the oblique voiding phase image of the micturating cystourethrogram. For data collection, pre and post-op at 3 months, we inquired regarding the stream. From the micturating cystourethrogram, we collected PAR. For the upper tract dilatation, we saw vesico-urethral reflex, that is VUR, and for renal function, the serum creatinine. A total of 59 children during this period, of which we included 47 who underwent PUVAB ablation. The age distribution, most of the children were within the age of 6 months, with 14 in the newborn and 22 infants. 60% had an antenatal suspicion. Coming to the presentation, 13 presented with poor stream, 5 with dribbling, and 8 had both. We noted successful outcome in 40 of the patients. 22 of the 26 reported improvement in the stream, and 11 out of 13 improved in dribbling, both about 84%. We noted normalization of the serum creatinine in 65% of the children and a decrease in 25%, while there was no change in 10%. In the pre group, there was VUR in 22, 15 unilateral and 7 bilateral. Of the 15, 11 were grade 4 and 5, that is high grade, and in the bilateral 3. We noted that there was complete resolution in 6 and significant reduction in 13. Of the high grade unilateral, 8 had reduced, and in the bilateral high grade, 1 remained the same, 1 reduced and 1 resolved. We calculated the PAR mean in the pre and the post. In the pre, we noted a value of 4.61 and in the post 1.8. We carried out the pair T test and we found it to be significantly different with a p-value of 0.0004. The Pioneer study from Mumbai in 2009 reported a pre of 4.9 and a post of 2.1. Another large study in Chandigarh suggested a cutoff of 1.92. In 2016, the study of Dr. Ramesh Babu and group in Chennai noted a pre of 3.4 and a post of 1.8 and suggested a cutoff of 2.2. Our study is in concurrence with the previous studies. In conclusion, PAR is a good indicator of effective PUE ablation, and we can avoid routine check cystoscopy. PAR is objective, reproducible, and comparable between centers and does not vary based on the method of PUE ablation. Limitations: no control group, uroflowmetry and urodynamic study not done routinely, and no routine check cystoscopy. Thank you for your patient hearing.
Thank you. Dr. Dasmeet, your question, please.
Thank you, Dr. Sheshadri. A very nice paper and a very nice presentation. So my question is, supposing you don't see the anterior urethra very well, or it's slightly faint, or if the child has moved a little bit, the width actually changes. How do you rule out these things? Are you going to keep catheterizing and taking multiple values and then taking an average? Second thing is, how do you standardize the position of the patient? Because sometimes the position of the patient is slightly, awkward, slightly more oblique in one, and that changes the actual measurement. So how did you go about correcting these things?
So most of the time, we were able to do it in the right position. We, at maximum, we have taken 2 shoots, not more than that, to avoid excessive exposure. The another thing is, because it is a statistical analysis, sir, though there may be slight variation, we have found that there is a significant difference between 4.6 and 1.8. So statistically, though there may be some variation, it cannot explain so much of a difference.
No, that's not. When we are talking about a cutoff, we are talking about defining a cutoff.
That's why we have not suggested.
That's where it makes sense.
At the end of our study, we have not suggested a separate cutoff, sir. We are in concurrence with the previous studies, like Ramesh Babu sir, which suggests 2.2, and a recent review article has given a cutoff somewhere around 2.2 to 2.3 as acceptable.
Dr. Munir, your question, please.
Yeah, Dr. Sheshadri, since you do not do check scopy, so how do you ensure adequacy of fulguration in your first attempt on table itself?
So at the end of the procedure, we palpate the suprapubic and see the streams on table. So
on cystoscopic view, when your scope is inside, when do you feel I've done enough?
So when at the end of fulguration, so once we remove the scope, we are palpating suprapubic, we are giving pressure, and once it voids, we are able to see the streams. So if we have a doubt, then we are again putting the scope and checking.
Okay. So suppose you have done adequate fulguration and still your ratio is not normalizing to your cutoff. What do you suspect?
Sir, if it is not, we have gone in for a check cystoscopy, sir, in those children, and seen for whether there is a persisting valve. But there are other conditions which can cause still the dilatation, sir.
Right. Thank you.
Dr. Ramesh, your question, please.
I have the same concerns of Dr. Dasmeet and Dr. Munir. See, the anterior urethral width depends on how good the stream is. sometimes if you don't get a good stream, or if you don't catch it in the right place, right point of the frame, you don't see the anterior urethra at all, or you don't see the anterior urethra get to measure it well. So only when you see it, it is useful. If you don't see it, that doesn't mean that it is not narrow. You know what I mean? The other thing is the posterior urethral dilatation is also subject to presence of a reflux. For example, if there is a grade 5 bilateral reflux, that is going to vent the bladder pressures and making the posterior urethra less prominent. So these are the limitations which you have to admit whenever you come to this kind of studies, saying that, you know, it's possible that this is fallacious. And like Dr. Munir pointed out, by only doing a check cystoscopy, you have confirmed that your findings have, you know, correlated with your MCU ratios. Okay.
Okay. Thank you, sir.
Thank you, Dr. Seshadri. We'll move on to the next presentation by Dr. Sravanti. Your screen is visible.
Yes, ma'am. Good afternoon, everybody. Greetings from PGI. Today, I'll be presenting a study on antiurethral valves, a rare but treatable entity. I have nothing to disclose. Antiurethral valves are a rare cause of congenital urethral obstruction in boys. The presentation is similar to the posturethral valves, but it is 25 to 30 times less common than PUV. It has a wide spectrum of presentation, starting from mild urethral dilatation to severe bladder outlet obstruction, and can be missed easily if not cautious. So it is a retrospective analysis done over a period of 5 years from 2016 to 2021 in a single unit in the Department of Pediatric Surgery at PGI. During the same period, we had 106 cases of PUV and 12 cases of antiurethral valves. Most of the patients we had a mean age of 1.5 years, and the majority of them were less than 1 year of age. The presentation was that they had poor urinary stream in almost all. Dribbling of urine was present in 9 patients. Pyonephrosis was present in 2. Acute urinary retention was in 1, and penile swelling was in 1. The renal function tests as per serum creatinine were normal in 11 patients, and 1 had elevated RFTs. And in the renal ultrasonography, 10 patients had bilateral hydrouretronephrosis, 2 had unilateral hydrouretronephrosis, and 6 had thickened trabeculated bladders. In the DMSA scan, which was available for 8 patients, impaired cortical function was seen in 2, preserved cortical function was seen in 4, good cortical function was seen in 2, and scars were seen in 4. The diagnostic investigation is a voiding cystourethrophy, and in the first image, we can see that the anterior urethra is dilated up to the penoscrotal junction, and in the second image, we can see that the anterior and the posterior urethra, both of them are dilated. Coming to the management, out of these 12, 3 underwent vesicostomy and 9 underwent primary cystoscopy and transurethral fulguration. In the picture, we can see that the antiurethral valve, which is present at 6 o'clock, after fulguration, the increase in the diameter of urethra can be easily seen. According to the Furley classification, in our study, we had 6 patients of type 1 AUV, 1 patient of type 2, and 0 patients of type 3, and 5 patients of type 4 AUVs. Vesicostomy was done in 3 patients, 2 in the isolated AUV group and 1 in the combination of AUV and PUV. Out of them, one underwent vesicostomy because he could not be fulgurated for technical issues, and 1 presented with severe pyonephrosis, so he was taken up for upfront vesicostomy, and the other was referred to us with a vesicostomy, and we have done a fulguration later on. Out of these 12, 3 AUVs were, 1 presented as a posterior urethral valve and was repeatedly fulgurated but had persistence of symptoms, and later on AUV fulguration was done, and 1 more patient presented with AUV with left VUR, and AUV was missed, and he underwent a left ureteric reimplantation outside and referred here later, and the other child was managed as a recurrent UTI. Over a period, we followed the patients for around 1 to 6 years with a mean period of 3.5 years. Out of 12, 10 are doing well with improvement in urinary stream and RFTs and ultrasounds. 1 had renal failure and expired. 1 patient who underwent fulguration developed stricture post-lateral to it and underwent peritoneal urethroplasty, and the 2 vesicostomy patients are awaiting closure. To conclude, AUV is a rare but correctable cause of congenital urethral obstruction. They can be presented similar to as PUV, and so caution must be present when evaluating in a VCUG. Fulguration is important as it is a mobile part, and there are high chances of injury to urethra, and follow-up should be long-term. Thank you.
Thank you. Dr. Munir, your question, please.
Yeah, no questions from my side.
All right, Dr. Ramesh.
Yeah. See, sometimes when we see a patient with a mega ureter, like either refluxing or obstructed, we call the dilated or the changes at the PUJ as a secondary PUJ. Like that, in a patient with an anterior urethral valve with the entire dilated anterior urethra, what you think as a PUV could be a secondary phenomenon, like a just dilatation or kinking rather than real valve? Do you get my question or not?
No, sir.
Yeah, so what I'm asking is, you said some patients have AUV and PUV. Was it a really PUV or was it a kinking because of the dilated entire anterior and posterior urethra?
No, sir. They really had PUV and they did not have a kinking because of the.
So you did a PUV fulguration and an AUV fulguration, right?
Yes, sir. Those patients underwent fulguration at both the sides.
Okay. Now, other question, my second question is, like, I have a feeling that the anteriourethral valve children are at slightly better risk or lower risk of getting a CKD or renal impairment than PUV children. Do you agree with that, or is that different from your finding?
No, sir. They are less prone to develop renal failure. PUV usually for 25 to 40% of them develop CKD, but in AUVs, less than 5% develop CKD.
That's what I was saying. Yeah. Okay.
My question is on the practical side. Shravanti, good presentation. My question is, what is the objective criteria to call it anterior urethral valve or a posterior urethral valve?
So anterior
Sometimes it's like a picture on MCU. When can you definitely say, okay, this is definitely anterior urethral valve, and this is definitely only posterior urethral valve?
If there is dilatation of the urethra distal to the bulb of the bulbous urethra, then we can say it as an AUV, sir.
But that, how do you determine that? On an MCU, how will you determine it? It can't be pure guesswork, no? So there must be some criteria when you look at it, you call it anterior urethral valve.
Do you say that is it something at the level of the vermontanum or distal to the vermontanum, something like that? Is that what?
Distal to the vermontanum, we usually have anteriourethral valves, sir.
So if the caliber changes distal, then you call it an anteriourethral valve, is it?
Yes, sir.
I'm trying to help you.
Right. Thank you, Dr. Shravanti. If there are no more questions, we'll move on to the next presentation. That is by Dr. Madhur Anand. Please start your screen share. Yes, we can see your slides. Please unmute yourself.
It is there in the list of the topics, because I don't see that.
In your marking list, sir?
Yeah, that's what I'm saying.
It may not be there, so you can just put it as a last comment and put the name and the paper name. There's a last column of comments, sir. Maybe you can put it there. Right, Dr. Madhur, please start.
Okay, thank you so much, ma'am. Myself, Dr. Madhur from SCPJ Lucknow, Division of Pediatric Urology, and I'm going to present on dysfunctional voiding in PUV, a misdiagnosis. So, as we all know, despite early valve fulguration, many of the posterior urethral valve children ultimately end up in bladder dysfunction in myogenic failure. And lower urinary tract symptoms in these children have quite a lot of overlapping features with those patients who have dysfunctional voiding or bowel bladder dysfunction, as we say, and they are also prone to recurrent UTIs. So we also encountered such a patient who had some degree of voiding dysfunction that persisted even after valve fulguration and bladder neck incision for high bladder neck. And then when we evaluated this patient, we found that he was having actually bowel bladder dysfunction with the external sphincter activity in the voiding phase. that is seen in the spinning top kind of appearance here also. So we went through a literature search to find out the prevalence of dysfunctional voiding in general population, and we came to a conclusion that it may vary anywhere between 4.2% to 63%, depending upon which study we are quoting. So in posterior urethral valve children, actually, they are anyways at higher risk of recurrent UTIs and CKDs. So we aimed this study to find out the prevalence of dysfunctional voiding in children with posterior urethral valve and to corroborate the findings with urodynamic parameters to formulate a hypothesis for future studies about it being a high-risk cohort for urinary tract infection, bladder decompensation, and recurrent UTIs. So it is characterized by dyssynergic status sphincter activity due to inadequate or variable relaxation of the external sphincter in the absence of a proven neurological etiology. The schedule for this study was 1 year, from September 2020 to September 2021. We recently completed all the assessment of the patients, and the design was prospective observational study. We actually, while coming to the conduct of the study, we reviewed the patients who underwent valve fulguration in the last 8 years, and we found a total of 198 patients. We reviewed their record for any presence of any staccato pattern, intermittent pattern, or mixed pattern on uroflowmetry, and persistently dilated posterior urethra on post-valve fulguration VCUGs, or any spinning top appearance. And we contacted those patients to find out the history of the patient before valve fulguration and after valve fulguration, and asked them to fill up the DVSS scoring system that was devised by Farhad et al. In 2000. And then we also asked them in detail about the constipation, the history of constipation, and we graded them as per the Rome-4 criteria. We took help of the Bristol stool charts also. And then we screened them with the uroflowmetry that was repeated for at least 3 times with voided volume more than 50% of the estimated bladder capacity. And PVR, we considered it significant when it was more than 20% of the estimated bladder capacity. And on that, if the findings were of staccato, intermittent, and mixed pattern, then we went further for Uroflow EMG, CMG, EMG, or video urodynamics. Then we tried to characterize it, whether the patient had the sphincter activity during voiding or not, and whether there was any spinning top appearance or not. And then we came to the results. So ultimately, we were able to find a total of 86 patients, which were included in the study after eligibility criteria and who had all the previous details and a proper history also. So the age for these children ranged between 6 plus minus 0.5 years, and average DVSS score was 2.6. Constipation was present in 20 patients, that is 23.25% of the population. 14 of these patients were on intermittent laxatives less than 3 times a week. 2 were taking more frequent laxatives, and daily laxatives were being taken were being administered for 5 patients. These were the DVSS questionnaire that we found, and the uroflowmetry pattern consisted of bell-shaped pattern in 45 patients, tower-shaped pattern in 13, staccato, intermittent, and mixed patterns were seen in 13, 5, and 10 patients respectively. These 28 patients were further taken up for uroflowmetry, EMG, video urodynamics, and CMG, EMG, and we found out of these 28 patients, only 11 patients were showing sphincter activity or spinning top appearance on video urodynamics. And on post-valve fulguration VCUGs, we found that 25 patients had dilated posterior urethra with the urethral ratio of more than 3. We did check cystoscopy in all these patients, and we found that there were only 4 patients who had residual valve. Now we came to the subset analysis of these 11 patients, and we found that 6 patients had a history of constipation, 7 had history of recurrent UTIs, that is 66.6% of this subset. And 5 patients underwent check cystoscopy for dilated posterior urethra, and none of these patients had residual valve. So probably there was something else other than the residual valve that was causing the persistently dilated posterior urethra in these patients.
Respected doctors, the presentation time is over.
I will take only a few slides. There was no statistically significant correlation in these variables, but constipation, dilated posterior urethra, and recurrent UTIs were significantly correlated. The take-home message is it is not uncommon in children with posterior urethral valve. Probability should be sought in patients who had recurrent UTI elimination issues and persistently dilated posterior urethra. And video urodynamics and CMG with EMG or Uroflow with EMG can give us a definite lead. Thank you so much, sir.
Thank you, Madhur. Dr. Ramesh, your question, please.
Were these patients on oxybutynin because oxybutynin is known to cause constipation?
Sir, these patients actually, after the video, for the video urodynamics and for that part, we had stopped the anticholinergics. And
no, that is not enough. I mean, if they've been having constipation for a long time, they may have an abnormal bladder dynamics and outlet obstruction kind of appearance, even if you stop it for the urodynamics.
Yes, sir. That is true, sir. But most of these patients, they were not. But I will again go through the data and find out whether any of these patients
Okay.
we have found out.
My second question is, there is some people talk about this external sphincter spasm in addition to the valve. Is that something which you found during your chest cystoscopy? That's what I'm interested in, because I really don't think that is there. But some people say that rhabdosphincter spasm is a feature of a posterior valve.
Sir, we don't find this kind of findings, even though it is described in the literature. But under anesthesia, anyways, it is very difficult with all the anesthesia.
Dr. Dasmukh?
No questions from me.
Sure. Munir?
Yeah, Dr. Madhu, can you tell us what was the average age at fulguration? I mean, how many patients had neonatal fulguration and how old fulgurated later? Because delayed fulguration is associated with increased incidence of dysfunction.
Sir, most of the children that present to us are between the age of 1.5 to 2 years, but many patients present even earlier also. But neonatal fulguration, as we do not have a neonatal unit right now in our hospital, it is relatively difficult for patients to reach here in earlier age also. But if the patients present to us, then we will definitely go for neonatal fulguration also. But it was less, sir.
Majority of the patients had derailed presentation. So that's why you had more number of voiding dysfunction patients.
Sir.
Okay.
Thank you, Dr. Madhur. With that, we come to the end of session 5. I thank all the judges and thank you, the participants as well, for finishing in time. So I trust if all the presenters and judges for the next session are there, even though it was supposed to start at 4:50, if Dr. Ravi permits, we can go ahead and start the next session. Dr. Ravi or anybody from the primary host team?
Okay, thank you, Brinder.
Thank you, sir.
Yeah.
Thank you for joining us. Is Dr. Ravindran already there, the judge for the next session?
No, ma'am, he is not joined yet.
I guess Dr. Prakash would also not be joining. He's in a surgery, he texted, so he may or may not join.
I just have a word with Prakash and Ravindran. They are coming just in 5 to 10 minutes.
Sure. So I guess we'll wait it out then.
Sure.
Thank you. So I guess we'll have a 5 minutes break and then see whether both of them have joined and then take it further.
Dr. Ravindra has been joined with us.
Dr. Ravindran, good evening and welcome for the session.
Shall we start the session?
I was just waiting for Dr. Prakash. Is Dr. Prakash joining?
My team is contacting Dr. Prakash right now.
Sure, because he initially said that he'll be in a surgery, so he may get delayed. So if we don't hear from him in another 1 minute, we can start. Is that okay with you, Dr. Ravindran? Is our first presenter with us, Dr. Uday Shankar?
Yes, ma'am. Am I audible, ma'am?
Yes, you are audible.
Shall I share my screen, ma'am?
You can start sharing your screen, but maybe we'll wait a bit to start the session. Just waiting to hear from Dr. Prakash a final word, and then we can start. Dr. Ravindran, I hope you have your scoring sheet with you. You are muted, sir. Can you unmute yourself, please?
Prakash sir is with me on call.
Okay.
He's joining in 2 to 3 minutes.
Okay. So I trust we have, anyways, we are before schedule, so we'll wait for 2 minutes for him to join. Please let us know as soon as he joins.
Sure, ma'am.
Thank you.
Ma'am, we can start the session because Dr. Prakash is having some issue with the Zoom application.
Okay, okay.
He's joining us soon.
Fair enough. Dr. Uday, please start your presentation.
Am I audible, ma'am?
Yes, you are.
Good evening, sir. Ma'am, I am going to present case series of pull-through vaginoplasty for complex urological problem, which was handled in Central Northern Unit, ICH, Madras Medical College. Case 1, 2 years child presented initially with mass abdomen in the newborn period. External genitalia shows the single opening. Anus was normal, for which the child underwent a tube vaginostomy in the newborn period. Now the child admitted for the definitive procedure. We did a contrast through tube vaginostomy. The contrast was entering into the bladder. The plasticitogram was done. The plasticitogram noted the long common channel and the contrast studying both the vagina and the bladder. We proceeded with the cystogenitoscopy. Cystogenitoscopy reveals a long common channel and the vaginal opening was noted in the posterior aspect of the common channel. It's around more than 4 centimeters. We planned a abdominoperineal pull-through vaginoplasty, keeping in vaginal replacement in mind because it's a long common channel. We went through the lower midline laparotomy incision, and the tube vaginostomy was disconnected, and the fishless opening was noted in the long common channel. The vagina was disconnected. This is the disconnected vaginal portion. Then we underwent the perineal pull-through. The inverted U-shaped incision was made. The inverted U-shaped incision, we bring down the disconnected vagina, which
5:30 to 6.
Which enables the uterus to sink into the pelvis. This is the immediate post-op image. The child followed up with dilatation. The child still on follow-up. Now the child on 18 agas. Then I move on to the case 2, 10 years female child with a single perineal opening. That's a persistent cloaca and transverse colostomy in newborn period at ICH. The child was urinary continent. No hydrometroculpus on follow-up. We did a flush genitogram. Flush genitogram reveals the septate vagina. This is the vagina. This is the bowel with contrast entering into the bowel. MRI coronal image with T2-weighted image shows this is a rectum and septate vagina and a bladder. We did a glycoscope through which the long common channel was noted. Vagina was septated. The 2 vagina was noted. Rectum was entering into the one of the hemivagina of the posterior wall. We planned the abdominoperineal pull-through anorectovaginoplasty. we did this is the plane of dissection where we disconnected the rectum first and the vaginal opening first next. So the common channel was closed. This is the intra image. This is the rectum which enters into the vagina, which we disconnected. Then the vagina was disconnected from the common channel. The septate vagina was, this is the, after disconnection, the common channel was closed. We have not touched a common channel to maintain the proper incontinence. Then we pull through the vagina and rectum both in the same way. And follow-up, the colostomy closure was done. And follow child on vaginal dilatation at 18 agas. Child is both fecal and urinary continence. Voluntary control over feces and urine was noted. Occasional soiling was present. Case 3, the 12 years female child. This is the first presentation at the abdominal pain for 3 months. On examination, single opening in the intra-itis. Anus was normal. We thought of persistent UGS and vaginal atresia. This is the intra-itis. Only the urinary opening was noted. So we thought of vaginal atresia. We did the ultrasound abdomen. It shows the fluid collection with internal echoes, which is the hematometrocarpus. MRI axial images shows the uterine tidal piece. So cystoscopy was done. Cystoscopy, only one opening which was entering into the urinary bladder. So we thought of vaginal atresia. We proceeded with the abdominal perineal pull-through vaginoplasty with the previous success in mind. Midline laparotomy was done. Uterine tidal piece was noted. The vagina was bring down to the perineum. This is the immediate post-op image. The child on follow-up. On discussion, complex urogenital anomalies requires individual approach. Goals of this vaginoplasty was creation of an appearance that corresponds to the patient's gender, restoration of function that will enable the individual to lead a normal life, including sexual function and, if possible, reproduction. The child should be both fecally and urinary continence to be preserved. So, in 3 cases, UGS, cloaca, vaginal atresia were managed by combined abdominoperineal approach. These are all my references. Thank you.
Thank you, Dr. Uday. Dr. Ravindran, would you like to start with your question? Can you hear us, sir?
I think, ma'am, Dr. Ravindran has lost connection.
Okay, and I believe Dr. Prakash has joined.
Yes, ma'am.
Yeah, I am online.
Sure, sir.
Virender, you can go ahead, please.
Okay. So, Dr. Uday, what is your age criteria for considering vaginoplasty? At what age?
Actually, we will proceed with a 14 years one. But in first case, we have did in a 2 years because the child is from a native state. So the child mother and father was insisting we have to operate and we have to do the case. So other cases will be around 10 to 14 years.
Okay. And the second question is, have you heard about peritoneal pull-through vaginoplasty? Is there any experience or what is your say on? Yeah.
Yes, ma'am. I heard about the peritoneal replacement with vaginal replacement as a vagina, but we have done nothing in our institute, ma'am.
Okay. And what do you think is or what is the dilatation routine that you usually advise these children in the post-op period?
Actually, we start the dilatation in the first week of post-op period, ma'am. But both cases has to be followed up with full dilatation till the adulthood, ma'am. Till the child is undergoing the sexual life.
Okay. What is the complication? Any complications that you observed in just these 3 cases that you presented?
We are in the initial stages of abdominoperineal pull-through, ma'am. So in these three cases, we have not observed till now. We have not observed any complications because all the cases will be done in the 3 years period. So it has to be followed up long time, ma'am. It's not
so no short-term complications.
No short-term complications. Yes.
Fair enough. Thank you, Dr. Uday.
Thank you.
We move on to the next presentation, that is by Dr. Nirki.
Good evening, ma'am.
Hi, good evening. Please start your slide share.
Yes. Am I visible, ma'am?
Yes, it is. Please start.
Good evening, all. Greetings from Vijay Medical College, Ahmedabad. I am presenting my study on renal function outcomes after complete primary repair of exstrophy bladder patients operated at our institute. Management of bladder exstrophy is a contemporary challenge, and there is no ideal surgical approach as such. Most commonly used techniques include modern stage repair of bladder exstrophy, combined primary repair, and modified stage repair. Historically, a single stage repair of bladder exstrophy was associated with compromise of the upper tract, while the modern stage repair of bladder exstrophy did not impair the renal function. The aim of study is to evaluate the renal outcomes on intermediate follow-up after complete primary repair of exstrophy patients operated at our institute. The patient data were collected from patients operated between January 2010 and January 2020. The parameters which are evaluated includes annual weight, height, serum, creatinine, ultrasound, voiding cystourethrogram, DMS scan, and urinary albumin and microalbumin tests were done in 2019 and 20. The primary outcome is in the form of decrease in the glomerular filtration rate with or without presence of microalbuminuria. Secondary outcome is in the form of presence of vesico-ureteric reflux on VCUG and renal scarring in DMS scan. The results include out of 104 patients which were evaluated in 2019 and 20, 61 patients of bladder exstrophy are included in this group. 45 patients are from the primary exstrophy repair and 16 were the redo cases. Out of which 16 were female patients and 45 were male patients. Median age at the time of initial surgery is 1.7 years and median follow-up duration is 4.1 year. The overall median eGFR is 112 ml per minute per body surface area for both bladder redo and primary cases. There is 8% patient having eGFR less than 90, of which the primary bladder exstrophy group included 2 patients and the redo group included 3 patients. Urinary microalbuminuria was noted in 23% of patients, of which the primary bladder exstrophy group include 10 patients and redo bladder exstrophy group include 4 patients. Renal scar on the DMS scan is seen in 34% of patients, of which 16 are from the primary group and 5 are from the redo group. Vesico-ureteric reflux is seen in 72% of patients, of which high-grade reflux is seen in 12% of the primary patient and 4 patients from the redo group. This is a chart showing classification in various parts like primary patient with reimplant, without reimplant, redo patients with reimplant and without reimplant, and with various parameters. Discussion. Most children born with the classical bladder exstrophy have normal kidneys at birth. Reconstruction of the lower urinary tract with restoration of storage function makes the child at risk. In this series, we report an 8% incidence of CKD stage 2 based on the eGFR values, 22% incidence of urinary microalbuminuria, 34% incidence of renal scarring, and 27% incidence of high-grade reflux. Neither the renal scarring nor the vesico-ureteric reflux correlate with the reduced GFR or microalbuminuria. Primary or redo repair also do not significantly impair the estimation of eGFR. Discussion. Risk factors that result in the kidney injury like pyelonephritis, high-grade reflux, reduced bladder compliance, and the urinary stasis. Few of our patients had reported culture positivity urinary tract infection, but none required admission. The low incidence of this pyelonephritis can be attributed to the high number of patients in which we are doing the urethral reimplantation, or can be attributed to the lack of diagnosis consequent to the decreased access to the primary care physicians. Time from surgery to time to eGFR estimation varies widely from 1 year to 10 years. Hence, long-term follow-up and rigorous measurement of renal function evaluation is required. The strength of the present study is includes a detailed analysis of kidney outcome using the eGFR, microalbuminuria, DMS scan, and vesico-ureteric reflux. Very few such studies are published. The limitation of the study is the lack of preoperative DMS scan, limited availability of data regarding the clinical factors like pyelonephritis, and it does not evaluate the nutritional status of the child. Conclusion. Modern CPR technique for the repair of bladder exstrophy may increase risk of renal scar on intermediate term follow-up, and therefore close follow-up is warranted and necessary. Preoperative screening for dysplasia with DMS scan would help to rule out renal dysformism. No definite correlation exists between the voiding cystourethrogram, DMS scan studies, serum creatinine, and microalbuminuria on preliminary studies. Hence, a standardized rigorous follow-up protocol with periodic voiding cystourethrogram, DMS scan, eGFR, and microalbuminuria estimation is required to assess the ultimate kidney outcome until the child reaches the adulthood stage. These are my references. Thank you.
Thank you. Dr. Prakash, any questions?
Yeah, when you say redo and primary repair,
yes, sir.
Were they redo of your own cases or they were done outside and you redid them?
Sir, most redo mostly is from the outside operated cases only. Only 1 or 2 cases from our patients, sir.
And when do you decide whether to do a reimplant or not to do a reimplant? Because you said some patients you.
Yes,
yeah,
sir.
some patients you did a reimplant, some patients you didn't.
Yes.
So what?
Sir, at the time of surgery, we assess the bladder plate. When the bladder plate is of good size, without any polyp or without any epithelialization, we proceed for the reimplantation, sir.
Okay. Dr. Ravindran, have you joined back? I can't see him here. So anyways, Nirki, your follow-up period was about 10 years.
Yes, ma'am.
So I'm sure many of these patients would have undergone, secondary bladder neck tightening procedures as well. So does that have any correlation, or the level of incontinence, does that have any correlation with the upper tract changes?
Ma'am, in these patients, we have done bladder neck repair at the time of main surgery only.
So you mean
we
to
have
say
not
that, okay.
We have not included patient in which bladder neck repair is done later on, ma'am.
So these are just single stage 10 years and.
Yes, ma'am.
Okay. All right. Thank you, Dr. Nirki.
Thank you, ma'am.
We move on to the next presentation by Dr. Prakriti.
Ma'am, shall I start?
Yes, please. Make it full screen and then you may start.
Good evening, everyone. I will be discussing on gastrocystoplasty and its effect on bladder dynamics and biochemical parameters. There's no disclosure. Children with bladder dysfunction are usually initially managed with non-pharmacological and pharmacological measures, failure of which prompts us to consider bladder augmentation, mainly to prevent renal complication resulting from high pressure and to achieve continence. Gastrocystoplasty per se, there's paucity of studies in India, so we decided to switch over to augmentation gastrocystoplasty in children requiring bladder augmentation, with the sole objective to study short-term outcomes as regards to its efficacy and complications. So coming to methodology, this was a prospective descriptive study including patients between 5 to 18 years of age with reduced bladder capacity and compliance resulting from various primary underlying conditions. Bedside cystometry was done to evaluate bladder volume and compliance, and all the relevant baseline blood investigations and radiological investigations were performed. The period of follow-up was for 3 months, and all these parameters were repeated at the 3rd month follow-up. Similarly, gastric patch viability scan was done on post-operative day 7 and repeated on 3rd month. International Continence Society criteria was used to define incontinence, and revised urinary incontinence score was used to grade incontinence to have an objective analysis. Continence was defined as a dry period of 3 hours with or without CIC. So these are some of the intraoperative pictures. Coming to the results, we had 7 patients who underwent augmentation gastrocystoplasty ranging between 6 to 16 years of age with 5 males and 2 females. The most common indication being neurogenic bladder, and these are the previous surgeries that the patients had undergone. All the neurogenic bladder patients had undergone LSMMC excision in the childhood. 2 patients were PUV and 1 BEC. Adjunctive procedures were performed as and when required in the individual need basis. Postoperatively, there was no significant change in the biochemical parameters and it remained stable throughout the follow-up period. This was similar in accordance with other findings that report stable biochemical parameters, including urea and creatinine. Coming to renal function, the renal function remained stable postoperatively throughout the follow-up period, except in 1 patient who progressed from CKD stage 1 to CKD stage 2. Similar results of improved or stable renal function has been reported in previous pediatric gastrocystoplasties with few instances of progression to ESRD. There is no significant acid-base disbalance in our study, and no patient developed hypochloremic metabolic alkalosis, which is an expected complication of gastrocystoplasty. We observed significant elevation in serum gastrin level on postoperative day 7 as well as on 3rd postoperative month. This could have been a reflex phenomena in response to acid suppression or a sampling error. Bedside cystometry revealed a significant improvement in overall bladder capacity and bladder compliance. Similar reports of improved bladder volume and reduction in bladder pressure has been reported in many pediatric gastrocystoplasties earlier, with some of the studies reporting as high as 200% increase in bladder volume. Incontinence was graded as per these different characteristics. And as we can see, most of the children had improvement in incontinence. And the total incontinence score was compared preoperatively as well as postoperatively, and it showed a significant improvement in the postoperative period. 3 of our patients achieved social continence, and all these 3 patients had marked improvement in bladder capacity and compliance. 2 of these patients achieved spontaneous voiding capability. Of the remaining 3 patients, 1 had vesicocutaneous fistula, 1 was incontinent and diaper dependent, and 1 was partially incontinent for about 2 hours with CIC. Similarly, there are some studies that have reported reduction in bladder capacity and worsening incontinence over time following gastrocystoplasty, requiring re-intervention and composite augmentation. USG and MCOG showed improvement in all patients except 2 who showed mild increment in the VUR and hydronephrosis grade. There was no change in DMSA scan on the 3rd month period. And gastric patch viability scan showed equivocal result in 2 patients, of which 1 patient had a non-viable patch and expired on the 30th postoperative day, and 1 had viable patch on the follow-up scan.
Respected doctors, sorry for the inconvenience. The presentation time is over.
Yes, sir, almost over. 2 patients had febrile UTI and was successfully managed. 2 patients had hematuria dysuria syndrome. 1 was managed successfully with PPI and 1 required prolonged PPI. 1 mortality, and stone and malignancy cannot be commented because this was a short-term study. Limitation being small sample size and limited follow-up period. So given the advantages, especially in CKD patients, we need to revisit and reconsider gastrocystoplasty in pediatric population. Thank you.
Thank you, Dr. Parkiti. Dr. Prakash?
Yeah. Were all patients CKD patients?
Sir, except 1, all patients were different stages of CKD, sir.
Okay. And you told only 2 patients had hematuria?
Hematuria dysuria syndrome in only 2 patients, yes, sir.
Yes. How did you manage them?
Sir, 1 patient required prolonged PPI. 1 patient was managed with ranitidine alone, H2 blockers alone.
Okay. Okay, Virender, you can take out.
Has Dr. Ravindran joined yet, or the host can alert me whenever he is on board, because I have no clues whether he's around.
Sure, ma'am.
Right, thank you. So Dr. Prakriti, are you proposing gastrocystoplasty as being better than ileocystoplasty in all patients or just in those with the CKD patients?
Ma'am, I would not say in all patients, but it definitely needs to be considered in patients with deranged renal parameters and already existing acidosis.
Okay. And did you do any like a mitrophanol or a continent catheterizable channel along with gastrocystoplasty in these
Yes,
patients?
ma'am. Yes, ma'am. All patients had mitrophanol. Most of them had appendicovesicostomy, and in 1 patient, Monty procedure was done.
Okay. All right. Thank you.
Thank you.
The next presentation is by Dr. Dheeraj. Can you please start your, Prakriti, you need to unshare your, yeah, great.
Yes.
Yeah, ma'am.
Dr. Dheeraj, can you please start your screen share?
Sure, ma'am. Sharing, ma'am.
Yeah.
Yeah.
Yes, you may please start.
Yeah. Good evening, everyone. Myself, Dr. Dheeraj from Mirabegron Institute of Child Health. My paper is on to evaluate quality of life in children treated for urinary incontinence. So my aims and objectives include to evaluate the quality of life perspective from the patient and the family from cohorts of patients with urinary incontinence with various causes. So methodology, we have taken retrospective health records from 2008-20. So we have used WHO validated questionnaire, pediatric quality of life 4.0 generic scores, and responses were received by telephone and social media. So we have included children with 8 to 18 years of age and children with 6 months follow-up are included in our study. So, and children who are not available and not responded by patient parents were excluded from our study. So these are the questionnaires. So it contains physical, emotional, and social school. So in physical contains 8 parameters, emotional, social, and school contains 5 parameters each. So the each of the parameters, that is, it contains total 23 parameters. So each parameter is scaled to 0 to 4. 0 is never a problem, that is quality of life is good. 4 is almost always a problem. So scoring, how do we score this course is quality of life is parameters are reverse scores linearly and transformed to 0 to 100 scale. So reverse scoring, how it is done is if it is 0, it's 100, 1 is 75, 2 is equal to 50, 3 is 25, 4 is 0. So higher score, that is if it is 100 is higher score, that is higher scores indicate better health related quality of life. So we have used descriptive analysis was carried out by frequency and proportion for background characteristics of the study population. Independent t-tests were used to compare outcome variables between 2 categories of experimental variables. And we have used RStudio version of for statistical analysis. Results, when we come to the clinical profile of the patients, out of 95 children included study, 21 were taken. So 24 were excluded, 3 died because of renal disease and 21 were not traceable. So 64.8% were in the age group of 8 to 12 years of age for whom quality of life questionnaires was answered by their parents. And 35.2% were in the age group of 13 to 20 years of age. So in our study, males are more dominant more than the females. So males include 50 patients, females are 21. So the patients who are on CIC are 69%, who are not on CIC were 31% of patients. And the result, when you come to the comparison of quality of life between the male and female patients, females have better quality of life in all the parameters compared to the male patients. So and quality of life in patients aged 8 to 12 years of age, children in 8 to 12 years of age had good quality of life, and physical and social functioning were better than emotional and social parameters. So statistical significant difference noted compared to other studies. So, and when we come to the quality of life score in patients 13 to 18 years of age, these age group had decreased quality of life versus compared to the 8 to 12 years of age in our study. So emotional, social, school functioning, quality of life decreased in these children. Emotionally, the children were disturbed and felt angry while doing CIC and who has incontinence. So they have trouble getting along with the peers and they are getting teased. So they have difficulty in concentration in studying. So the comparison of quality of life between the patients who are on CIC and who are not on CIC, there is slight improvement in CIC patient quality of life on CIC patients, and the school environment was not conducive for some children who are on CIC. So CIC, because on quality of life, we can see here the quality of life in school functioning is decreased compared to the not on CIC. So CIC may leading to school absenteeism and poor scholastic performance who are on CIC in our study. So comparison of quality of life between the patients who underwent Mitrofenov on CIC and per urethral CIC. So we can see the patient, children who are girls are doing better on Mitrofenov than boys, and emotional, social, and school functioning were more with quality of life was more with Mitrofenov CIC than per urethral CIC. And in our study, lowest quality of life is seen in anatomical malformation group, possibly associated fecal incontinence the child had. So in discussion, so overall quality of life is safe compared to other studies, and females on CIC have better quality of life, which is similar to other studies, and better quality of life is seen in Mitrofenov CIC children than per urethral CIC children. So conclusion, so overall quality of life is good in most of the parameters, and quality of life is in CIC is better but not statistically significant compared to not on CIC children, and better in girls quality of life than boys, and quality of life in Mitrofenov is better with no Mitrofenov in most of the parameters in our study. So limitations is size of the study, and pre-treatment quality of life was not evaluated in these children, and there is no cutoff value for quality of life in this study, and multiple variables due to various underlying conditions may affect the quality of life in these children. Thank you. These are references.
Thank you, Dr. Dheeraj. Dr. Prakash?
Yeah, Dr. Dheeraj, did your cases include patients of incontinence after surgery, or primarily they had incontinence for some other problem?
No, sir, only urinary incontinence, sir.
Urinary incontinence?
Yes, sir.
Following any surgical procedure, or primarily like exstrophy bladder, without surgery they are incontinent? You were measuring
Sir,
that, or all after surgery only you were measuring?
No, sir. This is including surgery and before surgery also, sir. All the patients include who have urinary incontinence before surgery and after surgery, both, sir. It's a retrospective study. So from 2008 to 2020, we have taken data and assess the quality of life. So over 12 years. So the quality of life is.
How do you expect your study results to be implemented on patients who are undergoing surgery? How do you think you can implement your study on the patients who have undergone surgery and who are likely to have incontinence? What will you tell them? Will you tell the parents as a result of your study?
Sir, can tell them that children who are not on CIC, better to do CIC so that quality of life will be improved. And who are on CIC, if they needed augmentation cystoplasty or any major procedure, so we recommend them to go for augmentation cystoplasty so that their quality of life will be much better in future life, sexually and psychologically. So better, I'll counsel them regarding mitrophenol, sir, if they are on CSC doing well, because who are not on CSC children, they presented with interrenal disease and they are doing CSC in spite of that waiting for this kidney transplant. Some patients in our study, they're waiting for kidney transplant and 3 patients died because they are not on CSC. And upper
yeah, but this is what you are saying is a known fact. Means I want to know what is new in your study. What
sir,
new
in the
data
quality
you
of
got
life,
in your
sir, the compared to other quality of life questionnaires, in our, we have included school functioning because the quality of life other they have mentioned only psychosocial meaning, but school functioning they have nowhere they have mentioned. There's a recent questionnaire by Pediatric quality of life. So the school functioning, we can tell that parents that in school also we can teach them, and we can tell them that take nearby home we can get the children means school, and regarding CIC, so we can teach them properly, hygienically, and
okay. Virender?
Right, so I have no questions, so I guess we'll move on to the next one. Thank you, Dheeraj.
Thank you, ma'am.
Dr. Avilash, you may please start the next presentation. We can see your slides.
Can you see me? Can you hear me now, ma'am?
Yes, please. Please make it full screen and then you may start.
Yeah. Good evening, everybody. I'm Dr. Avilash Sahu from Narayana Health City, Bangalore. Today, I'm here to share our experience on vaginal substitution in children at our institute over a period of 10 years. Vaginal substitution in children is extremely technically challenging procedure, which is mostly done in cases of children where in cases of long common channel cloaca or in cases of isolated vaginal atresia or in Mullerian agenesis. Our aim of this study was to indicate to highlight the indications of this procedure and its outcome. It was a retrospective descriptive study design. It was done over a period of 10 years from January 2011 to January 2021. Data were collected from medical records and over telephonic interviews. The inclusion criteria were all girls less than 18 years of age who underwent this procedure were included and none of them were excluded. This is a brief of the technique that we used in our institute as a protocol, using a sigmoid as a substitute or a ileum as a substitute depending on the type of cases that got operated. The outcomes that were assessed were the anatomical outcome based on the caliber of the neovagina at 6 weeks postoperatively, functional outcomes assessed by menstruation and sexual activity if attend, cosmetic outcome which was subjectively assessed by the parents. Coming to my results, total children in my cohort were 9. The age ranged from 14 months to 18 years. Follow-up ranged from 5 months to 10 years. Here you can see the indications in my cohort. Cloaca, long common channel cloaca were in 4, and isolated vaginal atresia and Mullerian agenesis were in 5 children. In this chart, we can see the cloacal cohort was operated at the age of infancy during the same time of cloaca repair, and the atresia cohort were operated at the time of puberty during the presentation. The conduit that was used in cloaca cohort was ileum, and the conduit that was used in case of atresia was sigmoid to preserve was sigmoid. And the approach that we used in cloaca cohort was an open approach because of the smaller children, and the approach used in cases of vaginal atresia was a robotic assisted open technique. Coming to my outcomes, anatomical outcomes. In anatomical outcomes, good caliber neovagina was seen in 8 girls in sixth week postoperatively. Only one girl had vaginal stenosis, which required serial dilatations for a longer time. And none of our patients had a graft loss. Coming to the functional outcome, 7 girls are in the pubertal age group, out of which 6 girls have the normal menstruation. Only one girl is still amenorrheic because of her Mullerian agenesis. And the same girl is married now and reports to have a normal sexual intercourse with no dyspareunia. 2 girls are still in the pre-pubertal age group. Coming to the cosmetic outcomes, satisfactory cosmesis was seen in 8 children, and only one child reports to have an unsatisfactory cosmesis because of a high cloacal abnormality due to her flat perineum. To conclude my study, vaginal atresia and cloaca are the common indications in children requiring this procedure of vaginal substitution. Bowel is used as a conduit, which because of its easy availability and it has a good favorable outcome with minimal complications. Ileum is used in cases of cloaca to preserve the sigmoid for a bowel pull through, and sigmoid can be used as a favorable substitute in cases of vaginal atresia. Both of the conduit in our case had a good cosmesis, functional and structural outcome. Thank you.
Thank you, Dr. Abhilash. Dr. Prakash?
Yeah, Dr. Abhilash?
Yes, sir.
Did you have problems with excessive mucosal discharge in any of your patients?
Yes, sir. Our patients have the problem of excessive mucosal discharge, which is worrisome. And mostly this was seen mostly with. So with periodic washes, vaginal washes, sir.
Okay, and did any of these patients get married?
Only one patient, sir. She is married and she is now sexually active as well.
Okay, any issues with her during your follow-up?
No, sir. She's doing
any problem.
No, sir. She's otherwise it's fine, sir. And she is a case of Mullerian agenesis, so we had counseled her everything regarding this prior to the procedure. So she's just having a normal sexual intercourse.
Okay. Abhilash, what is your follow-up routine for these patients? Like, do you follow a particular order?
Ma'am, like after the procedure, the first the examination under anesthesia that we follow at our institute is a 6-week post-operatively, where we do a examination and anesthesia under OT, and we see the and we dilate the vagina, because at that time we feel that the optimal healing would have occurred, and they could not affect our repair. And after that, we put them on a dilatation for a 6-month period, and then we again assess them as and when if they have any problem. I mean to say that we do an EUA as and when if they have any problem. Otherwise, we see them in the pubertal age group, sir. Pubertal age group, madam, when they are about pattern their
near-death experience.
So you mean to say that you put them on a dilatation regime, all of them, starting 6 weeks until when?
For a period of 4 to 6 months.
All of them?
Yes.
Okay. All right. Thank you, Dr. Abhilash. Host, can you please check there's some background noise from some, if you can mute that. Thank you. Yeah, Dr. Gurmeet, you can now start sharing your screen and start with your presentation.
Am I audible, ma'am?
You are audible, but can I request the host team to please mute the other speaker?
Parkiti Giri, I think her mic needs to be mute.
Yeah.
Should I start, ma'am?
Just a minute, Gurmeet. Let's mute Prakriti. All right. Yes, you can start, please.
Okay. Good evening, chairpersons and all the delegates. I'm presenting the last presentation of this session. My topic is status of upper tract in an unoperated patients of classic exstrophy bladder. Classic exstrophy bladder is a major lower urinary tract defect. Despite being a serious lower tract anomaly, upper urinary tract is usually normal in these patients. In literature, post-operative renal status in exstrophy Hypospadias complex is reported. But what is the pre-operative morphology and functional renal status? It has not been reported as of yet. So the question arises, is the pre-operative status of kidney always normal? The study attempts to address the pre-operative status of renal functions in classic exstrophy bladder patients. With this background, we aim to evaluate the preoperative status of the upper urinary tract in patients with classic exstrophy bladder. The study was designed as a prospective observational study. Study duration was from August 2015 to April 2021, with including the patients of classic exstrophy bladder that did not have any previous surgical intervention. We excluded the patients who with exstrophy variants and the patients who had any previous surgical intervention. We included 109 patients, and the parameters that we used for assessment of upper tract was the ultrasound KUB and the nuclear scan that included DTPA, GFR, and DMSA. Of that 109 patients, the mean age was 3.2 years and the median of 1 year. Male to female ratio was 2.7:1. In the ultrasound, unilateral hydronephrosis was seen in 3 patients, and each of the 2 patients had bilateral hydronephrosis, and 2 patients had the solitary kidney. In the nuclear scan, the normal GFR was seen in 70 patients. That was 64%, while other patients have some or the other abnormality, like subnormal GFR was seen in 35% of the patients. Unilateral and bilateral hydronephrosis was seen in around 5% of the patients. Pelviureteric junction obstruction was seen in around 2% of the patients. 1% patient had vesiculoretic junction obstruction. Unilateral renal cortical scar was seen in 2.75% of the patients, and bilateral renal cortical scar was seen in around 2% of the patients, while the solitary kidney was seen in, again, 1.83, that is around 2% of the patients. This was the normal renal scan showing the DTPA and DMSA of the patient. And this DTPA scan shows the left-sided kidney hydrouretronephrosis with the vesiculoretic junction obstruction. The DMSA of the same patient showing the left kidney with the preserved function with upper lateral zones cortical scar. This is a patient picture of the classic exstrophy bladder patient, and the CT urogram showing the bilateral hydrouretronephrosis. TTPA scan of another patient showing the right kidney hydrouretronephrosis with the vesiculoretic junction obstruction with preserved function, and the CT urogram can be shows the evidence of the same. So the strength of the study was there was no previous literature of the preoperative study showing the upper urinary tract in this exstrophy patients, and we assessed ultrasound, KUB, and the renal scan. So to conclude, preoperative renal status is abnormal in 46% of the patients, with the most common being the subnormal GFR and the hydrouretronephrosis that is seen in 35 and the 10% respectively. So with that aim, we had to aim for protection of the upper tract from further damage. This can be done by early relief of obstruction and an anti-reflux procedure early on. We have to avoid creation of high pressure reservoir in these abnormal cases, and a more vigilant post-operative follow-up is required for early detection of renal function. Thank you.
Thank you, Gurmeet. Dr. Prakash. You're muted, sir. Yeah. So we can't hear Dr. Prakash. I think I'll take the first question. Gurmeet, you mentioned that you have to, with this background knowledge, that nearly 46% of them would have upper tract damage. Early intervention for preservation is recommended, right? So
yes,
how early are you recommending, let's say, a ureteric reimplant or any upper tract procedure?
Once usually the mean age of patients present to us by around 1 month of age or other early on. Initially, as soon as the patient is ready for the anesthesia, not in the neonatal group, and the parents are ready for the same, and we had the DTP and the GFR as well, we go for the surgery. And the surgery is different. We go for the single stage total reconstruction with innovation preserving sphincteroplasty, or a multi-stage depending on the bladder plate and the functional status of the
that's
kidney.
Fine. Would you include like a ureteric reimplant in the first stage for all patients, or would you base it on?
No. We have an institutional policy for different types of the patients and different categories of the patients. We go according to that plan in these patients.
So how is it different? Could you elaborate on that?
But if they have if it is a deranged, like subnormal GFR, with the due course of time, when we have the reconstruction process is done, these patients have go for a somewhat around a near normal GFR with respect to the age. While if there is a vesicorectal junction abnormal.
That's fine. So we are just veering around the question. What I meant to ask was, like, the Manchester protocol follows that they do a bilateral ureteric reimplantation at the time of bladder turn-in, like a primary procedure.
Yes,
so based on your criteria,
yeah,
nearly 50% of them would have upper tract abnormalities.
Yeah,
Would
we
you-
do. We do for a ureteric reimplant. That's what I am saying. Single stage total reconstruction includes the bladder turn-in with the ureteric reimplant and this bladder neck reconstruction also.
For all patients.
Yes, ma'am. But for these patients that have either obstruction, we have to do for the early intervention.
Fair enough. Dr. Prakash?
No, that's okay, because I got logged out suddenly in between.
Yeah,
I have to log in again.
All right.
Host, can you see why I'm getting logged out in between? It says timeout. Again, I have to log in 3 times. It has happened.
As such, this is the last paper of our session, sir. So I guess it's okay.
Okay, no issues.
Yeah. Thank you, Gurmeet, and thank you, Dr. Prakash, for joining us.
Thank you.
Thank you, ma'am.
Thank you, Virender.
Thank you, sir. So trust that's the end of session 7A. If the host can confirm that the next session judges have already joined, I can start with the next session. And could you mute the background noise? You know, there's been a lot of disturbance in this session otherwise.
Dr. Virender, are we continuing, or I can log out from this session?
So you may log out because the next session has different set of judges. So we don't need to judge anymore. Yeah, thank you.
Okay. Thank you very much.
Give us 2 minutes, ma'am, please.
Sure. Thank you.
So next session is judged by Dr. K.L.N. Rao. He is with us, and Dr. Sandeep Agarwala. He is also with us.
And Dr. Monica Baba would be the third judge. Dr. Avirat is not with us. Has she joined?
Yes, Virender. Hi, I'm here.
Hi, ma'am. Good evening. All right. So I guess since we have all the judges, good evening once again and welcome. Dr. Rao, it's such a pleasure to see you after a long time.
Yeah, good evening. Good evening, Virender. You seem to have lost some weight.
I have, yes. A lockdown effect.
Monica, how are you? Sandeep, how are you?
I'm good. How are you, sir? Good to see you after so long.
Good, nice. Good evening, Sandeep. How are you?
Good, sir.
Good. Let's start.
Great. So this
Ravi,
is,
how are you? I forgot.
I'm good.
So it's sort of a mini get-together for all of us here.
Sure.
All right, so this is session 7B, and we shall start with the first paper. Judges, to please note, Dr. Ravinder has had a medical emergency, so he cannot present. In his place, Dr. Rajshekhar, the co-author, would be presenting. So Rajshekhar, you may please start sharing your screen. Yes, please make it full screen and start.
Good evening, everyone. I'm Dr. Rajshekhar. Greetings from ESAC Super Specialty Hospital, Hyderabad. My topic is Urethral, a single institutional experience. Urethral is a rare congenital abnormality where the terminal part of ureter forms a sac-like pouch. It opens into the bladder, and endoscopic incision of urethral is a well-established technique. These are one of the few images, and literature from India, long-term follow-up is limited, and few papers are there. Very few papers are there. So our aim is to compile and review our little experience with the urethral in patients with an intent to add to our existing literature. It is a retrospective study. All children with the diagnosis of urethral were reviewed. Endoscopic incision was done by cystoscopy using Bugbee. Patients were regularly followed, postoperatively followed with into the clinic. The growth parameters, blood pressures, and serum creatinine levels, and USGKUB and MCU and DMSA. So total of 10 children were included. That unilateral 7 and 3 are bilateral. That means total of 13 urethral seals were included. 40% were neonates, that is 4, and with a median age of 10.5 days. And remaining children, the median age was 24.5 months. The most common presentation was hydronephrosis. Male, 60% were male, contrary to the literature, and 70% were unilateral and 30% were bilateral. 7%, I mean, orthotopic, 92.4% were orthotopic uretrocells location wise, and duplex was seen in 20% of the children. So duration of the follow-up was 2 months to 6 years. The median follow-up, most of the children were asymptomatic. Anthropometry, blood pressures, renal function, and are normal in all children. So we could find VUR in 15.4% of the children. All patients with VUR were asymptomatic. No scars were found on follow-up DMSA, and no surgery was done. No anti-reflux surgery was done. So literacy is still struggling to find best practice guidelines in managing uretrocells. And endoscopic puncture of uretrocell provide not only the initial solution, but also could be a definitive treatment in most of the children. So uretrocell is rare, but being increasingly diagnosed, treatment needs to be customized. So duplex systems of uretrocells are more likely to require second surgery. If ectopic uretrocells are more likely to have a association with poorly functioning and non-functioning renal units. And to conclude, endoscopic incision of the urethral is a simple and quick procedure which may all that is required in majority of the cases. However, children undergoing endoscopic incision need long-term follow-up to identify the post-operative complications, and compilation and documentation of every case with its follow-up is important to expand the existing data in only fairly rare condition. Thank you.
Dr. Rao, would you take the first question, please?
Yeah, basically, it's a very small follow-up. It is less than mean follow-up is just about 23 months or so.
Yes, sir.
We do see good number of complications in the long run.
Yes, sir. That is our limitation.
You have some kidneys to be removed. You need to sometimes reflex, anti-reflux measures have to be taken. Sometimes stones get stuck in the retained urethral sac. Plenty of complications could be there. So the long-term, very long-term follow-up is required before we really comment that endoscopy is good enough to take care of these children.
Yes,
that's it.
Yes, sir.
Thank you.
Dr. Sandeep, your question, please.
Yeah, interesting paper, and we have had a similar experience that we had published. But I would like to know if there were any non-functioning unit in your
all bilateral duplexes were good functioning moiety, sir. No non-functioning moiety was there.
No non-functioning in all the cases. But because if there is a non-functioning moiety, what would be the indication for doing an nephrectomy in the non-functioning moiety?
Yes, we non-functioning moiety, if the child is having recurrent UTI and abdominal pain, then only we do partial heminephrectomy, sir.
Okay, thank you.
Dr. Monica.
Good presentation, Rajshekhar. I just wanted to know what was the indication of your intervention in the neonates? There were a good number of patients in whom you have done in the neonatal period itself. So can you just tell us what was the indication in those neonates?
They presented with retention of urine, ma'am. And
all of them?
Not, ma'am. I think I didn't compile in the table, ma'am. One child presented with UTI and the rest were presented with retention of urine, ma'am.
Okay. Thank you so much. That's it.
Thank you, Dr. Rajshekhar. We move on to the next presentation by Dr. Vivek, who's already started his screen share. So you may please start. Dr. Vivek, we can't hear you.
Are we audible to you, Vivek, sir?
So now Vivek is unmuted. I think Vivek, you can start.
Yeah, but even now we can't hear him, sir.
We can't hear him.
Yeah.
Am I audible?
Now you're audible, yes.
Okay, good evening. My name is Vivek Gaikwad from CMC Vellore, and it gives me immense pleasure to present to you congenital long segment anterior urethral strictures in children. Sorry, the screen is not moving now. Excuse me, I need to share it again.
No worries.
Is it moving now for you, please?
Yes.
Congenital lower urinary tract obstruction encompasses a heterogeneous spectrum of diseases in children in which urinary elimination is obstructed distal to the bladder neck. While extensive research has been conducted on obstructions involving the posterior urethra, particularly in PUVs, anterior urethral anomalies resulting in obstruction are relatively uncommon and usually remain as a diagnosis of exclusion. Most studies on congenital anterior urethral strictures have described a short segment narrowing of the anterior urethra similar to a Cobb's collar. The aim of this presentation is that we describe a congenital long segment anterior urethral stricture which manifests in infancy with a stricture length of more than 2 centimeters. This was a 10-year study period with the following parameters being assessed. The study included only those patients who presented at infancy with an anterior urethral stricture measuring more than 2 centimeters in length with no prior history of urethral instrumentation, manipulation, infection, or inflammation. Children over 1 year of age, those with posterior urethral narrowing or with short segment anterior urethral narrowing, less than 2 centimeters or hypospadias and prune belly were excluded from the study. At the time of definitive surgery, the stricture length was further classified into 2 to 3 centimeter and greater than 3 centimeter to create a treatment algorithm for defining the axis and type of tissues required for replacement. Depending on the above variables, a perineal approach with a preputial tube for 2 to 3 centimeter strictures or a transpubic approach and urethral reconstruction with either preputial or a bowel tube for greater than 3 centimeter strictures was used. And an appendicular mitrophenoff was placed in all patients for added safety. Treatment success was defined by the ability to void via naturalis with a good stream, absence of future UTIs, and radiological evidence of resolution of the stricture. We had 4 infants who met the inclusion criteria with a median age of 4 months at presentation. Only all children who presented had poor urinary stream and 2 also had acute urinary retention. 3 children had associated anorectal malformations and all children had vesicoureteric refluxes there were 5 renal units of such. All who required ureteric reimplantation and 1 even required a nephrectomy. 1 child was born with a spinal deformity that resulted in neurogenic bladder. Initial renal protective emergent management was a vesicostomy in 3 children and a perineal ureterostomy in 1. This MCU shows the abrupt cutoff of the posterior proximal anterior urethra with posterior urethral diverticulum and a grossly distended bladder. In this child, it shows a long segment narrowing, and this child shows the anterior narrowing with back pressure changes. Definitive procedures were deferred until renal function stabilized and the growth parameters returned to normal, which occurred at an average age of 36 months. The stricture involved the bulbar urethra and all with a distal extension into the penile urethra and 2 children. All children underwent an endoscopic assessment. 2 children underwent a preputial tube urethral replacement via perineal approach for the short stricture length, and the 2 cases with the longest stricture length, a transpubic approach with the preputial in 1 and ileal tube monty was required because strictures were greater than 3 centimeters. And the preputial was inadequate to bridge the gap, hence a ileal monty was used. The average post-op follow-up was 11 months. 1 child had developed a stenosis at the anastomotic site and required a strictureplasty 6 months later. While all could void via the post-op, 1 child with the neurogenic bladder continues to need CIC through the mitrophenoff. This is an image of post-op improvement in the urinary stream. The limitations of this study include a small sample size, delayed presentation, and limited follow-up. In conclusion, congenital long segment anterior urethral stricture is a rare and poorly described entity. Vesicoureteric reflux and anorectal malformations have been commonly associated with this as per our study. Initial management should be in the form of emergency diversion procedure, either at the level of the bladder or urethra. And definitive management entails complex reconstructive techniques for obtaining optimal results. Thank you very much.
Thank you, Dr. Vivek. Dr. Rao, your comments and questions, please.
Yeah, it's a difficult problem, I agree. And obviously the follow-up is very, very limited, just a couple of months rather than a long period. Most of the patients do have problems in the long run. I can say that with experience. Okay. So otherwise, it's a good presentation and a good attempt to salvage these children. Thank you.
Thank you. Thank you.
Dr. Sandeep.
Yeah, I agree with Dr. Rao. In the long run, they develop dilatations and circulation, especially the perpusal tube replacements, and they have problem. But it's a nice series of 4 patients. I'm surprised that so many of them have anorectal malformation. And what do you think was the cause of this in anorectal malformations? Patients.
So actually, we're not very sure yet because the fistula was actually in the posterior urethra and in the bladder, rectovesical and rectoprostatic. So we're not exactly sure why. And we actually in the future patients that we get, we'd actually like to do a further analysis. Maybe send some histopath to see what type of tissue we're dealing with. Whether it's an embryological reason for it. We're still not very sure. We'd like to research further on it.
Okay, thank you.
Thank you, sir.
Dr. Monica, your comments?
Good presentation, Dr. Vivek. I just wanted to know, as Dr. Sandeep had a query about patients with ARM, did these patients have any symptoms, urinary symptoms, before you did the definitive pull-through? Because your MCUs have been done probably after the pull-through procedures.
They did have symptoms. In fact, they presented with acute urinary retention. 2 of them presented that way, and 2 of them presented even with poor urinary stream and dribbling of urine. But these were attributed to the anorectal malformation, and due diligence was not given to these patients as to ascertain the cause of this. And it was actually missed out. And they came to us actually after the pull-through was done. So we were actually not involved in the pull-through as per the question you're asking.
Okay, so is there a possibility that some kind of injury has happened intraoperatively since you have not operated upon these patients?
Ma'am,
because of the stricture secondary to the catheterization, which has been done during the time of pull-through?
Actually, sorry, ma'am, the diversion colostomy was done outside. The pull-through was done by us. So we did the catheterization per se, and we did cystoscopy prior to that, and we found it to be pristine.
Okay, fine. So you mean to say you have done a cystoscopy before doing the pull-through?
Yes.
So you have given 2 controversial statements.
Ma'am, what I mean to say is we did an ultrasound which showed hydrouretronephrosis in the child, and we did an MCU thereafter. And when it showed that, the pictures I showed were actually before the pull-through, the pictures which I depicted to you.
Okay, fine. Okay, thank you.
Right. Thank you, Dr. Vivek. We move on to the next presentation by Dr. Anis. Please start your screen share. We can see your slides. You may please start.
Good evening, everyone. Greetings from Chennai. I am here to present the clinical microbiological profile and outcome of lobar nephronia. Acute lobar nephronia is a focal bacterial nephritis, which is a midpoint in the spectrum between acute myelonephritis and intrarenal abscess. It is increasingly being diagnosed because of the advancement in renal ultrasound. We reviewed our experience with pediatric lobar nephronia. It was a retrospective study, and we compared our results with the literature. Total of 18 children with lobar nephronia were studied. All were investigated with ultrasound, blood, and urine cultures. 2 required further CT scans to confirm the diagnosis, and 1 required an MRI as the initial ultrasound showed renal hemangioma. DMSA was done for 2 for diagnosis. The age ranged from a 10-day neonate to a 12-year-old girl child. One child had bilateral lesion. Culture reports, predominantly urine was positive in 56% and blood in 28% of children. The causative organism was commonly seen to be E. coli, followed by MRSA and Klebsiella. One child who was immunosuppressed had fungal infection. The associated anomalies with the urinary tract, 6 children underwent MCU, out of which 2 had VUR grade 3. One child had a duplex system with the right upper moiety nephronia, and 1 child had an obstructive ureteric calculi. Other comorbidities were immunosuppression, and 1 child who presented to us 5 days after appendicectomy with the right lower pole nephronia, probably a misdiagnosed appendix.
All children were managed with IV antibiotics for a minimum of 2 weeks. One child underwent ureteric stenting for the calculi. 2 out of 18 progressed to form renal abscess. One of them needed a surgical drainage. The other one, the abscess ruptured into the pelvis, forming pyuria and resolved with IV antibiotics. On follow-up, 16 out of 18 showed complete resolution. One child with persistent bilateral nephronia lost to follow-up after 2 months. One had a focal loss of lower pole parenchyma. On BMSA, which was done for 6 children, 5 showed residual scarring. One child who had completely resolved radiologically developed Wilms tumor on the same lesion at 2 years follow-up. Coming to the discussion, the typical clinical presentation all of our patients had the combination of these typical presentations, and the source of infection was in concurrence with the literature, that is urinary source being the most common. E. coli was also in concurrence with the literature. In literature, a PAP-G2 gene has been said to be strongly associated with E. coli causing ALL. For diagnosis, IVT was historically used, but it has been replaced by renal ultrasound. The features in renal ultrasound is a focal irregular lesion in the kidney with nephromegaly. The lesion could be initially echogenic, but it becomes hypogenic over some time. If in doubt, CT scan is a more sensitive diagnosis for acute lobar nephronia. The finding in CT scans have been divided into a simple ALN with a homogeneous lesion and a complicated ALN with a heterogeneous lesion. Some authors advocate DMSA to differentiate pyelonephritis with lobar nephronia. This is a CT image. Coming to the management, Cheng et al. Recently proposed prolonged course of appropriate antibiotics for all patients. Surgical intervention is only required when they progress to renal abscess, or if there is a non-resolution of the mass after antibiotics, or if there is a surgical correctable cause like urolithiasis. The associated anomalies in the literature was VUR, which was seen to be 17 to 42% in children with ALN. But one literature said the VUR among ALN is the rate is almost close to the children with non-ALN UTI. There was no proper guidelines for follow-up. We recommend ultrasound until documented resolution and at 1 year, DMSA at 3 to 6 months, MCU if DMSA or ultrasound has any abnormality. To conclude, acute lobar nephronia should be suspected in the setting of sonographic nephromegaly, high C-reactive protein, and fever for 5 days after initial IV antibiotic treatment. ALN requires a much longer antibiotic treatment and is associated with more complications than pyelonephritis. E. coli followed by MRSA were the commonest organisms in India's setting. Ultrasound followed by DMSA, and if required, MCU is done. These are my references. Thank you very much.
Thank you, Dr. Anis. Dr. Rao, please.
Yeah, basically some interesting terminology, I suppose. Probably in the earlier years, we were passing them off as renal inflammation or some such wording, maybe pyelonephritis, etc. Now a specific word has been labeled nephronia. I think honestly, it's a new word for me. I suppose otherwise it's a varied from Wilms tumors to VUR. Pathology is found in these cases. So that's a very interesting fact, I suppose. Otherwise, a good paper. Thank you for the presentation. Thank you.
Thank you, sir.
Sandeep, sir.
Yeah, a very interesting paper. And as I would like to know what would be the differential diagnosis for such a finding on the ultrasound? Are there any differential diagnoses?
So initially, if we find this kind of a lesion, we give them antibiotics, and yes, if it doesn't resolve, we need to think of any underlying cause, like a nephrogenic breast could be there, or Wilms tumor per se, or like the renal hemangioma. We need to further investigate, maybe with a true cut biopsy, to see what could be that lesion, sir.
So in your series of patients, did you find any other diagnosis once you first labeled a patient as nephronia, acute nephronia, and later on it turned out to be something else?
No, sir. In all the 18, we had them all as they resolved completely, except the one which lost follow-up bilateral nephronia. Rest all of them they resolved completely, sir.
Thank you.
Dr. Monica, please.
Thank you, Dr. Anis. Actually, for me also, nephronia is a new terminology, and I've learned a lot from you. But I would still like to know, how do you actually differentiate between pyelonephritis, secondary to VUR or nephronia? How would you actually label the patient has nephronia or has got pyelonephritis?
Basically, when there is pyuria infection in the urinary tract, which with the ultrasound finding of this focal irregular lesion in one of the lobules of the kidney, we label it as lobar nephronia because, as mentioned, it is a midway between the acute pyelonephritis and intrarenal abscess. If it is left untreated or if appropriate antibiotics are not given, it goes into to become a renal abscess. So it's basically a midway between pyelonephritis and intrarenal abscess.
Okay, thank you. So maybe we have been missing on that intermediate stage because I've never come across it. Thank you, Anis.
Thank you.
Thank you, Dr. Anis. Great presentation. We move on to the next one, which is by Dr. Kritika Rani.
Hello.
Yes, Kritika.
Shall I start, ma'am?
Yes, please.
Good evening, everyone. Just 1 minute, ma'am. Sorry.
No worries.
Good evening, everyone. From Indira Gandhi Institute of Child Health, I would like to discuss about pediatric endourology in urolithiasis, that is lesson learned in initial 50 cases. The aim of the study is to highlight the significant pediatric urolithiasis disease burden and to present our experience and perspective of endourological management in pediatric stone disease. It is a retrospective type of study which is done in 50 pediatric patients with urolithiasis, and the period was between 2018 to 2021. All the patients underwent appropriate imaging and metabolic workup. Under metabolic workup, we had 24-hour urine collection, urine calcium, urine creatinine ratios, and supersaturation products. Total, we had 50 patients of urolithiasis, out of which 14 underwent endourological intervention, whereas 9 underwent open intervention. Out of 41, we had 29 who belonged to upper tract and 12 patients belonged to lower tract. In this, out of 29 upper tract, we had 16 who belonged to renal and 13 ureteric patients. And we had categorized our patients into 3 age groups, that is 0 to 5, 5 to 10, and more than 10. And we found the majority of the patients belong to 5 to 10 years of age group. The regular instruments that we use is ureteroscope 4.5/6, ureteric catheter, and guide wire. In PCNL, we had the nephroscope of 14 French, sheet, argon rods, and 2-part puncture needle. This is a PCNL setup where the patient is lying in the prone position. A surgeon is standing on the right side of the patient with the C-arm and the C-arm monitor towards the head end of the patient, and the anesthetist standing towards the head end. In the PCNL technique, the first image shows the marking for puncturing site, stone in the lower calyx axis, dilator, and the sheet. Out of total upper tract patients, that is 29, we did 10 PCNL in 10 patients and 14 patients underwent URSL, and lower tract were 12. The operative time that we saw in PCNL average was 4.5 hours for PCNL, 2 hours for URSL, and 1.5 hours for cystolithotrypsy. The stone clearance in our study, 90% of the cases in PCNL and 100% eventually for the ureteroscopy. The complications that we faced were no complications observed in our patients, but though morbidities were seen, like loss of tract in one patient, then prolonged nephrostomy drainage with perinephric collection in one patient. Though, although we didn't have any hemorrhage or bleeding or ureteric injury or instrumentation-related complications. Coming to the discussion, the commonest age group found was between 5 to 10 years as observed in the literature, but we had observed slightly male preponderance. We did not observe any metabolic etiology, and commonest type of stones that we observed were mixed variety. We used pneumatic lithotripter for PCNL and the URSL. Although the preferred tools would be ultrasonic or the laser lithotripter, and also the stone clearance is best in laser and ultrasonic lithotripter. The PCNL was 90%, whereas when compared with the literature, that is 68 to 100%. In view of the cost constraints in the standalone pediatric hospital, we are yet to acquire it. The perinephric collection observed in one case in our study, that is 10%, 0.7 to 24% of the hemorrhage, 8% for perinephric leak is reported in the literature when using bigger tracts. However, there were no complications or transfusions in the 14 French tract group as reported in the literature. To conclude my study, there is significant urolithiasis load in pediatric age group. Endourology for pediatric urolithiasis requires special skills and setup. It requires a mentor who can handhold and train in initial few cases, establishing training modules and collaboration with the adult urologist or pediatric endourologist for setting up endourology units in MCH training center will go a long way in upskilling pediatric surgeons. Thank you.
Thank you. Dr. Rao, your comments, please.
Yeah, good paper and good presentation by Dr. Kritika, I suppose. And I agree with you that somehow so far in our country, the pediatric surgical training centers have neglected stone disease. Only thing is, you said in your abstract at least that the stones form nearly 5 to 10% of the pediatric surgical cases. Probably it's a very high figure that you mentioned, because if that is so, you have about 50 cases in 3 years, and taking least possibility of a 5%, you have only 1,000 pediatric surgical cases in 3 years.
No, sir. Averagely in our institute, sir, we have almost 60% of caseload under pediatric urology.
Okay, pediatric urology as such.
Yes, sir. Pediatric urolithiasis cases.
Okay, thank you.
Yes, sir. Thanks.
Okay, Sandeep.
Yeah, again, the paper that I received, the title has been changed completely. The title says Pediatric Endourology as a part of training program in pediatric surgery residency of paramount necessity. Let's prove it. Anyway, it was a good paper. And there's a question in the chat box by Professor Kanishka Das, who's asking that he's surprised that there were no metabolic conditions associated, and was any stone analysis done? The question from my side is stone disease, urinary stone disease also endemic in South as it is in the North?
Yes, sir. We have a quite low caseload of urolithiasis cases, pediatric urolithiasis cases. As I told already, there is 60% of our cases out of 100, 60 patients, there will definitely be urology. And regarding the stone analysis, we have done all the patients undergone stone analysis, and maximum majority what we found in our study was mixed stones, though most commonly will be calcium oxalate or followed by monohydrate. So we had mixed variety types.
But you didn't have any patient with any metabolic abnormalities detected?
No, sir. We always have a tally with the nephrologist over here. So we didn't have in the first 50 cases that we had taken, in that we didn't have any metabolic cases, physiological.
Okay, thank you.
Thank you, sir.
Dr. Monica.
Thank you, Dr. Kritika, for a nice presentation. I just wanted to know, can you think of any reason that you find maximum of mixed stones in your population?
Ma'am, multiple calculi will be there in the urinary tract. So, ma'am, actually, maximum most commonly was calcium oxalate only. Oxalate stones are found maximum, but out of that also we had monohydrate, and additional we had other zinc, xanthine or other, like once in a while we had other varieties of stones, but that is very minimal, that is very negligible. So that's why it's mixed variety we had taken as a.
Okay, fine. Thank you.
Yes.
Thank you, Dr. Kritika.
Thank
the
you.
Next paper is by Dr. Sohail. We can see your screen.
Good evening, ma'am.
Yeah, please start.
Good evening, ma'am. Myself, Dr. Sohail Ahmed from AIIMS Bhubaneswar. I am going to share an experience over 2 decades on case of persistent Mullerian duct syndrome. Mullerian duct regresses by 10th week gestational age in a destined male, and the incomplete regression of so is usually because of either deficiency of anti-Mullerian hormone or the receptor insensitivity. It's an autosomal recessive disorder. With hence there is a persistence of Mullerian structure like uterus, cervix, cranial vagina, fallopian tube, and fimri, and it's a rare occurrence with the various presentations. It's a retrospective analysis of 9 cases over last 20 years from 2000 to 2020 over 2 tertiary centers, St. John's Medical and AIIMS Bhubaneswar. The clinical presentations, anatomical imaging like ultrasonography, MRI, and even the diagnostic genotoscopy and laparoscopy were done, and the surgical management will be discussing. There was one case who had a consanguineous parentage, and the age of presenters were from the infancy to the adulthood up to 15 years. The median age was 4.5 years. The 2 patients had a bilateral impalpable urethra on a phenotypically male. There was 3 cases who had unilateral impalpable gonad but ipsilateral hernia. There was no cases of cross-testicular ectopia. 2 cases had recurrent epididymourgitis, 1 hematuria, 2 cases torsion of testis. Out of those 2 torsion testis had undergone unilateral gonadectomy. There was another case who had undergone gonad removal, who had inguinal fistula as a result of the melanoma duct structure which has bled and has resulted into fistula. And when presented to us, it had already gonad had removed. There were 2 cases, one had microphallus and 1 proximal hypospadias. 6 cases out of 9 were able to reach to diagnosis with the pre-op on clinical examination, ultrasonography, VCUG, and MRU. There were 3 cases out of 9 who had surprise on laparoscopy done for impalpable undescended testis in a phenotypical male. 2 on laparoscopy, we found a mullerian structures, and in the cystogenitoscopy, we found a cervical dimple in 6 cases. And on 3 cases, cervical dimple were not seen, and there was a counterless pouch, and all of them had a karyotype 46SY. This is a pictorial image who had, there were 2 cases who had a cystic lesion. Usually these PMDS cases will have normal testis, but 2 had a cystic lesion. For that biopsy were done, and these vessels were taut and small, and herniation may be because there is a laxity of fallopian tubes. We could barely see the vas in it because vas is usually hypoplastic or it has failed to recanalize. There are different modes of surgical approach. We have done transtrigonal in 2 cases, laparotomy. Initially in previous years, it was done laparotomy, and recently now the laparoscopic approach is being performed on 4 cases. Transtrigonal were done in 2 cases because the pouch were very low lying, and one had small and low, and another had to go on for the redo. It was previously operated outside, and still the patient presented with the symptoms. On biopsy specimens, this is the endometrial structures and the fallopian tube. On histopathological also, it was confirmed it was a fallopian tube. And another, on histopathology, there was on 6 cases, there was endocervicals with this columnar epithelium myometriums, and 3 cases had ectocervical pouch with stratified squamous epithelium. Those 2 cases who had a cyst in it, where biopsies were done, those had a normal testicle and the matured one. The child were followed from 1 to 19 years. Median is 19 years. The last follow-up, the adult is 20 years and all of asymptomatic, and they are voiding normally. And one had a recurrent UTI which has settled. There was 2 patients who had attained puberty, and we had gone for the semen analysis and found that the 2 had oligospermic and had anxiety regarding fertility issues. This is a picture of 8-year child. Midline structure, midline incisions were given, transdiagonal approach. Right testis were a good volume, so it was fixed, and left very small in size. In a very small Mullerian duct remained about 1 to 1.5 centimeter. It was very difficult to see either in VCOG or other investigations. It was cystogenitoscopy. We could make out there is a large, is like a prominent prostatic ureticle. So all cases
doctors, sorry to intervene. The presentation time is over, sir.
Sir, I am to follow pediatric dental clinic.
Just finish your conclusion slide. That's
Sir.
okay.
Was preservation and Mullerian excision are the prime concern of the objective of surgery, and then laparoscopy and either laparotomy both can be done.
Right. Thank you.
Thank you.
Dr. Rao.
Yeah, thank you, Sohail. I just wanted to know, when you say transtrigonal, can you please explain what exactly, where is your line of going to the part to be removed or operated?
Yes, sir. Is the pouch is rectovesical and cannot be approached from the posterior approach. The anterior wall of the bladder is open, then the trigone, and the trigone is open in the midline. We have reached to the posterior structure.
Don't you think that will be, too much of a risk for urinary continence and the bladder emptying mechanism to go to the trigonal route? Or you think it doesn't matter at all?
No, it matters, sir. But since in a case size is very small, and then we need to remove it in view of the child is having recurrent UTI, the left out option is transtrigonal.
Okay, thank you.
Thank you, sir.
Dr. Sandeep, please. Well, I can't see him. Dr. Monica, would you take the question?
Thank you, Dr. Sohail. There's a question in the chat box which says, was there one child who had proximal hypospadias?
Yes, ma'am.
So
usually in PMDS, as this hypospadias is because of testosterone issues. In this, usually the testosterone are normal. Usually we should not have, but we had one case who had a proximal hypospadias.
How proximal was it? Was it?
It was a penoscrotal.
It was a penoscrotal. So you had done a genetic workup pre-operatively for that child?
Yes, ma'am.
Okay, thank you.
Thank you, Dr. Sohail. The last presentation of this session is by Dr. Ashwita Shinoy. Please start sharing your screen, so we can see that.
Yeah, am I audible now?
You're audible as well. Please start.
Good evening, everyone. I am Ashwita Shinoy. I'll be presenting diagnosis of 5-alpha reductase deficiency in case of severe hypospadias with small phallus. Since we all know hypospadias is the most common congenital anomaly of genitalia, glans diameter and stretch penile length are an independent factors affecting surgery. So various studies have shown that when glans diameter is more than 14 and stretch penile length more than 30, the results are better with lesser complications. And if the size is less, what do we do? So preoperative hormone stimulation is one of the options available, which is in the form of testosterone or DHT. So testosterone is responsible for development of testis, which is converted to DHT in the periphery with the help of 5-alpha reductase, and deficiency of this causes impairs virilization. So aim of this study is to diagnose 5-alpha reductase deficiency and to assess the response to hormone testosterone or DHT. So this was a retrospective analysis conducted over 7 years. All children with severe hypospadias were included in the study, and we measured the SPL and GD in the OPD. The ones with less than 30 mm SPL and less than 14 mm GD were included in the study. All of them underwent karyotyping and HCG stimulation test. So HCG stimulation test was done as follows. Serum testosterone was measured on day 1, followed by HCG administration on day 1, 2, and 3. And on 4th day, 24 hours after the 3rd injection, testosterone and DHT were measured again, and the ratio was calculated on the 4th day levels. Normal ratio is 8 to 16. And also we saw the rise in testosterone from day 1 to day 4. So results, 19 children were included in the study. Age of presentation was 19 months mean. Type of hypospadia, 17 were primary, 2 were failed. Position of the meatus was penoscrotal in 3, scrotal 13, and perineal 3. None of them had family history, and chromosomal analysis was done in all of them, which was 46XY. So pre-HCG testosterone median was 9.26. All of them had rise in the testosterone post-HCG, which was 481.48, and DHT was 82.69. TDHT was more than 16. Normally 8 to 16. And median was 38. And the SPL GD presentation was 20 mm and 9 mm respectively. So initially 5 years ago, we did not have DHT gel available. Hence, 5 of them received testosterone injection. 3 received 2 doses and 2 received 3 doses. 2 of them showed no response. The ones who showed response, the response was from 22 to 28 SPL and 9.5 to 15 GD. And TDHT in this group was 30.3. The remaining 16 received DHT gel, which was applied all over the penis once daily. And SPL and GD was measured after 2 months. All of them showed response. And here it went improved from 21 to 30 and 9.5 to 40. TDHT was elevated in this group also, 43.26. So these are some of the images pre and post DHT. So at OPD, it was 12 to 18, and this is after 2 months, which has improved to 24 and 12.5. Similarly, another patient with severe scrotal hypospadias, 24 to 34 improvement. Glans had improved from 9.5 to 16. This is also another similar case. So post-hormone stimulation, all of them underwent stage repair. Cordy was noted in all of them more than 30 degree, and hence Cordy correction was done with Bayer's flag. Out of the 16 who've been operated, only 1 have developed the urethroplasty fistula. So our complication rate is 6.2%. 3 are still awaiting repair. So to conclude, Diagnosis is essentially in 5-alpha reductase deficiency, and we have to have high suspicion when there is small phallus with severe hypospadias. HCG stimulation test has to be done, and based on T-DHT ratios, we can either give testosterone or DHT. Hormone stimulation in the preoperative period have shown good results in the post-operative period, various papers. So this is one of the options in case of small phallus. Thank you.
Thank you, Ashwita. Dr. Rao, your comments, please.
Yeah, thank you, Ashwita. One problem we always face with the application of either testosterone injections or gels, etc., is that there will be heavy bleeding at the time of the surgery, be it urethroplasty or anything else. Number
Yes,
one.
sir. Yes.
Do you also face the same problem?
Yeah, so we give a gap of 4 to 6 weeks. Sir. So initially we have faced this problem. So we give a gap of 1 to 6 weeks. There is definitely bleeding, but it is less than if you would have done earlier.
Okay.
Second question waiting is for a longer period as well. Yes.
Yeah. Second question is for cardiac correction also you require to increase the size of the glands and the size of the phallus. Cardiac correction can definitely be done without also, isn't it?
Yes, sir. It can be done. So we have seen once we have given DHT, the effects they are not transient like testosterone there for 6 months. So we prefer to give before the surgery and later we don't have to give it again. So for cardiac correction is not required. Mainly we are worried about glans dehiscence and glans closure in the second stage. So, but we follow this protocol. So later we don't give it because it's even if the patient comes after 6 months, 1 year, we have seen the effects are present.
Okay, thank you.
Thank you, sir.
Dr. Sandeep, please.
Thank you. Interesting paper. So the question that is being asked in the chat box also, did all the patients have a prominent vaginal pouch? Was a cystoscopy showed vaginal pouch in these patients?
Yes, we did cystoscopy. No, none of them had. So
None of them had.
We would have excluded that because that will come under DSP. So cystoscopy is done in all of them. None of them had a vaginal pouch.
But 5-alpha reductase deficiency patients would all have a vaginal pouch. No.
None of them had, sir.
So, and that is the main problem. The other problem is that when you consider that 5-alpha reductase patients, deficiency patients will have a vaginal pouch, should we also consider that any patient with severe hypospadias who has a vaginal pouch be labeled as 5-alpha reductase deficiency? You know, a lot of places don't have 5-alpha reductase level.
Right.
So should all these patients, because if you label all these patients as 5-alpha reductase deficiency, which means we are labeling them as infertile patients. So it has long-term implications. So I'm surprised that none of your patients had vaginal pouch.
No.
I think Dr. Mane is asking the same question on the chat box.
Karyotyping, yes, sir, has been done in all of them were 46XY.
Yeah, XY.
Yeah, all of them were XY.
5-alpha reductase deficiency comes in under the XY DSD only.
XY, yes, sir.
Okay, thank you.
Thank you, sir.
Dr. Ashwita, there are 2 more questions in the chat box.
Yes, ma'am.
One is from Dr. Kanishka. He is asking any genetic tests you have done to confirm, and when do you plan to manage penoscrotal transposition?
So penoscrotal transposition we usually correct at second stage, or we do it at later because it's mainly cosmetic correction. We do it 6 months after stage 2 or we do it during stage 2. And regarding genetic testing, PCR sequencing, we are not able to do, if that is what the question is. 5-alpha reductase can be diagnosed on PCR genetic sequencing, but we don't have the feasibility, so we have not been doing that. And urinary steroid metabolite is one more which can be done, but we don't have the feasibility, so we've not been doing it.
Okay. Thank you so much.
Thank you, ma'am.
Thank you, Dr. Ashwita. With that, we come to the end of session 7B. I thank all the presenters and the judges for a wonderful session. So we close this session now and move on to our last session, which is session 9 on hypospadias. May I request the host to please confirm the presence of all our 3 judges, Dr. Shivaji Mane, Dr. Amilal Bhatt, and Dr. Kishore Panjwani.
Yes, ma'am. Dr. Mane is here.
Okay.
Dr. Bhatt is here.
Yes. Hello. Good evening, everybody.
Good evening, Dr. Bhatt. Wonderful to see you. How are you, sir?
Good evening, ma'am.
And Dr. Panjwani, is he around? Jatinder from the host team, can you please confirm if Dr. Kishore Panjwani is around?
Ma'am, Dr. Kishore will join us in 5 to 10 minutes.
Okay. All right. So since we are already running a little late, if the judges, Dr. Shivaji and Dr. Bhatt permit, we can start with the session and then Dr. Panjwani can join us midway, sir. Both of you are muted, sir.
Yes, yes, we'll go ahead.
Sure, sir. Right, great.
Go ahead, ma'am.
Sure, sir. So we'll just start with the session. So may I request the first presenter, Delona, to start sharing your screen?
Yes, ma'am.
And the title of her paper is Caudal Block in Hypospadias Repair, a bliss or a miss.
Yes, ma'am. Is my screen visible?
Yes, it's visible and you're audible. You may please start.
Okay. Good evening, everyone. Respected chairpersons, faculties, and dear colleagues. From the Department of Pediatric Surgery, AIIMS, New Delhi, I'll be presenting our experience in caudal block in hypospadias repair. I have no disclosures to make. A prospective RCT conducted in the Department of Anesthesia from South India to study the analgesic effect of caudal block versus penile block in hypospadias observed that there is increased rate of fistula formation in the group with caudal. So caudal block was then incriminated as a risk factor for ureterocutaneous fistula formation after hypospadias repair. The proposed mechanism of action is vasodilatation following caudal administration, leading to penile engorgement and local edema, resulting in local oozing and suture cut through, finally contributing to fistula formation. Many studies were conducted worldwide following that, but with controversial and conflicting reports. A meta-analysis by Zhou et al. Concluded that in caudal block in hypospadias repair, they had favored the caudal block with no increased rates in fistula formation. Yet another meta-analysis by Tansaco et al. Did not find any association between caudal block and the fistula formation rates. Another systematic review conducted from our department of AIIMS New Delhi had observed increased rates of fistula formation in the group who are receiving a caudal block. But the study was again limited due to availability of only retrospective studies. So our aim with this background was to study the vasodilatory effect of caudal block analgesia in children. It was a single-center prospective study, and we included pediatric patients undergoing elective infraumbilical surgeries under general anesthesia plus caudal block. We excluded cases in which the caudal was not effective. We had measured the stretched and resting penile length and then the penile girth at 3 locations, scrotal temperature, capillary filling time in the nail bed and sole, before caudal, 10 minutes post-caudal and 20 minutes post-caudal administration. The total number of cases was 63 with a median age of 5.9 years. The resting penile length measured at 10 minutes post-caudal had increased from the baseline, but then at 20 minutes post-caudal had decreased, though it has not yet reached the baseline. Similar observation was seen with a calculated penile volume, which had increased at 10 minutes post-caudal, while again it decreased at 20 minutes post-caudal, though it has not yet reached the baseline. The scrotal temperature measured 10 minutes post-administration had shown a transient increase in the temperature. The capillary filling time measured in the nail bed and the sole of the foot had showed a transient decrease at 10 minutes post-administration, while it again had increased at 20 minutes post-administration of caudal. So the caudal block has affected the resting penile length, the penile volume, the scrotal temperature, the capillary filling time in the lower limb at 10 minutes, though this vasodilatory effect was observed to be transient and the graph had shown a trend towards normalization at 20 minutes. And all hypospadia surgeries from the caudal to the incision time is always more than 20 minutes. So it is unlikely that the caudal block is leading to pooling of venous blood and penile engorgement, resulting in local edema and contributing to fistula formation in a hypospadias repair. Thank you.
Thank you, Delona. Dr. Mane, your question, please.
Thank you, Delona, for a nice paper.
Yes.
And
Thank
I
you,
totally agree with that. I remember sometime back from AIMS only. I just comment on that paper. I said, can you hear me?
Yes, sir. Yes, sir.
Can you hear me?
Yes, sir.
Yeah. So I said sometime back, the similar paper was presented from the AIMS only about some 4 or 5 years back in Kolkata. And the conclusion was totally different. It was said that it is a producer complication rate was much more. And I agree that the effect of the caudal lasts only for maximum for 4 to 5, 6 hours. So we cannot contribute to the complication like a fistula. There are so many factors which involve for the contribution of the fistula formation. So one just a caudal block which acts for 4 hours cannot be a factor for the fistula formation. That's just a comment on that. Thank you.
Yes.
Thank you.
Albert.
Yeah. Dr. Amilal, please unmute yourself. You're muted, sir. Please unmute.
Hello, are you getting?
Yes.
Yeah.
Yes, sir. Now we can hear you.
I think it's a good study, prospective studies, effect of local. There was so much confusion, though it was well proved now that there is no effect on the not only the fistula rate, but overall complication rate also in hypospadias. And on the contrary, this makes the child comfortable post-operatively. Thank you.
Yes, sir. Thank you, sir.
Thank you, Delona. We move on to the next paper by Dr. Archika. Could you please start your screen share, ma'am?
Am I visible?
Yes, ma'am. Yeah, you're audible as well.
Also?
Yes, you are.
Good evening, Chairperson and all. I'm presenting paper titled Problem of Glans dehiscence and Subcoronal Urethroplasty Fistula in Hypospadias Repair, resolved with the application of Matthew flap. Occurrence of glans dehiscence along with subcoronal urethroplasty fistula after hypospadias repair is a unique problem and it has to be managed like primary hypospadias. There is no universal technique for redo urethroplasty as in primary urethroplasty, and most commonly described technique for redo urethroplasty is snodgrass tuberoid incised plate urethroplasty with or without graft in incised glans plate and urethral plate as in primary urethroplasty. However, incidence of glans dehiscence and distal urethroplasty fistula is still reported to be 8 to 14%. Our aim is to report outcome of Matthew flap repair for glans dehiscence and subcoronal urethroplasty fistula occurring after hypospadias repair. From January 2015 to December 2019, this Matthew flap repair was used in 15 patients of hypospadias presenting with glans dehiscence and subcoronal urethroplasty fistula. And the Matthew flap repair was done at least 6 months after primary repair. In this patient, this was a hypospadia that was operated outside, and we can see the glans dehiscence and subcoronal fistula and a very small bridge in between. So a stay suture is placed and the bridge is divided to convert into a subcoronal hypospadias, and Matthew flap is harvested as described in the standard Matthew flap. But we have made a modification. We have created a V shape in the distal part of the flap, free part of the flap. Then this flap is flipped over and urethroplasty done, and glans wing is radically mobilized and glansplasty performed over this flipped Matthew flap, and this followed by the closure of the repair. So this is the appearance of the hypospadias patient after repair. Outcome measurement included recurrence of glans dehiscence and fistula in follow-up, elimination of natal stenosis and aesthetic appearance. In the results, no recurrence of glans dehiscence and subcoronal fistula occur in any of the patients, and none of the patients has natal stenosis due to our modification, and aesthetic appearance was satisfactory in all. And this is the aesthetic appearance in early follow-up. And this is the aesthetic appearance after prolonged follow-up. And this is aesthetic appearance after prolonged follow-up in other patients. And so we conclude the technique of Matthew flap with radical glans mobilization and glansplasty over the flipped Matthew flap is effective to address the problem of subcoronal fistula and glans rinsing. These are declarations, and thank you.
Dr. Archika, nice presentation.
Thank
I
you,
just wanted to have one question about, you'll agree with me, Matthew's flip-flap technique, whether you do primary case or the redo case, is possible only in the cases where the perimeter skin is not tethered to the underlying urethra. That means if fully we can lift it away from the urethra, then it is possible. Is that correct?
Sir, it is correct. I have written in my presentation also.
Now the question is remains, most of the cases of redo hypospadias, not necessary, it will be always possible to lift that perimeter skin easily away from the urethra to go for the Matthew's flip-flap. So my worries always remains that this is one of the techniques one should definitely should consider about Matthew's flip-flap, but not necessarily in all the cases that is possible. The selection is very important, and we should be ready for another technique in case we find the Matthew's flip-flap is not technically possible because we're not able to raise the fin flap. And second objection is about the raising that V type of flap, M type of flap. Obviously, because of that flap, the vascularity of the tip of the both edges of the skin flap is not going to be as good as you get a U-shaped flap. Third point about what do you do for the barrier layer for this your redo cases?
So, firstly, I agree with your comment that this technique is used only in those cases where we get the adequate mobile skin proximal to meatus to raise the flap. And secondly, and we always be ready to other technique. And secondly, sir, you can what is the advantage of this? Sir, we modify this because we want to have a adequate meatus. Because in Matthew flap, one is the disadvantage is that it gives rounded shape of meatus. So to obtain the slit shape over meatus, that's why we modify it. And third point.
Archita, the getting a slit like meatus depends upon how do you do a glansplasty. This is not related with the shape of the flap, whether it's a U-shaped flap or the VM shape of flap. How do you do glansplasty? That decides how do you get the meatus, vertical slit like or the circular meatus.
So it has
been Dr. Amal, but any questions from your side?
So it has been described in literature also, this modifications. And second is that, sir, third, you want to ask that what cover. We give the daughters cover from the penile daughters because whenever we get the penile daughters covers.
Dr. Amal, any questions from your side?
Thank you. I must compliment that you didn't have any recurrence of fistula or glans disease.
This is a short series, so might
no problem. No problem. I have my few questions about this. So what are the causes of glans disease? Number one. Number two, you said that Matthew flap in reoperative cases. So from where that blood supply will come, because this is the reoperative cases. In native case, there is an intact blood supply. Here, the skin has already been mobilized, and the case which you showed, there was a flap mobilized and then skin was covered. So in such cases, what about the blood supply of the flap? My third question is, what do you mean by radical glans mobilization? Can you exactly tell that what radical glans mobilization is?
Sir, first question is I didn't get, sir, your first question.
Just explain what is the radical mobilization of the glans. Explain that first.
You start with this.
So, okay, radical glans mobilization, sir, in our technique, we start mobilization in subfacial plane and we do the mobilization, freely mobilization of the glans up to the half circum so that it comes easily over the urethra.
Can you say some?
Let me correct you. So the mobilization of the glandular wings is that you mobilize deep up to the tip of the corpora. So that is, if you mobilize that one, then there will not be any tension on the glans wings. Number one.
We mobilize in the subfascial plane below the buccal fascia and above the tunica elbow.
No, limit when you are going deep, it has to be up to the tip of the corporal bodies. And
so it is
second one was
of the body, but laterally we have to mobilize up to the lateral edges of the corpus so that it comes easily without any tension over the urethra.
Okay. That is a radical mobilization. Then blood supply of the flap in reoperative cases.
So blood supply, because we are doing only in those cases where we found the skin well mobilized and well suppled skin. So probably in these patients, Dartos covering has been given over the urethra. So might be subdermal plexus supply had been given. We found that this skin is found suitable, then only we do this procedure. Otherwise, we have not used this procedure.
The basic is that whenever there is a fistula, the skin will be adherent to the urethra at that place. Then how will you find that glans dehiscence and urethral fistula, you get the proper skin blood supply at that level?
So we use skin proximal to fistula, and we convert the fistula. From glans dehiscence up to fistula, we convert it into a hypospadias, and we use skin proximal to fistula.
Okay. The basic fundamental is, as Dr. Mane pointed out, the method is to be done only in those cases where the skin is healthy as well as not adherent to the urethra.
So that's why
third question, if you point out, then what are the causes of glans dehiscence?
So causes of glans dehiscence might be that probably glans wings are not adequately mobilized in earlier surgeries, and that might have been the causes.
That's the only cause.
So,
what about receding of the urethra?
So receding of the urethra might occur.
Okay. What is when you are using method, what precaution you will take? Where are the chances of recurrence of fistula?
So chances of recurrence of fistula is the where the this is the base of the flap. It is the chances of the fistula is there.
So what do you do for that one?
So we do the Dartos cover from the available penile Dartos. Or if available penile Dartos is not available, sir, no, then we take the
actually that has to be, the skin has to be resected up to the spongiosum or up to the urethral plate. There should not be any dog earring at that place. If that is, then that will lead to fistula. Okay, go ahead. That.
So maybe move on to the next.
Permit?
No, sir. Maybe move on to the,
one more comment. Okay.
Maybe move on to the next one, sir. Sorry.
Okay.
Yeah. Thank you, Dr. Archika. The next presentation. Yeah. The next presentation is by Dr. Shilpa Sharma.
Good evening. Can you see my screen and can you hear me well?
Yes, ma'am. Please go ahead.
Respected chairpersons, good evening to everybody here. I will be talking about our experience with hypospadias repair in patients with the shallow navicular fossa, adopting the synergistic principles of Matthews and Snodgrass. In cases where there is a narrow navicular fossa, we are in two minds whether to use a Matthews or a TIPS procedure. When a TIPS procedure is used, the urethral tube formed is very narrow. On the other hand, when a Matthews procedure is used, the tube form may be superficial and hence may give way. We thus thought of evaluating the outcome to combine both these procedures. Started doing the procedure in October 2008, and since last 11 years have till this study until December 2018, I've done it prospectively into 86 cases of distal hypospadias repair, where a Matthews procedure in the form of parameatal U-shaped flap and a Snodgrass urethral plate incision were adopted. So here is what we mean by a narrow navicular fossa. The narrow navicular fossa may be described as 2 to 3 millimeters, very shallow, and if it's moderate, that's 2 to 3 millimeters depth. The urethral plate is described as narrow being 2 to 3 millimeters, moderate 4 to 5, and good if it's more than 6 millimeters. doing hypospadias over so many years, have made a choice of choosing the kind of catheter and then deciding when to do the surgery and how to go about it. So the minimum size which we would suggest less than 3-year-old is 6 French, never go with a 5 French. Up to 7 years, maybe 8 and go up to 9. And then in up to 8 to 12 years, a 10 French catheter should be put. A U-shaped parameter based flap was made and the native urethra was also lifted with the flap. So here is the difference from the Matthews, making it a modified Matthews. Here you can see the AB is now converted into a BA flap. So this also gives adequate length mobilization of the urethra and makes it shorter the urethral tube to form. The 2 limbs are extended to the proposed site with a parallel incision, and the place where there is narrow navicular fossa or the urethral plate, an incision of the snodgrass is given so that we get adequate diameter here. The incision is given in such a way that we know that this incision here will help to get the diameter here. So this is wider than the dissection of the glands. Here is the parameter flap. Here you can see. Datta's flap is also raised later from the sides to give a second cover. Granular rings are raised on either side, and the anastomosis of the urethral tube is quite deep inside and covered well with the dartos and the gland rings. These are the completed repairs. So doing it in the median age group of 5.6 years, the deficient urethral length was 1.2 to 2.9 centimeters. The urethral plate width being 2 to 8 millimeters. The navicular fossa was shallow and moderate. Minimal cording was there in 12 cases that was released by skin declaving. Operative time was 30 to 70 minutes. The urethral catheter was removed in 9 to 10 days. There was a darkening of the skin patch in 3 cases which resolved spontaneously. 1 case had a delayed infective dehiscence as the patient had not taken bath for 1 month after going home. This was also repaired by the same procedure 11 months later. 2 patients had fistula formation. Of the 2 patients with fistula, 1 resolved spontaneously. But recently that patient had another fistula at a different site which was also repaired. 83 cases healed well with meatus at the tip, no stenosis or stricture, and all the patients are passing urine and both stream. Here you can see the darkening of the skin. This was the redo case which we had done. These are the results. The advantages of the Matthews flap gives us more tissue to reconstruct the urethra, avoid a major stenosis or a stricture, and form an adequate sized urethral caliber with better functional outcome. The addition of the snodgrass incision helps to place the new urethra deep inside, form a slit like meatus, and place the sutures deeper to get a good glandular approximation, in spite of putting a dartos there. The advantages being good cosmetic and functional outcome and a good caliber, deeper navicular fossa, and which also allows a second layer of entering the fistula formation. To conclude, this technique is giving satisfactory outcome with minimal complications, a good cosmetic and functional outcome. Thank you.
Thank you, ma'am. Dr. Mane, your comments, please.
Yeah, just one comment of Dr. Shilpa's nice paper. I think I heard this paper in the past also somewhere. But my problem about this Matthews flap always remains. Of course, I have done it quite a good number of cases, 15 years prior to the started doing TI repair. So one of the major drawbacks that I saw was when you raise the meatus base flap, there is always, or to some extent, there is always some blind pouch that remains around the meatus level. And these are the patients who I still remember in my early days when I used to dilate the meatus, and I always find that there's sometimes you may not directly go into the urethra, but you used to go into that blind pouch. And I have seen 2 patients who have come back with a stone in that blind pouch. So somehow I don't know the Matthews flap, though it is a very good technique, especially from the redo cases to be done. And this, as I said in the previous case about Archita's presentation also, one should do it only when you can easily, nicely lift it away from the perimetal skin, from the urethra, so that there is no blind pouch remains around the meatus level. Sometimes the skin around the meatus is tethered to the urethra, maybe a small extent, and that you really cannot mobilize completely when you take the as a flap. And that blind pouch, I'm always concerned about it. Your technique of yours is your technique about taking the dorsal incision to make it a bigger urethra. To certain extent is good, but at the same time, my objection about this technique is that suppose the same urethra you can widen it by doing a graft inside, and you can put a nice getting a urethra rather than getting a pouch like urethra by a flap.
So your concerns are very valid, and the blind pouch should be removed at all costs. So either we can do it posteriorly, you give a slit incision there and make the meatus wide, because we are aiming to put in a larger feeding tube. That is the main purpose for this procedure. And in the ones that are stuck anteriorly in the ventral part, those also can be given one small incision. And then when you lift up, the flap should be very thick. So the skin should not be very thin. So you take a nice cover of the flap, and when you reach the area which is there where the blind pouch is due to form, you can slit it open also. That will also heal well. It's like a snodgrass, anterior snodgrass. So that has to be taken care. And it is when it is too much inside, placed deep inside, the glands have good vascularity and they take care. The snodgrass incision helps us to place it right inside.
Right. I think Dr. Kishore has joined us as well. So Dr. Kishore,
Good evening.
Hi, good evening, sir.
Everybody.
Your comments, please, sir.
Shilpa, I'm listening. This study for in a few more conferences in the nationally as well as the internationally.
So I presented it when it was 27 cases, then 56. Now it's
so
86.
now it has extended to 140 cases.
86 cases.
My two questions. One is how does it is superior to the snode graft and the Matthew procedure, and what are the drawback of what are the complication in your series? Because what you have shown, ideally this type of technique when you use in the glance width is less. Then you are try to using this technique. Truly speaking,
yes,
or you have planned for the snodgrass procedure, and after giving the incision to the urethra, you are finding this is not covering the whole urethra. The total circumference is less. So what are your comment? How does it superior to two techniques, snode graft and Matthew?
So it is superior to both the techniques because we are placing the urethral tube inside the glands. It is not a superficial thing. So when you give a snodgrass incision, that also is not very deep. There will never be any stricture formation. It's just 1 millimeter, and it's at the area of where there is narrowing. When you have a navicular fossa, it may be narrow in some area. The urethral plate may be narrow in some area. Only in those parts you're giving. You're not taking it right up to the meatus. So there is never any meatal stenosis. So you're giving a wider tube. If I do the procedure in a patient of 4 years old and I put in a 6 French feeding tube, I will not be happy. I will try to make it 7 and 8. And because 30% anastomosis always brings the caliber down. So I've never had to do a dilatation. The stream has always been good. And I started this procedure on 17th October 2018. And since then, after doing this, there was no fistula. When I did it in RML 56 cases, there was no fistula. When I came to him, did 30 more cases, there were 2 fistulas.
But don't you think that is when there is a the glance distance is more? If you use in a small glance circumferences cases, glance distance will be more in these type of cases because you are giving the more bulky type of.
So the take home is that the incision for the urethral tube from the gland side is very less. It's around 3 millimeters, not more than that. So that you plan in advance that this will be the gland swings. This is where I want to go. And then the urethral tube from the side of the glands is very less. Most of it is coming from the Matthews flap. So they are going behind. Their two anastomoses are basically posteriorly placed, posterolateral. They are not lateral at all. They are posterolateral. So the anterior and the lateral walls is formed by the Matthews flap. So that should be wide enough. You take it 2 millimeters wide from the meatus so that you get good flap. And with a cover, which is already there. And putting the dartos really helps because you have enough space there. You have created that space. So that takes care of it.
Right, ma'am. I think we'll take one quick comment from Dr. Bhatt and then move on to the next paper, please.
Very good, Shilpa. I have my two reservations about it. If you are putting flap without, then why to incise the urethra?
The flap is only helping to make the urethral tube. When we put an incision, we are placing it deep and we are covering up for the narrow, for the urethral tube, which is taken up from the gland so that we have more of gland swings. When we put a flap just like that, it will be superficial. We need to place it inside the gland so that it is inside. And then the part of the glands that is used for the urethral tube is less. So we can manage with 2 to 3 millimeters of the glands forming the urethral tube and the rest coming from the anterior and lateral part from the Matthews flap.
Yeah, got that point. You see, if you are taking the width of the flap is good enough, then you see the basic principle of healing is that whenever you give incision, if there is a wound, there will be inflammatory reaction and there will be healing process. So that may cause problem. If you are taking wide enough without flap, then what is the second? My question is that I have my reservation about this one, that you are putting the flap and you are then covering that flap with the ventral dartos, then it is going to be bulky and there are more chances that you will have the tension on the glandular wing closure.
That is why the snodgrass is helping, because you're able to place it inside and you have planned your procedure. I don't do early. I'll wait for the patient to grow up and have adequate size. The measurement should be adequate so that we are able to do this procedure well. The dartos is helping to prevent the fistula formation. So even at the corona level, there is not much of a fistula formation. That is the use of the dartos flap.
So sorry, we are beyond the discussion time. So if you permit, we'll move on to the next paper, please.
Thank you.
Thank you, ma'am. The next presentation is by Dr. Rupesh.
Good evening, ma'am. Is my screen visible?
It is not yet visible, Rupesh. It says started screen share, but it's not yet visible.
Share once and share again.
Please unshare and then try sharing again.
Okay, ma'am. Share. Is it visible now?
Yes, it is visible now. You may please start.
Okay. Greetings from AIMS Jodhpur. I'm Dr. Rupesh Sikhi and my presentation is on pattern of preoperative uroflowmetry study in hypospadias patient and age-matched control patients. I have nothing to declare. Patients with hypospadias often present with voiding difficulties after successful repairs. However, the question which remains unanswered is whether the postoperative abnormal uroflow in hypospadias patient is a generalized field defect as a part of urethral malformation or as a result of any operative intervention. We sought to analyze the degree of uroflowmetric anomalies that may be present in children with hypospadias preoperatively. Our aim was to compare the pattern of preoperative uroflowmetry study in hypospadias patients and age-matched control patients. A total of 90 pediatric patients underwent preoperative uroflowmetry during the period of 2 years, out of which 30 patients comprised of hypospadias and 60 patients were the age-matched controls. The uroflowmetry was performed with the help of Nexam Pro uroflowmetry system connected to the computer. The children were well hydrated and the participants were asked to present with full bladder, and the test was performed when the child had normal sensation to urinate. Each participant voided twice, and higher values of the two consecutive maximum urine flow rate values of the same child with a voided volume of greater than 50 ml were included in the study. The uroflowmetry parameters studied were maximum urine flow rate, that is Qmax, average urine flow rate, voided volume, voiding time, time to maximum flow rate, and urine flow curves. Boys older than 3 years of age and those were toilet trained were included in the study, while previously operated case of hypospadias, patients suffering from urinary tract infection, those patients with neurogenic bladder or any patients with any associated neurological or urological abnormality related to bladder which could potentially affect the flow pattern were excluded from the study. Outcome parameters included normal flow pattern where the Qmax was greater than 25th percentile for age according to the Toguri normogram with a normal bell-shaped curve. An equivocally obstructed flow pattern was Qmax between 5th to 25th percentile for the age, and the obstructed flow pattern was considered when Qmax was less than 5th percentile for the age with the obstructed flow curve. The statistical analysis was done with the help of SPSS 23 software program, and the results were calculated as medians. The uroflow parameters and the urine flow patterns were compared with the help of Mann-Whitney U test, where the p-value of less than 0.05 was considered to be statistically significant. Among the 30 hypospadias patients, the anterior group included 10 patients, middle group included 19 patients, and the posterior group included 1 patient. While in the control age-matched controls, majority of the patients included were undescended testes, hernia, superficial cystic swelling, and hydrocele. In the results, according to the ICCS, the maximum urine flow rate, that is Qmax, is the most important value in the uroflowmetry parameters. It was significantly low in hypospadias patient. It was 10.7 ml per second as compared to in hypospadias patient as compared to 14.45 ml per second in controls. Similarly, the average flow rate was less in hypospadias patient. It was 6.5 ml per second as compared to controls. It was 8.5 ml per second. And the voiding time was significantly higher in hypospadias patient. It was 43.5 seconds as compared to 30 seconds in control, which was also statistically significant. The Qmax by voiding volume was taken out so as to avoid the bias of voiding volume, and it was also statistically significant. The urine flow pattern according to the Toguri normograms, urine flow rate pattern according to the Toguri normogram revealed that the obstructed pattern was seen in 50% of the hypospadias patient, while the normal flow rate pattern was seen in 37% and equivocal was found in 4% of the patients. In hypospadias patient, about 60% of the patients showed plateau-shaped curve, while only 37% of the patients shows normal bell-shaped curve and 3% shows intermittent pattern of urine flow curve. While in control group, about 65% patients showed bell-shaped curve and only 27% shows plateau-shaped curve. So to conclude, uroflowmetry remains a useful tool in screening for abnormal urethral function in hypospadias patient preoperatively. Hypospadias patient can and do demonstrate an obstructive uroflow curve pattern uroflowmetry even before the surgical corrections. And hypospadias patient have significantly low maximum urine flow rate, average flow rate, Qmax by voided volume, and higher voiding time as compared to their control group. Thank you.
Thank you. Dr. Mane, your comments, please. We can't hear Dr. Mane. So, Dr. Panjwani, would you take a question?
Beside the meatal stenosis, few percentage of cases of hypospadias, what do you think the cause of this type of obstructive pattern?
Sir, it is usually said that in hypospadias patient, the corpus spongiosum is lacking. Also, there have been the studies that there are overactive bladder in these patients of hypospadias. There has been.
I want to know basically the proximal urethra, proximal to the hypospadias. There is most of the time normal unless until only there is a meatal stenosis. What are the other causes you think?
Sir, deficient corpus spongiosum, deficient.
Proximal urethra has got a well-developed corpus spongiosum. Only the corpus spongiosum is deficient in the distal part. It's a very good study what you have done. Very few people has done the pre-operative. We are doing the post-operative, especially in cases in the proximal hypospadias on the long-term basis. Because the proximal hypospadias where we use the flap procedures, they sometimes they show the obstructive pattern. But you are done in a distal hypospadias also in pre-operative. So what do you find the causes?
Sir, we found that these patients, we also studied according to the location of the meatus, whether it was proximal, distal, or it was granular. So, irrespective of the location of the meatus, the hypospadias patient had a low maximum urine flow rate, and it showed the obstructive pattern or plateau-shaped pattern. So here we basically studied the uroflowmetric parameters and their patterns. We could not evaluate in detail what were the exact causes for this significant finding.
Okay.
We could not evaluate what exactly was the cause. We found the clinically we found meatal stenosis, but we were not to measure the caliber of the meatal stenosis.
Fine, Rupesh. Dr. Amila, do you have any comments or questions?
Yeah, I have. You see, poor flow rate, if you have demonstrated, there could be two causes.
Hello?
Hello?
Yes, we can hear you, Rupesh.
Yes, sir. Hello?
Hello, yes. Can you hear me?
Yes, sir, I can hear you. I can hear you, sir.
There could be two causes.
Sorry,
Either there is a meatal stenosis. You see, the deficiency of corpus spongiosum in distal urethra will not cause the change in flow pattern. So there could be two causes only. That could be either the meatal stenosis or there could be some detusser problem. So poor flow patients who has a very poor flow, did you do the bladder function study? You didn't do. Okay. This is the part which you should look for, but these are good parameters which you have brought. And this is a very good guide post-operatively also to tell the patients that these were the parameters pre-operatively. And it's like, second one is that what you are thinking was there, did you do this uroflowmetry post-operatively also?
Sir, that study is going on. The post-operative
To
uroflowmetry
compare
of this
whether there
patient.
is any difference
Yes.
in that the pre-operative and post-operative parameters. These were two comments. Thank you.
Right.
Sir,
Thank you.
that is ongoing, sir. Sorry, I got
Fine.
disconnected twice, so I could
No
not
worries,
hear the first
Rupesh.
statement.
Yeah, that's okay. Thank you, Rupesh. We move on to the next paper, which is by Dr. Avinash.
Good evening, one and all.
Hi,
Is
can
my
you
screen visible?
not yet? Try unsharing and yeah, it says start. Yeah, it's visible now.
Good evening, one and all.
Please go ahead.
I'm here to present a study on postoperative complications following primary repair of midpenile and distal penile hypospadias.
Can
There's
you
no
make it
ideal
full
procedure.
screen? Sorry, can you make it full screen, please?
There's no ideal procedure described for any hypospadias, and there are over 300 operations being described and being modification also being described. Our aim of the study was to analyze the postoperative complications following primary repair of midpenile and distal penile hypospadias. So in our materials, we collected data or retrospective data in a span of 5 years from 2016 to 2020, the total number of cases of 253. We included all the midpenile and distal penile hypospadias and exclusion criteria being proximal hypospadias and scrotal hypospadias. So we had 82 cases of midpenile hypospadias, 113 cases of distal penile, and 27 cases of coronal and 31 cases of glandular hypospadias. The most commonly performed procedure was Snodgrass. It was performed in 150 patients, followed by peripheral tube urethroplasty in 81 patients, which is followed by Snodgraft in 14, MACPI in 22, and rest of the other modification procedures in 21 patients. Urethroplasty fistula is the most common post-operative complications found. It was in 29.5% of patients with Snodgrass urethroplasty and 11.1% of patients with peripheral tube urethroplasty. It was seen in 3 patients with Snodgraft and 2 patients of MACPI urethroplasty. Urethral stricture was found in one patient who underwent peripheral urethroplasty and 1 patient with advancement urethroplasty. Meatal stenosis was seen in 7 patients who underwent Snodgrass urethroplasty and 2 patients who underwent peripheral urethroplasty and 1 in each who underwent MACPI and Snodgraft urethroplasty. Glands dehiscence was seen in 16 patients of Snodgrass urethroplasty and 3 patients in who underwent peripheral urethroplasty and 1 in each of MACPI and Snodgraft urethroplasty. Urethral diverticulum was seen in 2 patients with peripheral flap urethroplasty and 1 patient who underwent Snodgrass urethroplasty. So, and residual penile curvature was seen in 1 patient with peripheral flap urethroplasty. To conclude, the most commonly performed procedure in our setting was the Snodgrass urethroplasty, followed by a peripheral tube urethroplasty, and the maximum proportion of complications were seen with the Snodgrass as it was the most common procedure performed. The most common complication being urethropedias fistula, followed by glands dehiscence, followed by meatal stenosis. Thank you.
Thank you.
Can I
Dr. Mane has
comment on
joined
this?
us. Yes, please.
Yeah,
Yeah.
Can I comment on this? I forgot the name of the presenter.
Avinash.
But Avinash, very nice paper, but I do not agree with the title and you see, what somebody has to study the complication hypospadias is better to study for the particular repair. Say you talk of any repair, you talk of MACPI, you talk of TIP, you talk of Snodgraft, you talk of Duckett's tube or Osopus tube, all these techniques we can individually study and their complication rate. When you say it is a distal hypospadias and mid-penile hypospadias, it doesn't mean anything. It can be just we are all aware that what is the meatus opening when you start the surgery, not necessarily that is the defect in hypospadias. The real defect in hypospadias remains where the bifurcation of the corpus spongiosum starts. So what turns out to be, say, something like a coronal hypospadias can be still a proximal penile hypospadias when associated with a severe hypoplastic urethra. So I don't agree with your first hypothesis, the way you did the study. And because you are agree with that, you may agree with that some of these cases are the chordae without hypospadias. They are glandular hypospadias. But the chordae will be so variant in the severe degree. It may be mild to moderate to severe chordae. So even though sounds severe distal hypospadias, but it's not a really distal hypospadias. So to begin with, I mean, I don't agree with you. The study saying that mid penile and the distal hypospadias, which can be, you're not considered the factor like a chordae, the other factors like related to the complication. Basically, you just study the one technique and its complication that can answer you properly.
Right, sir. Dr. Amila, your comments, please.
Yeah, I would like. So first thing which I wanted to ask was that, you see, you classify the hypospadias. What do you mean by distal and middle? You see, it is real is that when you do penile degloving and then see where is that real is at the, as Dr. Mane also pointed out, the bifurcation of the spongiosum is the type which will decide the type of hypospadias. Number one. Number two, do the authors analyze why there is so high complication rate in the tubularized urethral plate urethroplasty? You see, that's what I wanted, because if they will analyze, then they will find that the hypospadias which they were thinking of distal, they may not be. That means the application of the technique might have not been a proper one to have so high complication rates. These are my two comments. Thank you.
Thank you, sir. Dr. Kishore, your final comments, please.
I agree with Dr. Mane and Dr. Milal Bhatt, because every technique has got a different, its own complications. So it's a very vague type of study. Ideally, he should more refine it and make it a more particular about the technique and uses. And definitely, there are not so much complication with the snodgrass unless until there's a wrong selection of the patients. Okay.
Sure. I hope Avinash has noted the comments. We move on to the next paper that will be presented by Dr. Tanveer Roshan. Dr. Tanveer? Host, do we have any information about whether Dr. Tanveer has joined us? All right, since I have no word from them, I'll take it that he hasn't joined us. Hello, yes?
Sorry for interrupting, ma'am. Actually, we tried to contact Dr. Tanveer, but I think he's not picking the phone and we didn't get any response.
All right, Jatinder.
As well, ma'am.
Fine. In case he joins later, please do let us know.
Sure, ma'am.
So it is for the judges to please note while you are marking your sheets that we'll omit this paper for now and move on to the next one. That will be presented by Dr. Riaz Ahmed. I hope all the three judges are marking their sheets alongside.
I'm not marking, truly speaking. I was late.
Sir, but you do have the sheets, right? Maybe you can do it once the session finishes.
Okay.
No, Dr. Virendra, we have not received any sheets like that, not anywhere on the mail.
Dr. Ravi has mailed it thrice, sir.
Sir,
So maybe
there,
No.
sir, it's there on your WhatsApp. Can you just open your WhatsApp? It is there. I have sent on your email also.
Okay. In fact, just about 3 o'clock, 4 o'clock, I got a call from somebody. I especially asked him that I not received this, and I'll check it again.
How about Dr. Amila? Are you marking, sir?
I have resent them just now on WhatsApp of all the three judges.
Yeah, I agree with you.
Right, sir. Yeah, so maybe we can continue with the next presentation.
Can I start, ma'am?
Yes, please, Raz. Go ahead.
Is my presentation visible?
It is visible and you're audible. Please go ahead.
Okay. Good evening. I'm Dr. Riaz from Super Specialty Hospital, Government Medical College, Srinagar. So I will be talking about crush and cut myotomy for meatal stenosis under topical anesthesia. So meatal stenosis is defined as a narrow urethral caliber. Some define it as less than 5 French caliber, and it's found in about 9 to 10% of the male population. Most common causes are non-therapeutic circumcision and idiopathic. And theoretical explanation for circumcision being a cause of meatal stenosis is it leads to damage of renular artery while circumcision, and then ischemia, and other reason being the because of the we remove the this prepuce, the glans is exposed to amniotic urine in diaper-clad babies, so leading to meatitis and can lead to meatal stenosis. These are two possible explanations. So clinical presentation is usually asymptomatic, and symptomatic kids will present as upward deflected stream or difficult to aim stream, dysuria, urgency, prolonged urination. This is a classification of meatal stenosis grading, in fact, by McCain M. et al. And grade 0 is open meatus with normally visible mucosa. Grade 1 is open meatus with some mucosa visible with mild web, and grade 2 is pinpoint meatus with no mucosa seen, and there's a large web. So ours is a prospective study. We studied symptomatic children less than 15 years of age who have not underwent any surgery, and pre-operative grading was done as per this McCain score, and ultrasound KVP was done to look for any back pressure changes. And we have used topical gel containing 2.5% lidocaine and 2.5% prilocaine. And we have a contact period of this gel was 30 to 45 minutes. This is a pictorial representation of the procedure. This is this was a small kid, so we have used some occlusive dressing so that the kid doesn't remove it and it stays for 30 to 45 minutes. And in this slide, we can see that on the ventral aspect, this web is crushed and it is cut. And this is after follow-up of 10 to 15 days. And this is this kid after 3 months. So this study period was from January 2020 till January 2021. Total of 58 patients, all circumcised. Age ranging from 3 to 14 years. Grade 2 stenosis was seen in 45 patients and grade 1 in 13 patients. Predominant complaint was deviated stream. And ultrasound KV showed cystitis in 7 and grade 1 to 2 hydronephrosis in 3 patients. Majority had ventral web, while 5 patients had dorsal web. So complications of this procedure: minimal bleeding in 6 patients. It was settled with compressions, and transient urinary retention in 2 patients. Self-resolving spraying of urine in 5 patients. None of the patients needed suturing or per urethral catheterization. So these are the few pre-operative photographs. The first one is the dorsal web. We see a sort of glandular hypospadias, I can say, and others are the classical where we can see the meatal stenosis with the ventral web. These are the post-operative photographs of some of the patients which we have done. So to conclude, crush and cut method is superior to conventional meatoplasty in terms of need for anesthesia and sedation and duration of surgery. And the outcome of surgery is excellent with minimal complications. Thank you.
Thank you, Yas. Dr. Amila, your comments, please.
I have Dr. Vani.
Yes,
I have my reservation about you are selling meatoplasty. So how it is meatoplasty?
We are telling meatotomy, sir.
Yeah.
Meatotomy.
Meatotomy. Okay.
Yes, sir.
It's not meatoplasty.
No, sir.
Okay. So you see, what was the thickness of the web which you have crushed and incised. And
It was a very thin
the
web.
cause of bleeding in those cases, was that thick or there was some other region?
No, sir, it was very thin web.
Okay.
There was no major complication, no bleeding in most of the patients. Small amount of bleeding that settled with compression for 1 or 2 minutes.
Okay.
Dr. Kishore, your question, please.
I don't have any experience of crushing the meatus. Truly speaking, sometimes we get this type of patients, but this technique only can be used when there's only 1 to 2 millimeter narrowing, meatal stenosis. Sometimes if you see the few patients, they got more than 4-5 millimeter narrowing, a whole glandular urethra is narrow. So before doing this type of thing, ideally we should go for seeing the status of the length of the stenosis. And I don't
Basically, sir, we are talking about the stenosis that is present in normal kids. We are talking about stenosis that is present at the tip only.
Yeah, I agree with you, but how do you say it's a normal patient, normal kids? Sometimes the patient, they come with initially they are normal with and they come with the stenosis. How do you say it's a normal patients?
Once we try to crush it, we will insert the tip of the artery into the meatus, one prong.
And
yes,
another thing, I'll happy to listen from you in some other conferences. What will be the long-term result of this type of the procedures? Because it's a very short study of 1 year.
Yes,
sometimes
sir,
there will be repeated stenosis or other complication. I don't have any
yes, sir,
experience.
yes, sir. That needs a long-term follow-up. Yes, sir.
We'll be happy if you'll tell us their long-term results in a future conference.
Sure, sir. Sure.
Dr. Mani, your comments, please.
Yeah, Dr. Vani, I agree with you what you described. It's typically seen in patients with a poor circumcision, and there may be different factors, but I think most important factor remains when they start wearing the underpants much early, it just irritates or erodes the exposed glans meatus area, and that leads to this stenosis. And obviously, this can be easily managed with a local surgery. But with problem with me, I never got this IMLA easily available. So we need to sometimes do under proper short anesthesia. If you get an IMLA cream available, of course, that is what you do is the right thing. Second thing, what Dr. Kishore was trying to point out was probably these are some of these cases associated with some kind of phimosis, which are the BXO or the lichen planus, sclerosis, where there is a whitening of the skin, and that can go along the meatus into the urethra. So
that
those
can
patients
go for
also
some
can
distance.
sometimes, if you miss that early part, you are just on circumcision and you send the skin for histopathology, when especially if it is a white ring at the tip of the skin, which definitely goes in favor of the BXO. You send it for histology. And these are the patients, if by chance they come back to you with a picture like a meatus stenosis, please don't try what you're trying. That will need a proper urethrostomy and put a mucous graft.
Yes, sir. Sure. Agreed.
Thank you. Thank you, Dr. Riaz.
Thank you.
We move on to the next presentation by Dr. Akash Bihari. Dr. Akash, are you here? Yeah.
Yes, ma'am.
Yeah, we can see you. Yes, we can see your slides. Please start.
A very good evening. Greetings from AIIMS Bhubaneswar. I am going to present the effect of preoperative estrogen on the complications after proximal hypospadias repair, and we have conducted a randomized control trial. The management of proximal hypospadias involves a multitude of treatment options, including various technical modifications, because the complication rates of proximal hypospadias are very high, according to different studies in the literature. So the causes of complications have also been studied, and they have been found to be there are multiple causes which have been studied for the regarding the complications of proximal hypospadias. But the literature is sparse regarding the complications arising out of the tissue healing characteristics, and there is no literature suggesting the modification and treatment based on that tissue healing characteristics of a hypospadias patient. Beneficial effects of estrogen on wound healing has been known since long in animal and both animal and human models. So with this background, we have designed a study based on the presumed wound or tissue healing property of estrogen, and we seek to determine whether it can limit the complications of hypospadias repair. The study, the sample size calculated was 32 patients in each group. And for a uniformity of the study, we selected only the proximal hypospadias patients who have undergone Bayer's stage 1 repair and are waiting for stage 2 repair. During this study, we excluded the patients with having other associations and syndromic disorders. We have randomized the patients into two groups. One is a control group and an estrogen group. We have used an applicator to apply a fixed dose of estrogen to the penile skin, which is destined to be tubularized during the second stage of urethroplasty. With this applicator delivered 0.5 gram of the cream onto the penile skin, and we have compared that with the control group, which is a placebo control. At this time of surgery, a small skin harvested for biopsy and immunohistochemistry was done. Mean vascular density was taken by counting the vascularity of 3 low power fields. Outcome measures were at a 6 months follow-up, and the outcomes were calculated in terms of occurrence of fistula as percentage. Length of the fistula, we have measured the length of a fistula with a digital vernier caliper, and occurrence of glans dehiscence and any other complication that we have found urethral stricture in some patients. We have according to our study, we have enrolled 32 patients in each groups, out of which 4 patients had lost to follow-up, so we have or incomplete data, so we have excluded them from the study. Then we had 29 patients in estrogen group and 31 in control group. When we compared both the groups, the occurrence of fistula was less in the estrogen group. The severity of the fistula calculated as a percentage was less in the estrogen group, and the glans dehiscence was less in the estrogen group. But in the estrogen group, we had a significantly high number of patients with the neourethral stricture, and mean vascular density was also not significantly different in both the groups. All these less number of fistula severity and glans dehiscence, though they are less, none of them attain statistical significance. So many studies have been done with androgens to increase the penile biometry, but none of the studies and those studies with androgens have not reached any consensus regarding the post-operative complications. Estrogen acts on different phases of wound healing, and it is known that estrogen increases the vascularity by increasing the vascular endothelial growth factor. Many studies have done over that with estrogen, but we didn't find any increase in vascularity in our studies. Future research is required why estrogen causes increased wound healing and whether it is due to more collagen or reduced degradation of the collagen in that area. We have to study that because we have found more number of stricture in those patients where we have used estrogen. A significantly high number of our patients developed stricture of the neurethra, though stricture of neurethra is a known procedure when a skin-lined urethra is formed in a Bayer stage 2 procedure. To conclude, estrogen failed to increase the vascularity in proximal hypospadias penis. There was no statistical difference in the occurrence of fistula and glans dehiscence in the estrogen group compared to the control, and a significantly higher number of the patients in the estrogen group developed stricture of the neurethra compared to the control. Thank you.
Thank you. Dr. Panjwani, your comments, please.
I never use the estrogen in any pre-operative or post-operative, only truly speaking. So, and I'll not give any comment as an expert. I want to know, Dr. Akash, whether he will continue this study or he will quit this study, because what he has seen in a short-term study, there's a more number of strictures.
We have stopped the studies.
Akash.
Yes.
Yeah. Does it mean that overall wound healing in a female is much better than the male, which can involved from any age, especially in adults when they got a lot of estrogen? Does it mean that wound healing in a female who do the same surgery is much better results than the male patient?
Sir, regarding that, some studies have been done in comparing the wound healing effect in post-menopausal and pre-menopausal women, and they have found that using estrogen in post-menopausal group has increased the wound healing effect.
Okay. Second thing, you mentioned so many causes for the complication, but last you mentioned one of the causes is a learning curve. But I find that is the most important factor for the getting complication. Is that some person's experience about the technique and what technique you're using for particularly doing day and out, one particular technique you're using for one particular proper selection, that will lead to the complication, variable complication in your cases. Third thing, you have not mentioned that as we know it, the older the child, the problem that they face is the erection. And one of the drugs which was initially described, which I never practiced this, is the giving estrogen. And estrogen, not immediate post-op, but if you start much earlier before surgery, probably are supposed to have effect on the prevention of the erections. Is that really the factor which contributes, or is there really something, what you said, like increasing tissue healing by what are the different means?
Regarding increasing tissue healing, that we have not found any significant difference in the vascularity of both the groups. So in our study, we have got a negative result. Though there are some studies which have said that estrogen causes great amount of wound healing. I don't know whether our study has some flaws, like the fixed dose of 0.5 gram might not have created that much of effect in those patients.
Secondly, how do you take a consent with the parents when you say you're going to use the estrogen, the drug which normally we should not use in a male, other boys? How do you take a consent? What extension that you give to them?
Regarding that, sir, we have clearly explained them that this is an experimental study, and you are going to give it locally, not a systemic effect. So we are not going to give it systemically. So in that way, we were able to convince all the parents while taking a consent.
I think most of us will agree with what I'm trying to say. When you talk of any complications, there are 100 factors involved. The most important factor remains the surgeon, his experience, learning curve, the technique which he does day and out, masters the technique, and the proper selection of those surgical procedures. Rest, there are so many factors we can blame. You can say this is the factor related with that. That is the factor, switcher material, so use of estrogen, use of testosterone, so many dressing types. So many factors can be there responsible for the complications. But the most important remains as the proper selection of technique. One has to master the technique. And like, for example, you talked about the proximal hypospadias. That is the one area where, in spite of spending so many years, we still have got a more complication rate than the distal hypospadias. But as I said, we have to master some of these techniques to get the better results. So by none of the other techniques like using estrogen or testosterone, or by this using PDS, the Vicryl or 60 Vicryl or 70 Vicryl, that is going to much affect the results.
Our study is mainly aimed to see the wound healing effect, whether the wound healing effect is a culprit in the more number of complications in this or not. But we could not find it in that way.
But why only hypospadias? You can use any other surgeries for the wound healing. You want to use this.
Right. I think we
there are so many variables are there in hypospadias. Then why use the hypospadias?
Fine. Thank you, Dr. Akash. May we move on to the next presentation, that is by Dr. Rupa Banerjee.
I'm on the place of Rupa Banerjee, ma'am.
Yes.
Dr.
Sanghamitra is presenting, is she?
Yes, ma'am. Yes, ma'am.
Okay. Dr. Sanghamitra, please start your screen share.
Yes, I'm.
Dr. Akash, there are a few questions in the chat box. If you could take them in the chat box, please. Any troubles, Dr. Sanghamitra?
Yeah. Just give me one.
Sure.
Am I visible?
Yes, you may please start.
Good evening, respected chairperson and my colleague. I am presenting our paper on prepuce preserving surgery in hypospadias. As we sacrifice preputial covering to reconstruct urethra in hypospadias, in this study, we tried to assess whether we can preserve the preputial covering in hypospadias surgery. Now, my study period was from 2017 January to 2021 July. Out of 35 cases, all had low-grade body. In fact, 2 cases of proximal penile hypospadias was excluded from the study per-operatively as the body was found to be of high grade. Age group was 2 years to 8 years, coronal 12, distal penile 13, mid-penile 6, and proximal penile 4 cases. This is a representing case of distal penile hypospadias. You see the incision marked and made around the urethral plate and preputial wing. The preputial skin would split along the inner and outer layer for enough length to form a preputial inner and outer layer. Pre-operative assessment of the post-operative appearance. Body corrected by ventral and lateral dissection. Urethral plate was closed by tip repair with 6 cervical continuous suture. Urethral tube formed was fortified with spongiosum layer. Glans closed. Inner preputial skin repair started. Outer preputial skin layer opposed, and this repair extended down vertically to oppose the ventral penile skin. This is the, sorry, I can't show the video of the,
That's okay, it's not running. You may move on to the next slide.
Okay, this is actually, I had made this video to show how the prepuce was mobile post-surgery, like moving, the prepuce cover was mobile post-surgery. This is the representing case of mid-penile hypospadias. The incision was marked around the urethral plate and preputial wing. Operative steps same as the previous case, only here the ventral penile skin was split to midline to a certain length for adequate access for body correction. Urethral plate was closed by tip repair with cervical continuous suture. Tunica vaginalis flap was prepared. Urethral tube formed was fortified with tunica vaginalis flap. Inner preputial skin repair followed by Grant's repair. Outer preputial skin repair and repair extended down vertically to oppose the ventral penile skin. This is again a video I had taken to show the prepuce cover, but sorry, I cannot run the video. I don't know why. I'm moving on to the follow-up. This is the follow-up. Now the problem which we have faced was in mid-penile proximal penile cases, that is short skin length ventrally. This was managed, initially we tried to manage this by like bringing the dorsal preputial skin towards the ventral side, but this caused tightness of the preputial orifice. Later on, we switched to Z-plasty of the ventral skin, and this has provided with a satisfactory result. This is a representing case of proximal penile hypospadias. Again, incision around the plate and preputial wing. Incision extended vertically down, body corrected by proximal and lateral dissection. Urethral tube formed by 6 cervical continuous suture. Urethral tube fortified by tunica vaginalis wrap. Gans repair and inner preputial skin repair. Outer preputial repair and penile shaft apposition started. Z-plasty on scrotal skin, which was repaired. Post-operative appearance, and this is on follow-up. Again, this is again the video of the child passing urine, which I cannot show, sorry. Now, in results, there was scarring of ventral skin in 4 cases, were managed by application of steroid-based cream for 2 to 3 months, residual body in 1 case, tight prepuce in 5 cases, and none had fistula. So we can conclude that prepuce preserving urethroplasty can be considered as a good surgical option in any type of hypospadias, provided the circumcision is not indicated and provided body is of low grade. Advantages being cosmetic and more anatomical closure. Thank you.
Thank you, Dr. Ramilal. Your comments, please.
Thank you, Dr. Sangmitra. You presented a nice one. Prepucioplasty is my favorite, which I do. But my concern was that how do you cover the new urethra? What tissue you used? Tunica vaginalis in proximal.
Yeah, in distal penile cases, I did a tip repair, just tip repair with a corpus spongiosum covering over the tip. And in mid and proximal penile, I did a tip repair followed by a primary tunica vaginalis flap.
What about that? Do you mobilize the dartos and do dartosorrhaphy? Do you know this terminology?
No,
Ventral
actually,
dartos, if you mobilize it nicely and cover that covers the whole length. And then you can go ahead and do with the very good propusioplasty and a cover of new urethra with the ventral dartos. Third point which I wanted to make out that you had a complication of meatal stenosis. What to do with that?
not meatal stenosis. It was stenosis of the preputial orifice. If I can come back to
that one.
No, first I'll want to answer the previous case. Actually, this dartos cover was not very, I was not very comfortable with the dartos covering, particularly in the mid and proximal penile cases. So I used the tunica vaginalis. Because
no, it's not like that one. You see, the dartos is on the ventral side also. When you mobilize and when you use the intermediate layer of the propusioplasty, that is dartos. That you can cover from below, from the shaft of the penis also. So the new urethra you can cover with the dartos in whole length without sacrificing the prepuce. Rather than dorsal, you can use the ventral dartos itself as a dartos cover. Second one is that you said that preputial
preputial orifice was tight.
Then how to prevent that one? You can prevent that by doing a simple incision dorsal. Rather, you can do a dorsal Z-plasty. Yes. So if you will do that one, it is narrow, then you can do that one. That will prevent the preputial orifice narrowing. These are 3 comments. Thank you.
Dr. Mane, your comments, please.
Yeah, Doctor, nice presentation. But I do not know why were you so obsessive about presenting the preface for all the cases of hypospadias. You said for irrespective, whichever the hypospadias, we can go with the propusioplasty. I think one can do a propusioplasty only for a cis-related cases, not in all cases.
No, never.
Where you can
that is why I said I cannot do when there is a if there is a ventral skin deficiency, like gross, that is also can be managed by Z-plasty, but the most contraindication is a high chordy.
Yeah, listen
high grade chordy. Yeah.
Yes, listen to me. But you said most of your cases, you said the by lateral dissection you manage the chordy. I really don't understand what do you mean by just lateral dissection you manage the chordy.
No, Dr. Mane, I didn't mean lateral dissection. Actually, when I was I just clarify. When I am dissecting the ventral chordy, I just went a little laterally. What I meant to specify is we don't need to dissect it dorsally. That is what I meant.
Yeah, that is okay. Maybe, and I am very surprised to see one of the patient had a persistent chordy after that this surgery, which again means which again means our selection of the cases for this propusioplasty was not correct. That means in the view that you are just want to do a propusioplasty, you are doing the propusioplasty irrespective of having the high degree chordy. Person can get a persistent chordy only when we have not corrected the chordy adequately in the first stage, or you have done what is the technique of correction is not done adequately, and you are trying to just do a propusioplasty for that particular case, which means that selection of the case for that particular child was not correct.
Yeah,
otherwise there is no reason why somebody should develop a persistent chordy with a typical TIP repair with a propusioplasty.
Yeah, can I just make one comment? Yes. Actually, that case of my persistent chordy was in mid-penile case, and that was because of this short ventral skin, which I tried to manage by bringing the dorsal preputial skin, but that made me learn the message. And from the next case onwards, I went on going for a Z-plasty. And after doing Z-plasty, I didn't have...
Dr. Sangmitra, you will agree that chordy is not because of just a short of the ventral skin. There are so many factors available, have been responsible. So just by doing a Z-plasty, sometimes you have missed that other tissues, you are going to get a recursive chordy. So one has to be very careful by selecting these cases. Preferably, one should say there is no chordy, then when you do
absolutely. Oh, Dr. Mane,
There is no question
Only
of doing
one-
some degree of TIP repair
Yeah,
or doing
never,
something
never.
body
Dr.
correction
Mane,
and then we do prophylaxis. I think we don't
absolutely.
agree with
Dr. Mane, only one contraindication I thought was for this case was a severe CODY. So those even I operatively I have removed 2 cases from my study because I couldn't go for prefuse preserving because the CODY was high grade. So only if the CODY is low grade, only in those cases I can go for prefuse preserving surgery.
I will put it other way around again. The cases where there is no CODY, one can do easily a TIP repair without dorsal dissection, can easily go with a proceedings. Another factor remains the starting part of the prepuce sometime is too lateral to the glans. Sometimes, as my own patients, I have seen quite a good number of cases, we develop a so-called like a procedural fistula. There is not directly fistula with the urethra, but fistula is just at the proximal level of the prepuce. And this happens typically the starting part of the prepuce is too lateral. We try to get in the midline. That usually say opens out in the midline. The prepuce may be intact distally, but opens proximally. So all these points are very important factors for a selection.
Preputial dehiscence may be partial preputial dehiscence from above as well as from the coronal area. That is the most common site because there is a skin tension on that area.
Actually, if you have seen, I had one slide where I was always preoperatively assessing the amount of the point from where I can start the anastomosis before the surgery. So I always assess. I always try to assess from which point I will take the skin so that there is no tightness or on the preputial skin.
Right, Dr. Sangmitra, I think we are past the discussion time. Thank you. Maybe move on to the next presentation by Dr. Rashmi.
Good evening, respected teachers.
Please start your screen share.
Yes.
Yeah, it's visible now.
Yeah.
Please go ahead.
Yeah, I'm Dr. Rashmi D, resident at RML Hospital, New Delhi, and I'm presenting role of uroflowmetry in the functional evaluation of Snodgrass urethroplasty. As we know, Snodgrass's tubularized incise-based plate urethroplasty repair has simplified the treatment algorithm for distal penile hypospadias. It's a single-stage procedure and gives excellent functional results in cosmesis. But the assessment of the results of hypospadias repair remain problematic, as there exists a significant difference between the judgment of patients and the operating surgeons. So in order to eliminate this bias, uroflowmetry has emerged as an objective tool for the functional assessment. Uroflowmetry is regularly used in pediatric urology practice for screening, diagnosis, and follow-up purposes. It is well accepted, easy to perform, and non-invasive, and it is used to objectively evaluate lower urinary tract dysfunction in an outpatient setting. Here we have conducted a prospective observational study during the period of November 2019 to 2020 of all consecutive cases of Snodgrass urethroplasty at RML Hospital. A total of 29 patients were included in the study and were subjected to uroflowmetry in the preoperative and postoperative period at 6 weeks and 12 weeks, respectively. We have excluded those patients who had associated urogenital anomalies and those who underwent redo urethroplasty or UC fistula closure, and those of who had poor follow-up. The parameters that we studied included maximum flow rate, average flow rate, total voided volume, voiding time, and type of curve, and these were compared with those of post-op. We used a gravimetric uroflowmeter. Results, a total of 29 patients were enrolled in the study during the study period, and due to complications like urethrocuteneous fistula and the need for redo urethroplasty, 7 children had to be excluded from the study. All the 22 children had distal penile hypospadias, and the mean age of presentation was 6 years. Plateau-shaped curve was noticed in 10 patients at the time of presentation, indicating some amount of obstruction to voiding. However, at 12 weeks post-urethroplasty, 20 patients were noted to have a bell-shaped curve during micturition, indicating a normal voiding pattern. 2 patients maintained a plateau-shaped curve. These were the preoperative uroflowmetry curves. As you can see, they're mostly plateau-shaped. There were even patients with tower-shaped curve, and the last image is that of a bell-shaped curve. Some of our patients presented with bell-shaped curve, and most of them, after the surgery, had a bell-shaped uroflowmetry pattern. This is the uroflowmetry curves of a single patient in the preoperative period, 6 weeks postoperatively and 12 weeks postoperatively. You can see that the Qmax has progressively improved, and also the uroflowmetry curve has progressively improved to look like a bell-shaped curve at the end. Qmax at 6 weeks was decreased in 6 patients as compared with the preoperative rates by an average of 20%. But at 12 weeks postoperatively, 20 patients were noted to have an overall increase in the Qmax as compared to their baseline uroinflammatory rates. The mean increase was 23.9%, but this was not statistically significant. In 2 patients, a progressive decrease in Qmax noted at 6 weeks and 12 weeks follow-up after surgery indicated a subclinical urethral stenosis. And these patients were advised weekly urethral calibration, and the flow improved on follow-up uroflow studies performed at monthly intervals. Their uroflowmetry curves remained plateau-shaped until almost 24 weeks after surgery. These were the Qmax values of these 2 patients with subclinical urethral stricture. In terms of total voided volume, there was no clear correlation with other parameters checked. However, a voided volume of at least more than 100 ml was found essential to achieve reliable flow rates. Discussion: all the functional assessment of the hypospadias repair is possible by observation of the urinary stream. Uroflowmetry is considered to be a more objective tool, especially for the detection of a subclinical urethral stricture. A maximum urine flow rate less than 10 ml per second, low mean flow rate, plateau-shaped uroflow curve in the uroflowmetry measurements are important in the evaluation of urethral obstruction and the planning of early-stage urethral dilation. The flow pattern in a preoperative case of hypospadias is abnormal, mainly due to hypoplasia of the urethra, insufficient spongiosal cover, and meatal stenosis. The flow pattern in the postoperative period is likely to be abnormal due to glans dehiscence secondary to fibrosis of stretched gland rings or meatal stenosis. Urinary flow obstruction immediately after Snodgrass hypospadias repair may be a temporary phenomenon, and the actual clinical significance of this obstruction remains unclear. It is established that there is great potential for normalization of urinary flow at puberty for patients treated for hypospadias with tip urethroplasty. To conclude, uroflowmetry is a tool in the functional assessment of hypospadias surgery, objectively analyzing the changes in pattern and rates. This optimizes comparison of pre-op to post-op uroflowmetry rates and aids in the long-term follow-up of patients undergoing hypospadias repair. Early follow-up with uroflowmetry will aid in the early detection of complications. These are my references. Thank you.
Thank you, Dr. Rashmi. Dr. Kishore, your comments, please.
No, I absolutely agree with her that uroflowmetry is a very good tool in the post-operative management of the hypospadias, especially in the long term.
Yes.
I'll not give any more.
Sure, thank you. Dr. Mane?
Yeah, not really any comment on this, but do you consider this is the only one factor, there is a test which we should follow in our day-to-day practice to assess the result of our surgery? Or there are some other parameters like sometimes what we normally practice is like just observing the stream of the child, which asks the parents to see daily at least for next 2 to 3 months, because with the clinical presentation, the child who strains to pass urine, you can make out from his face much easier. Second is just simple like test where the sonography pre-wide and post-wide residual urine. And there is another child who might come who's not regular follow-up but comes with a repeated UTI, again indicating there is a picture like presentation. Uroflowmetry, as you have the previous paper and other papers, it is not necessary, even a pre-op also not necessarily is a normal flow. There is a because hypoplastic, sometimes urethra, sometimes the sponge is not covering that. So same thing can be seen in early post-op period, is obstructive to the pattern, and people believe that over a period that pattern can change, right? But one can easily miss some of these patients who have got really genuine some obstruction, hoping that is going to change. So I don't think I will rely totally on uroflowmetry. I will believe in 2 or 3 other factors and to assess my results of this surgery.
I agree with this.
Dr. Bhatt?
Yeah. I think this is a good study, and this is actually what we can objective or data which you can get one. And I wish that you continue with this study even for the adolescents and adult age, and with this time it improves. The number one. Number two, what I wanted to know was that what do you think that the uroflow which were poor post-operatively improved after surgery?
Yes, sir, that's exactly what I have established. They have included, the Qmax has improved after surgery, but it was not statistically significant.
What do you think the cause?
Inherent poor spongiosal cover can be.
Poor spongiosal cover is distal one. You see, once that has come out of that one, until unless there is a narrowing, that will not cause. And there are no significant or any data about this one, is that spongiosum cover will improve the flow rate. That is directly until unless there is some narrowing in that.
Yes.
What my concern was that the fallacies may be in eliciting the uroflow. You see, many a time before surgery, child may not be able to void nicely or stream, that you are not able to correct that. And once you have done a surgery and then the child is peeing in a good flow and that goes into, that may be the reason for it. So you see this part also. And another important is that, okay, you see, normal flow never always means that there is no obstruction. As Professor Mane has also pointed out, you see other parameters also. But poor flow is there, then one has to evaluate for the stricture. That's all my comment is. Thank you.
Thank you.
Thank you, Dr. Rashmi. The host, can you please confirm whether Dr. Tanveer is here to present his paper that he could not present in between, or are we done with the session? I saw Dr. Tanveer logged in between, but I can't see him now.
Right now, he is not online, but before 5 minutes, he was.
Yeah, so I think we've lost him again, so we'll give it a pass. Right, so that is the end of the session. I thank all the presenters as well as the judges. I hope the marking has been done and has been duly sent. Otherwise, that brings us to the end of this marathon urology session. I hope all of you enjoyed it, those who were with us constantly. Thank you, and the audience has been great as well. A big shout out to the eventful hosts as well. And I hope the rest of the days are as academically rich as was this evening. If any of the judges or senior members has any comments, Dr. Kishore, please.
Thank you, Virinder, for conducting a very good urology session.
Pleasure, sir. Thank you.
Thank you. Thank you, everyone. Thank you, Dr. Milan.
Thank you.
Good to see you back again.
Thank you. It was a nice session. There are a few good things which has brought, and I think more and more work has to be done. And specifically, I wanted to make a point on that estrogen study. You see, that is not only the study, but there is the way they are telling that tissue healing is better, but how much it is going to help. One has to have many multi-center trial that can prove or disapprove, so that we can come to this conclusion that there is no effect on this one. And especially if you are operating adults, and when you are using it to prevent the post-operative nocturnal tumescence, then it is a good one that you had the added advantage of that. Thank you very much.
Thank you, sir.
Very nicely done, Virendra.
Thank you. Thank you, Dr. Pat.
Thank you, Virendra. Thanks a lot.
Thank you, everyone.
Thanks to all the judges, Mane sir, Dr. Panjwani, Dr. Bhatt. Thank you for sparing so precious time. And I think we can call it a day. We will close this session. I would request hall coordinator to close this hall now and stop the streaming as well.
Thank you. Take care. Good night.
Okay, good night.
Good night, sir.
Thank you very much, everyone.
Thanks, sir.